for excellence in patient care. So let's begin this journey of learning and growth together. We shall begin this great day by prayer to the goddess of learning, Ma Saraswati, by our postgraduate student, Dr. Adi Narayan Kishore.
Shri Saraswati Namostute Varade Shri Saraswati Namostute Paradevate Shripati Gauri Pati Guru Guha Vinute Vidiyuvate Shri Saraswati Namostute Vasanatraya Vivarjita Varamunivandita Murte Vasavadya Khila Nirjita Varavitarana Bahukirte Hasayuta Mukhamburuhe Hasayuta Mukhamburuhe Arbuda Charanamburuhe Samsara Bhityapahe Sagala Mantrakshara Guhe Shri Saraswati Namostute.
I would like to call upon Dr. P.V. Ramnarayanan sir, Organizing Chairman of Iacts Techno College 2024, to address the esteemed gathering.
Good morning, ladies and gentlemen. It is a wonderful sun-shining day at KUMARAKOM. Couldn't be a better day to start the inauguration. I utilize this opportunity to invite all of you to this great day. For me, it's a very special privilege because I'm in this scene of this specialty for 45 years. I had always a Kerala base, worked elsewhere, and the changes which has happened in the Kerala scenario, especially in KOTTAYAM Medical College, developing transplant and pediatric cardiac surgery, all forms of adult surgery, is a great event for me to celebrate. And I believe I'm the oldest member in this congregation, so please give me 30 seconds to rejoice myself. I extend my hearty welcome to Dr. Manoj Duraraj, who is the President of IACTS, Dr. C.S. Hiramath, the Secretary of IACTS, the distinguished members of the Executive Committee, IACTS, the most revered faculty members, not only from cardiothoracic surgery, but from allied disciplines like cardiology, and delegates and the students who always inspired us to do all these things. And the level of application of innovation into day-to-day practice is one of the highest motto set in this particular session. And I once again invite all the participants, delegates, faculty members, other consultants, senior consultants, junior consultants, and all supporting staff, and the industry, which has been liberal in supporting us all through this. I have only one personal suggestion to make. The association, please try to influence whichever be the power governing the central government in future to establish a standard staff college for simulation training not only biological models, but non-biological models, fabricated material. I'm sure this is implemented in the United States. This will enhance the quality and confidence of the surgeons before they actually get to do a surgery of a difficult nature when they become consultant. So please enjoy yourself. Thank you very much.
Thank you, sir. Dr. Manoj Dureraj, the President of ICTS, is being a constant motivation and support in organizing this conference from the very beginning. With great pleasure, I invite Dr. Manoj Dureraj, sir, to deliver his presidential address.
Good morning, everyone. I was supposed to speak in the afternoon, so I am not mentally and physically prepared now. But I'd like to welcome you all on behalf of the Indian Association of Cardiovascular and Thoracic Surgeons, as well as KOTTAYAM Medical College organizing team, led by the chair, Dr. Ram Narayanan, a very senior stalwart, and I think blessings of such individuals who have carried us on their shoulders for so many decades are very important for us to move our field forward. Let us embrace technology today. Let us keep forward thinking. The future is already here, so I would request all the faculty delegates to impart their profound knowledge in this sharing discussion. I'd like to thank Dr. Jayakumar for organizing such a beautiful event for us. It's an academic feast which we need to enjoy in a beautiful venue. And also the other organizing teams like Dr. Praveen Verma, Dr. Shiv Nair, Dr. Nitish. I can see that they have really been working day in, day out, and especially our dear Dr. Vinita. Thanks for getting us all together here. And let's have a great day. We will meet again maybe around 4 or 4:30 when we have a short inauguration, and then we will take these things forward. Thank you. Have a great day.
Thank you, sir. As our secretary, Dr. Hiramit, will be joining us late this morning, we will be having an official inauguration in the evening. But just to kick off this day, I just request you to light the lamp. And Dr. Ramnarayan, sir, please to join him. Thank you. With the blessings of Almighty, let's proceed towards today's academic session.
Now we are moving on to the academic schedule for the day. Coronary artery disease is the bread and butter for the cardiologist as well as cardiac surgeons. But many a times it becomes an Herculean task to arrive at an accurate decision to manage a patient. The guidelines and recommendations keep on changing, and a good heart team is necessary for optimal patient care. It is crucial that we rely on the best available evidence to guide our decisions rather than relying on intuition or anecdotal experience.
Let us welcome our eminent panel of faculty to lead a discussion on evidence-based decision-making in coronary artery disease. Panelists are Dr. V.L. Jayaprakash, former professor and HOD, Cardiology, Government Medical College, Kottayam, presently Professor Cardiology, Pushpagiri Medical College, Tiruvalla, Kerala. Dr. Satyajit Bose, Senior Consultant Cardiac Surgeon and Chairman, The Mission Hospital, Durgapur. Dr. Shiv K. Nair, Senior Consultant and HOD, CVTS, Rajagiri Hospital, Kochi, Kerala. Dr. K.U. Natarajan, Clinical Professor and Head of Cardiac Electrophysiology Division, Amrita Institute of Medical Sciences, Kochi, Kerala.
This panel discussion will be moderated by Dr. Praveen K. Verma, Senior Consultant and HOD, CTVS, Amrita Institute of Medical Science, Kochi, Kerala. And case scenarios will be presented by Dr. Vinita V. Nair, Assistant Professor, CTVS, Government Medical College, Kottayam.
Good morning and welcome to all the delegates and faculty to this wonderful place. So the most common and the most debated surgery in the world is actually coronary artery bypass grafting. And there are a lot of gray zones in that, whether these patients needs medical management, whether the patients needs any kind of revascularization strategy where PCI and CABG, which can be in a competing terms. So we thought that we will highlight some of these cases. Vinitha will be presenting some of these cases and we will ask this esteemed panel what's the opinion. And once this session is, questions are over, we'll also, if the time permits, we'll have comments from the audience. So this is the kind of framework we have. So before we start our proceedings, let me welcome Dr. Jayaprakash to our midst. The association welcomes you, sir. So Dr. Jayaprakash has been instrumental in making the Department of Cardiology in Kottayam Medical College one of the most vibrant departments in this state as well as in the country. So it's a great pleasure, sir, to have you with us. Thank you, sir. So Dr. Vinitha, you can start.
The first scenario is PCI versus CABG in multivessel coronary artery disease. So our patient, first patient is a 57-year-old male who is having a type 2 diabetes on oral hypoglycemic agents and systemic hypertension. He had a history of old angioval MI, status post PTCA to LED by a drug-eluting stent in 2022, presented with recent STEMI in January 2024. Echo shows mild LV dysfunction, regional wall motion is present in inferior wall, basal IV septum and posterior wall. Syntax score is calculated to be 21 in the angio. Let us see the angio.
So, Vinitha, you can explain the findings in the angiogram. So this patient is a 57-year-old male patient, relatively young guy, diabetic, old Anderwall MI with a recent STEMI. So, so this is a very common scenario in our practice. So my first question will be to Dr. Jayaprakash. Dr. Natarajan will be joining us a little late. But Dr. Jayaprakash.
So the angio shows a disease in the mid-circ and this shows the mid-LED lesion. Yeah. And the RCA lesion was in the, after the precox area in the PDA and PLB. Sir? Yeah, so it was put in the LEDs and the proximal LED.
So there's a proximal LED stent. So, sir, so the first question is to you, sir. Is there any indication to do revascularization in this patient? That's the first question. Whether we can medically manage the patient or does the patient deserve any form of revascularization? Is old Anderwall MI and recent STEMI.
Thank you, sir. Thank you.
Yeah.
So this patient, few points I would like to highlight here. One, he has a triple vessel disease. First, second thing, that stent, I think the stent is patent. It is distal to the stent.
Yeah, it's ISR, distal ISR, yeah.
And two more things, he is a diabetic and LV is not good.
Yeah, mild LV dysfunction.
Mild LV dysfunction is also there. So, although there are the recent data saying that that revascularization versus no revascularization, there is no difference in the outcome. 2 points here are: one, the LV dysfunction. So one is the LV dysfunction group, and second is that already he had a previous stenting, and he had a recent STEMI also.
Yeah.
So we cannot equate with a stable coronary artery disease as such.
Yeah.
And on the more, he is a diabetic with LV dysfunction.
Right.
So I would like to revascularize this patient rather than going medical.
Medical management. So the next question is also to you, sir. Do we calculate the syntax score in all the cases in coronary angiogram in our practice? If so, yes. If not, why?
I think, to be frank, not in all cases. If you look at my practice, I usually, for a three-vessel disease, is an area where we come to the syntax score.
Right.
Whereas in the other two-vessel disease also, we don't look at the syntax score at all.
Yeah.
When it's a three-vessel disease, in my practice, if there is a choice between CABG and PTCA or PCI, often I go for a syntax score. Often I would say maybe 80% of the cases I would either do myself, or to be unbiased, I would be asking some other person to do the syntax.
So the answer is that most of the time you will not do the syntax score. What about you, sir? It's open to other panelists, surgeons. Do in your practice calculate syntax score, you or your cardiology colleagues? If so, yes. Why? If not, why?
In my practice, I wouldn't go for a syntax score.
Yeah.
And basically because of the fact that syntax study and all of that is at best an observational study, and it is hypothesis generating.
Yeah.
And it doesn't prove anything except for the fact that the incidences of stroke is slightly higher in the first month post CABG rather than otherwise. All these, it is not significant. So that is my take on that. I mean, people may agree to disagree, but I think that is at my best, I wouldn't like to do a syntax scoring system. The reason being this.
Yes, sir. What's your opinion about this routine measurement of syntax score in our practice?
No, I think one thing is, as surgeons, what cases we get, actually the syntax score is usually very high in any case.
Yes.
What is referred to us.
Yeah.
Second, I think that syntax 2 is better than syntax alone, because syntax is very observer dependent.
Yeah.
But the clinical aspects added to it may help us better to correlate between the severity of disease. But in my personal view, I definitely believe that anatomical severity of CAD is most important. Because for complete revascularization, which has got a great impact on outcome, the anatomical severity of CAD has much more importance than functional assessment. So but in this particular case, I think whatever may be the syntax score, if there is diabetes mellitus, surgery is the first option.
Right. Natarajan, do you do syntax score to decide the choice of revascularization? That is a question, because it's a class 1 indication by European guidelines. You know, they divide patients based on syntax score. So do we do that?
See, when you deal with diseases like left main coronary artery disease, you also would like to know the syntax score.
Right.
In non-left main disease, whether you really meticulously look for it or not, as Dr. SKN said, actually mentally you are actually doing a syntax score.
Right.
Based on the anatomical complex, not by the numbers I am talking about.
Right.
Overall, you know, we did a study, one of our postgraduates under my guidance did a study to find out whether our revascularization strategy, without meticulously doing the syntax score, is actually conforming to the syntax. It was actually conforming.
So how do you decide between PCA and CABG? Is it just a feasibility assessment, or is it a feasibility assessment and benefit assessment?
Both feasibility and benefit, but one of the limitations of the syntax score is all these are not based on contemporary PCI techniques.
Right.
Now we have lot of advancements in PCI techniques with calcium modification, intravascular lithotripsy, long drug-eluting stents, post-PCI optimization by imaging to look for adequacy of stent expansion.
Right.
So many advancements have taken. So these guidelines, etc., may not be truly applicable in today's time.
Right. So what is the consensus decision for this patient? CABG? CABG. Okay. We'll go for the next case. Vinita? You can explain the angio also when you do that.
Can I make a small comment, please?
We can have comments later, sir.
Oh.
Yeah.
Second patient is a 51-year-old male who has systemic hypertension, not a diabetic, stable angina, good LV function, status post PTCA to the ramus in 2020, which is completely occluded. Syntax score is 26.
You explained the angiogram as it runs around. Yeah.
So there is no significant left main disease.
Right.
It shows a occlusion in the sac from the mid portion, and it
Occlusion in the
circle.
Yeah.
Circle,
Yeah.
And it shows a significant LED lesion in the proximal portion as well as in the distal portion of the LED. So there is multiple disease in the LED, and the RCA is occluded. We can see the retrograde filling of the PDA.
Can you show the RCA injection?
Yes, sir. Yes, sir.
So this patient is a 51-year-old male, status PTCA to ramus, ISR grade 4, but stable angina with a good LV function, diabetes mellitus. So the first question is going to be to Dr. Natarajan. What will be the line of management in this case?
I'm sure you are asking this question with a focus on the patient having stable coronary artery disease.
Yes.
So, like what we were discussing yesterday,
Yeah.
there is no evidence in the literature to show that revascularization, particularly with percutaneous intervention, has
Right.
a survival benefit in stable ischemic coronary artery disease. Having said that, if there is involvement of the proximal LED, going back by the contemporary surgery versus medical management historical trials,
Right.
proximal LED and symptom status also is very important. Patient may be stable, but he may be having class 1, class 2 angina. TMT may be stage 1 positive.
Right.
So you have to take into account the symptom status of the patient.
So this patient, what do you think?
This particular patient, I would send him for surgery.
So you will choose on.
I will definitely revascularize
so
this
what?
patient.
What are the reasons for you to advise CABG in this patient? Can you?
There is involvement of the LED, as Dr. Vinita said.
Proximal LED.
Proximal LED. Only thing, it appears a little borderline.
Yeah.
So it's not very tight as she mentioned. So probably there may be an added evidence to look for functional importance with the FFR analysis of this particular LED.
Right. Dr. Jayaprakash, do you agree with Dr. Natarajan? Or?
Yeah, mostly, because I also thought that proximal lesion is not very tight.
Right.
It's less than 70% according to me. So
Right.
I would do an FFR in that LED.
Yeah.
And if it is less than 0.8, of course, already the patient is having a type 4 instant restenosis.
Right.
And RCA CTO.
Yeah.
I would prefer a CABG as the first choice.
First choice. So you will not advise medical management based on the current guidelines?
If that proximal LED lesion is significant, especially with the ISR, I may not be going for, and also that CTO.
Right. So I'll ask the surgeons, with this, are this data enough for you to do CABG, or do you want any more investigation in this patient?
First of all, when you talk about stable angina, I would also want to know what is actually the TMT of this patient, A.
Oh, yeah.
And B, in the angiogram, I find the right coronary artery is very dominant.
Yeah.
And that is CTO.
CTO.
And the entire left circumflex artery there is no major artery supplying that area.
Right.
And also, in addition to the proximal LED, there is another block in the mid-third and distal third junction.
Right.
So obviously, we will have to address all these points before you take a decision. But having looking at this objectively, I will go for a CABG and do arterial grafts because he is 51 years old
51
only.
years. Esken sir, what do you think?
I think CABG is an order.
No, are you happy
the
with?
ramus is also large.
Are you happy with this 70% LED? Will you be asking for some other physiological studies, or will you go for only straight away CABG?
I am a little doubtful whether we should go according to FFR in this particular patient. It may be borderline FFR, maybe 0.78, 0.82, 0.84, something there.
Yeah.
I don't think that it would change my decision very
Any
much.
any particular reason, sir?
Yeah, because FFR again, functional assessment may not be entirely accurate from the surgical point of view.
Yes.
Creating
yes.
a surgical collateral
Yeah.
is preventing further spontaneous MI occurring in these patients, which is the major cause of death or mortality in patients undergoing either a PCI or a CABG. When CABG incidence of spontaneous MI is far, far below, following CABG is far below that following PCI.
Right.
So this patient would be putting at great risk if we do that alone.
So according to you, the FFR based CABG is still an evolving concept. There are not enough data to prove that it is absolutely mandatory, isn't it, sir? Natarajan.
One more point I wanted to particularly emphasize in this case is the right coronary artery, as he said, is a super dominant right coronary artery, and it is dependent on collaterals from the left side.
Right.
So here the feeder is the left coronary artery.
Right.
So I also tend to agree with SK and sir that you should have a lower threshold to revascularize this patient, because if this LED closes,
Right.
there will be two territories at jeopardy. So here you should probably have a lower threshold to consider revascularization. I will definitely consider an FFR to make sure that the LED is not significant or insignificant.
Insignificant. We'll go for the third case, sir.
Patient 3 is a 70-year-old male with an uncontrolled type 2 diabetes and systemic hypertension, history of old CVA, effort angina, function at class 2, good LV function, syntax score is 57. Shows a significant circumflex lesion proximally.
Yeah.
Calcified and diffusely diseased LED with a retrograde PDA.
RCA, CTO.
RCA CTO, sir.
So it's a 70-year-old person, high syntax score, old CVA. So in this patient, what do you think, sir? Will you advise revascularization, or will you go for medical management?
He is symptomatic, or he is not very symptomatic because of diabetes.
Is functional class 2, uncontrolled diabetes.
So in this case, I believe that with good LV function and triple vessel disease, diffuse disease, I'd go for endarterectomy as well as CABG along with it.
So you will go for CABG rather than put the patient on medical management.
Absolutely.
Will you refer this patient, Natarajan, first to surgery?
Can you show the angiogram once again, please? This patient is a symptomatic patient.
Functional class 2.
Functional class 2.
Little high risk, old CVA.
It all depends on how effectively and completely revascularization is possible by the surgeons.
See the angio.
Yeah, there is distal LED disease. So obviously you have to do some endarterectomy for this LED. So if this patient is very symptomatic, is the proximal LED involved here? There is significant disease in the proximal LED. Fortunately, there are some good diagonal branches which can be addressed. So there is a good diagonal, at least one diagonal is pretty good. Endarterectomy, RCA, triple vessel disease. I will definitely consider surgery, provided the surgeon accepts this case.
Dr. Bose, what do you think?
What's the creatinine value of this patient?
1.3.
1.3.
Then I'll go for a CABG, but I'll do multiple endarterectomies and vein patch or whatever.
Okay.
And he's 70 years old, but we'll look at the carotids and all of that before we actually go for the surgery.
Dr. Jayaprakash, will you refer this patient for surgery?
Yeah, probably I would refer for surgery because the patient is already symptomatic, and such a disease, I think a PCI may not be able to completely revascularize this patient.
Okay.
CTO, heavily calcified, diffusely disease. So if the surgeon can do a reasonably good job in complete revascularization, definitely surgery would be the choice.
Surgery is. So, sir, you said about endarterectomy. So how common is endarterectomy in your practice, or you avoid endarterectomy? All the time.
I do go for endarterectomy even if there's the slightest doubt in my mind.
So you are very aggressive in endarterectomy.
Very aggressive in endarterectomy and even in doing multiple endarterectomies in the same patient.
Is there any data supporting evidence of endarterectomy in CABG?
Recently there is one review of the STS database for coronary endarterectomy in 2023 on 2022, in which the results are pretty good compared to the older results of endarterectomy following CABG.
Right.
So incomplete revascularization and not having a lot of hypoperfusion immediately after the operation, you are likely to get a lot of LV dysfunction, and patient may be in more difficulties in the post-operative period if you have not revascularized. Of course, the issue of late patency is to be addressed, but the first primary aim is to get a complete revascularization right away.
So that is the next question to the panel. How do you define complete revascularization?
Yeah, I think there are three types of complete revascularization. First, it's as SK has told, it's anatomical. Anatomical complete revascularization is defined as any vessel more than 1.5 with a more than 50% stenosis being revascularized with a TIMI-3 flow anatomically.
Right.
But that may not always be a correct thing, because we look at the functional revascularization also.
Okay.
In functional revascularization, so anatomically there is a complete revascularization and incomplete anatomical revascularization. Functionally there is a complete revascularization where we look at the FFR.
Yeah.
So anatomically all the lesions may not be revascularized.
Yeah.
Those lesions which are having an FFR of less than 0.8, if it is revascularized, that is said to be a functionally complete revascularization.
Yes. Dr. Bose, sir, how do you define complete revascularization?
Basically, any artery which is more than 70% blocked, and FFR is an expensive thing to make FFR coming into consideration of whether I will revascularization or not is a very, very dicey situation. And secondly is that any artery which is more than 1.5 millimeter must be grafted.
Right. So surgically the complete revascularization is a little dicey term. But one of the common accepted terminology is like the expected graft and the actual performed graft. The ratio between the actual performed graft and the expected graft you do pre-op, I mean on the angio. If it's close to 1, then you call it as a complete revascularization. So what's the guidelines say, Vinita?
Guidelines say that in patients with multivessel CAD, an assessment of CAD complexity such as syntax score may be useful, which shows 2B recommendation.
It's a 2B recommendation, syntax score.
The AHA 2021 guidelines.
Right. Then?
It's a flowchart for the management of multivessel CAD.
So multivessel CAD with anatomy suitable for PCA or CABG? No, you will go for GDMT. In ischemic cardiomyopathy, yes, it's a class 1 indication is CABG. But EF more than 50% and triple vessel disease, CABG and PCA have class 2B indication. And another controversial thing is EF 35 to 50%, CABG gets a class 2A indication. Your comments on that? Surgeon first, CABG in EF 35 to 50%, a class 2A indication. Do you think you agree with this personally?
I think this first thing is all these recommendations based on the ischemia trial itself is faulty.
Yeah.
26% of patients in that trial had CABG, 74% had PCI.
Right.
And comparing 74% with 26% of CABG, comparing it to optimal medical management and basing a recommendation based on that, I don't think is appropriate. And I think all societies, cardiac surgery societies across the world have commented on
that.
This.
Okay.
So, number two, you know, in all these trials, there is such a bias in selection also.
Right.
And especially in this trial, there was even more, very less patients have proximal LED disease, more than 50%. Now, I am knowing all of this not because of this, I had made a presentation on this.
Right.
And therefore, I am absolutely, it's really a very unfortunate
it's an unfortunate event that has happened.
What I would just like to add one thing. I think since 1994, seminal RCT analysis by Salim Yusuf, published in Lancet in 1974, clearly established the superiority of CABG over medical management.
Okay.
1 year follow-up, 5 year follow-up, 10-year follow-up.
Okay.
It was a landmark paper.
Right.
7 RCTs assessed at that time. And in that paper, they said LMCA, triple vessel disease, LV dysfunction, CABG is better.
Right.
There's no single trial which shows PCI to be superior to OMT.
Right.
So it's stable and ischemic heart disease. So this trying to prove that it is better is, I think.
Yeah, Natarajan, what do you think?
See, my take on this particular guideline will be, this is a framework to work on. Let's say somebody has multi-vessel coronary artery disease. Let's say triple vessel disease. EF is, let's say, 40%.
Yeah.
If that patient has discrete lesions in the LAD, circumflex and RCA, which can be eminently corrected by percutaneous intervention, I don't see any reason why it should not be offered to the patient. It depends on the anatomy also.
I am more interested in your comment on class 2B in PCI.
In PCI.
No, but this elevation of demotion of CABG to 2B,
yeah.
When you look at the rates of repeat revascularizations, I wouldn't agree in this situation.
No, actually what happened was mainly this ischemia trial was actually a bad thing for the PCI, but they clubbed the revascularization together, and that's why CABG was moved to 2B. But particularly I would like to have your opinion on PCI class 2B. Do you agree with this guideline in stable coronary artery disease?
I kind of agree, because there has been a huge improvement in the way we medically manage patients with stable coronary artery disease. We have a host of wonderful drugs now which were not there during the time SKN sir was telling about the historic Lancet analysis.
Right.
We have plenty of medicines now, so unless the anatomy is something like a proximal LED, stable coronary artery disease not involving the proximal left anterior descending artery, patient is asymptomatic or reasonably asymptomatic on good medical management in today's time, a patient can be comfortably treated with medications. That is why the recommendation for Revasc has been downgraded to 2B.
That is very gracious of you, I can say. Oh, sir, what do you think? Your opinion.
See, why this both the CABG and PCI was put in 2B is because of two things. One is not only with this ischemia trial which sir has told, which its own limitation. Subsequently in 2022 a meta-analysis involving 16,000 patients was published. That has also shown that in this subset of patients with stable coronary disease, there is no actual improvement in the mortality, either whatever be the revascularization strategy. Especially as Dr. Natarajan has told, we have a good armamentarium of medical management which can be done to alleviate the symptoms of the patient.
Right.
So if it is not giving a mortality benefit, then definitely it will not be a class 1 indication. That is why we had gone both for PC and CABG as a class 2, not only based on ischemia trial.
Right.
So I would suggest that because of the lack of survival benefit, class 2B indication may be acceptable.
Right.
Both for PCI as well as for CABG.
Yeah, thank you, sir.
Praveen,
so we'll move on to the next one.
Praveen, can I make one intervention?
Yeah.
No, I just want to
Go to
tell
left main.
everybody in the audience, there's one paper recently published in Annals of Thoracic Surgery.
Left
It's
main.
the Maxwell Chamberlain paper published 2023. They have, actually all these are trials. And
Yeah.
there are a lot of exclusions, there are
Yeah.
a lot of patients. So it's not a real world scenario at all. This is an analysis of more than 100,000 Medicare patients.
Right.
In the current, that means all the patients, the technology, the medical management, the PCI technology, the medical management and the CABG are all real world.
Right.
In 3-year average follow-up, PCI mortality was far higher than CABG.
Right.
So this is a real world, 100,000 patients over the recent 3 years, 2017 through 2020.
Yeah. So the answer to this is that actually medical management is actually not a very bad option in patients with a stable coronary artery disease. We should not discredit medical management. So we'll move on to the next set of this one. This one, left main coronary artery disease revascularization strategy, PCI versus CABG. That's also another hot topic.
Patient 1 is a 42-year-old male with a type 2 diabetes mellitus. HbA1c is 9%. Is having a good LV function. So the angio shows an ostial left main disease significant. No significant LED lesion.
So, isolated ostial left main disease, right side?
Right side is normal.
Right side has some disease, no? Right side is normal, okay. So, it's an isolated ostial left main disease, isn't it? Huh?
Yes,
Vinitha?
yes, yes.
So, the first question, the panel, one by one, you can answer. Jayaprakash sir, what is the appropriate revascularization strategy in this case?
Of course. Okay. It seems that there is a significant ostial LM disease, especially in that one view it is significant. That's a iliocranial view, it is significant.
Right.
Whereas in the other view, I am not very sure whether it is significant. That spider view, it was not very, very significant as it is seen as though in the. So, of course, it has been shown that in the LMCA lesions, especially ostial lesions, between 30 and 70%, our assessment by angio may not be a good thing.
Yeah.
So I would definitely go for other modes of assessing the LMCA in this patient rather than directly going for a revascularization.
Could it be catheter spasm?
Maybe we have to give NTG and C, and also I would definitely go for other investigations, either a IVUS or a FFR.
Natarajan, what do you think?
Whenever somebody does not have much of downstream disease, like for example LED is clean, RCA is clean, young patient, of course he is a diabetic. Other than the fact that he is a diabetic, he is a young man, downstream disease is not there. So as Dr. Jayaprakash rightly mentioned, this could be a spasm, it's too smooth. So you should give nitroglycerin, you have to make sure that we have made accidents. LMCA being normal and patient being referred for surgery. So it's very important, and when in doubt, now we can do imaging.
Right.
IVUS will clearly show. We have some discussions on imaging
coming up. So, sir, what do you think, sir?
No, I agree with Dr. Jayaprakash and Natarajan. This needs to be further evaluated.
Dr. Bose, what do you think?
Was there any pressure damping during the left main engagement?
Was it? Any pressure calculated? No. This is referred for CABG, isn't it? Yeah.
And there is no diregurg, so this is quite critical, and we must go for CABG in this case. Obviously, there are newer techniques coming in like OCT and all of that, and we can go in for all of that and understand.
So
there are people who are reporting.
So one of the points to you junior faculty here, or junior surgeons here, is that when you see an ostial left main disease, we have all burned our fingers doing CABG in this patient. And later on, after 3 months, all the grafts will go down because spasm induced by catheter is not uncommon. So when you have an ostial left main disease, take it with a pinch of salt. Let us say this is significant. We have done. We'll come to that. So this patient, let us say it's an ostial left main is significant. So what do you think, Natarajan? What will be your strategy? Isolated ostial left main.
Yeah. So a few things of importance in this particular patient is the fact that he's only 42.
Yeah.
He's a young person.
Right.
He's a diabetic, of course. And ostial lesions, unlike the distal left main involving the bifurcation, involving the ostia of the circumflex and the LED, is a different ball game.
Right.
Mid shaft and ostium of the left main are amenable for an angioplasty. So that too in a young patient, I would definitely, being a young patient, and if this ostial disease is significant, I will definitely consider a PCI as a reasonable strategy. And the recommendation is by the syntax score will obviously be less than 22 here. So according to European guidelines, this is class 1 indication for PCI, and by the American guidelines, it is 2A.
Okay. Dr. Jayaprakash, what is?
I also thought like that. And after imaging, if that oscillation is significant, we calculate what the minimal luminary, which is less than 6.
Yeah.
I would definitely go for a PCA because we have good data to say that in an ostial LM, it cannot be equated with the distal LM.
Right.
In an ostial LM and shaft LM, one of the recent meta-analysis, 2022, we have the pre-combat and other trials where ostial LM especially with the current imaging optimization of the OCLLM PCI, the result is as equally good as CABG. And so, because the digital LM is free, other vessels are free, I would go for a PCI in this patient if that lesion is significant.
So, left main angioplasty, is it very common or is it a difficult subset? Because in US guidelines, they say that you have to have at least, do at least 25 cases a year to do a left main angioplasty?
I fully agree with that. Left main is a very critical, doing a PCI for the left main needs experience. Not only in doing the procedure, but also in the initial assessment and doing the procedure and ensuring that it is optimally done. And in the event of a problem, etc., it should be addressed promptly. So experience is definitely important in dealing with the left main disease. That is what, but left main disease is being rampantly angioplastied in today's time.
So if this comes for surgery, my question to both of you is, will you go for one conduit only to the LAD, or will you go for two conduits, LAD and OM? If it is OM, will you consider total arterial or lima or vein?
In this case, there is a disease in the circumflex as well, which I can see here.
Yeah.
So I'll go for grafting for both the cases, but in a case-based scenario where there are no blocks in the circumflex, I would go for revascularization both the vessels and both arterial. Because if you put a vein graft on the OM, the flow will be so high, and if it is communicating with the LED, there might be a flow problem, and the lima to LED might string up.
So you will put lima to LAD and vein graft to OM?
No, rima as in Y.
Rima to Y.
I agree. I would put two arterial grafts, but I would use a radial on the circumflex because I think there is...
No, is competitive flow a concern? That's what...
I would use calcium channel blockers for a longer time, at least for 12 months in such a patient.
Right.
Where I've got any doubt regarding the competitive flow for the radial. But considering his age, I think the possibility of the vein graft getting occluded is pretty much, is quite high.
High.
And therefore I would take the chance of putting a radial. Because they're diabetic patients, I would keep the second mammary for a future use in case he gets some other progression of disease.
So if you have like a ram, let us say there is no lesion in the circumflex. You have a ramus and a distal OM. Which of this you will graft? Will you graft with a total arterial to ramus or to the distal OM? Is there any difference?
I think there are some research studies which show that the distance to the apex of whichever vessel you are trying to graft, more than 70% reaching the apex, that's the vessel to graft as a better strategy for patency in the long term.
Right.
So domination, non-LED targets, the length of the vessel towards the apex
is a critical deciding factor. Thank you, sir. We'll go to the next case.
Second patient is a 62-year-old female who is not a diabetic. Hypertension is there, good LV function. She presented with recurrent angina. So this is a distal left main, significant lesion. With an ostial RCA.
So the first question is to Dr. Jayaprakash. Sir, is there any role for medical therapy in left main coronary artery disease? Only medical therapy?
That's a highly controversial area. All of us are afraid when we see left main, and nobody takes courage to manage it medically, in fact. But if you look into the literature, of course, I'm not talking about this case, because this case is obviously a distal left main bifurcation and RCA total occlusion. Yeah. So obviously not talking on this case.
Yeah.
So studies have shown that a left main which is more than 70% cannot be equated by 50 to 70%. We take left main more than 50 as significant. But these two groups, 50 to 70%, behaves entirely differently from more than 70%. So if you ask me, is there a role for conservative management in left main? I would say there is very meager data, and actually trials are also very meager, but it has been shown that a conservative management people goes okay, provided the plaque is stable, the lesion is between 50 to 70, and with the invasive group and found that they fare equally good as the invasive group. So if you ask me, there is a role for medical management LM provided. It's a stable block. Other coronaries are normal. His LV function is good. He is not a diabetic. And it's a 50 to 70% lesion. If the IVUS is showing more than 66 meter squared MLA, probably there is a role for medical management.
Will you consider PCA in this patient, Natarajan?
In this particular case, the added problem in addition to the left main distal disease is the involvement of the ostial RCA.
Let us say the patient does not have ostial RCA.
If
only distal left main.
If the RCA was completely normal in this case, it is a distal left main, and this is not there is no complex downstream disease.
Yeah.
It's only distal left main involving the ostia of the LAD. And whatever view she showed, I thought the ostium of the circumflex also is diseased. Here, if the recommendation is a PCI can be done, the recommendation is 2A by American guidelines, provided the PCI is done as good as a surgeon will do a surgical revascularization. If I were to do this case, I will definitely do after a PCI, I will make sure that the stents are well expanded by a post-PCI imaging study. But it can be done.
Is there any benefit?
By doing PCI?
PCI, yeah. Feasibility, yes, it may be there, but benefit kind of this one.
I'll ask the question, I'll make a counter question to you.
Will
surgery benefit this patient?
Yeah.
If the surgery benefits this patient, a good angioplasty also should benefit.
Should benefit.
Because the syntax score is not very high. I'm talking about a situation where the RCA is normal.
Okay.
This left main definitely you can offer is equivalent to surgery if done properly.
We can ask the surgeons, what is your opinion about distal left main stenting, sir?
No, if it is my relative or it's me, I would choose to go for CABG.
No, what your opinion about distal left main stenting?
I think it's, even the proximal LAD has got extension of the left main disease into the proximal LAD also in this particular case.
Right.
So I don't think it's simple stenting in any case.
Yeah.
It's got its
complex stenting.
Complexities. And a CABG would be pretty simple. She's non-diabetic, young.
So this case most probably everybody will do CABG, but I wanted to stimulate discussion on distal left main stenting. So that is what
left main stenting with low syntax score, non-diabetic.
Right.
That may be a probable indication for left main stenting.
Right.
As compared to CABG. But I think the criteria of no diabetes and a very low syntax score.
So in left main stenting, you are talking about IVUS and OCT. So in all cases of isolated left main, will you do IVUS and OCT, or what is your cutoff?
In today's time, imaging is mandatory when somebody does a left main PCI. As against non-left main PCI, you may get away without doing an imaging. There is a wealth of data now to show that imaging is very vital in left main PCI. Not only for pre-procedural assessment, also for post-PCI optimization.
Right.
In borderline lesions, imaging will tell you whether intervention is necessary also. Like he said, more than 6 millimeters squared of the left main, you can conservatively manage. Less than 4 square millimeter, it has to be intervened. Between 4 and 6, you need additional functional assessment by FFR and things like that. So it also tells you whether it should be necessary. And if it is necessary, after doing the stent, you must do a pullback from both the LAD into the left main and circumflex into the left main and have excellent post-stent areas.
Yeah.
Higher the stent area, better is the outcome.
Dr. Jayaprakash?
Yeah, I do agree that if at all, the only indication for imaging, because in other scenario, imaging has not been shown to be good, whether it is OCT or IVUS. The only area where I would definitely go for an imaging after a PCI, both pre and post procedure, is left main.
Right.
And I personally think doing an F main PCI without imaging based on coronary angiogram alone is not a correct thing.
Right. So we'll just look at the guideline on left main. This is the 2021. Vinita, just point out what imaging is preferred, IVUS or OCT?
In left main, if it involves the ostium of the left main, IVUS is better than a OCT. Because OCT is injection of contrast and the imaging catheter comes out. Here you can do static imaging of the ostium. It is not a mechanical pull by. You can always stop at the ostium. So OCT is probably less ideal for ostial disease of the left main. For mid shaft and distal left main, they are kind of equivalent.
Can we go for the guideline? Yeah.
The 2021 AHA guidelines state CABG as class 1 indication for significant left main disease irrespective of whether it is a proximal or a distal left main. And this is EACTS 2022 joint consensus. The left main disease with low or intermediate syntax score is a class 1 for CABG and class 2A for PCI. And this chart is given by the EACTS as the factors which favor PCI and the factors which favor CABG.
Can you read the factors favoring CABG?
Factors favoring CABG are patients with diabetes who are contraindicated for dual antiplatelet therapy, recurrent diffuse in-stent stenosis, and prior CABG with a patent Lima LED graft. An anatomical factor, you can see that the ostial or mid-shaft lesion is said to be a factor favoring PCI as per the European guidelines, whereas distal or bifurcation lesion and presence of multi-vessel disease should go for a CABG. Of course, a high syntax score goes for a CABG.
Yeah. So basically, high syntax score, left main, and with diabetes is the indication for CABG. And prior CABG with the patent Lima LED graft, PCI is the favorable thing. So, shall we move on to the next this one?
Yes.
Is it so? Yeah.
Next scenario is revascularization in STEMI patient who is having a triple vessel disease. So first patient is 66-year-old female with type 2 diabetes, systemic hypertension and dyslipidemia, presented with acute anterior wall STEMI. The echo showed a hypokinesia of the anterior wall with moderate LV systolic dysfunction. So it's complete cutoff of LED. The patient is having circulation also and diffuse RCA lesion.
So this is a 66-year-old female with acute STEMI, isn't it? Huh?
Yes, yes.
Anterior wall hypokinesia and moderate LV dysfunction. So the first question is to Dr. Jayaprakash sir. Sir, how will you decide to go for stenting, POBA or thrombolysis in acute STEMI?
Of course, in acute STEMI, it's a different scenario because it's a real emergent situation. And all the trials, starting right from years back in 70s, and even to the latest one, it has been shown that primary angioplasty is a better choice than thrombolysis.
Right.
So I may not be going for a thrombolysis if at all possible in a STEMI situation. Only very few scenarios where STEMI is not possible, only will go for a thrombolysis. Otherwise, in general, mostly it is a primary angioplasty that's a choice in acute ST elevation myocardial infarction.
So when is POBA considered? Any POBA is considered in STEMI or?
Yeah, that is another area which needs some deliberation because POBA alone has been shown to be not as good as stenting. Right. All the trials have shown that, all the data has shown that if at all possible we should stent. So I would say if at all possible in a STEMI PCI, stenting should be the option. There are very few scenarios where we may not go for a stent. For example, a vessel is less than a 2 millimeter diameter or 2.5 millimeter diameter, we may not be very keen in stenting. And second, if the patient is having a very heavy thrombus burden and after initial preparation of the lesions, we are not able to achieve a TIMI 3 flow, probably we may defer the stenting for later. And another scenario where we may do a POBA, but if the patient is being taken for an urgent CABG, because the patient is having a multi-vessel disease and is being taken for an urgent or a very early CABG, probably I would be going for a POBA. But the data on that is not very, very solid. Even deferred stenting in a heavy thrombus burden, the data does not favor a deferred stenting.
Yeah.
And so most of the cases I would prefer a stenting. Only in very, very rare scenarios where a small vessel or when we are having only a TIMI 1 flow or such scenario, I may prefer POBA or a drug-coated balloon.
So the primary treatment is primary PCI.
Stenting, with stenting.
So is the patient presents late? What is this one? Like if it presents like within 6 hours, yes. Let us say the patient presented in 24 hours after acute MI. What will be your strategy? Not
You're talking about an ST elevation
ST elevation MI
who comes the next day.
Next day.
After 24 hours, let's say the pain has completely settled. And the patient is taken for an angiogram and we find that the infarct-related artery is totally occluded. There is no merit in doing angioplasty. In fact, it's a class 3 recommendation. Persistently occluded artery in an asymptomatic patient following ST elevation MI beyond the first 24 hours, there is no merit in opening up. In fact, it can be counterproductive. Such patients can go into an arrhythmic storm. We have even lost patients by inappropriate delayed opening of an IRA. 24 hours later, it will produce an arrhythmic storm. We can even lose the patient. It is better to treat the patient conservatively.
So the next question is also to you. If this patient had STEMI, what will be the line of management?
We're talking about the timing.
Yes. No, is this patient presented to STEMI to your department rather than STEMI? What would be the, how will you manage this patient?
See, it's very unlikely that you're asking a
hypothetical question.
Because the LED is completely
cut
off.
Hypothetical question.
Let's say this LED had a 90% lesion. And there is flow in the vessel. This patient has complex disease.
No, the patient is presenting with STEMI. Will you take the patient for PCI? Like a primary PCI. That is a question.
The timing of an angiogram in non-ST elevation myocardial infarction is as early as possible. There are enough and more data to tell us that if you do an angiogram plus minus revascularization within the first 24 hours, survival is much better. Survival not only in the immediate period, also in 6 months or 1 year, protracted survival also is much higher. Earlier you do an angiogram and revascularization in non-ST elevation ACS.
But that's not called primary PCI, isn't it?
No, primary PCI is reserved for ST
only
elevation MI.
ST elevation MI.
This is only ACS patient, non-ST elevation, early angiogram and early revascularization.
Revascularization can be both, isn't it? Both arms, depending on the anatomy.
That's depending on the anatomy, but it is not called primary PCI.
So, sir, Dr. Bose, sir.
What is the, is it a culprit lesion only doing or what are they going to do?
No. That's the next, we are coming to the next one. Yes, sir.
Non-ST elevation MI, we don't know the culprit exactly.
We have that question later. So, Dr. Bose, sir, what are the current indications for CABG in acute MI in the current setting?
In this kind of setting,
acute MI
and failed angioplasty, and if the vessel is, the vessels are very, very critical and not amenable for primary angioplasty, obviously we would go for that. Or if there is any associated MR which has developed, or if there is a VSR, certain situations we have to go, but then...
so the percentage of CABG in acute MI have really come down, Sir, this is a question which all of us have no answer. So the patient has got an RV infarct and then the patient is referred for CABG. Do you take the patient as such or do we wait? What is the current management strategy?
I think first we need to define RV infarct carefully. So if you have already defined it as RV infarct, the earlier recommendation used to be very clear cut. I remember in the 90s it was 3 months. But currently, if you have established RV infarct, I would wait 4 weeks.
4 weeks. What about you, sir? Boss, sir? Boss, sir, what do you think? RV infarct, how long will you wait?
I'll wait for at least 4 to 6 weeks and look at serial echocardiograms and see how the TAPC is, and maybe do a cardiac MRI also at the end of it to see how it is evolved.
Right. Vinudha, next case.
Next case is a 60-year-old male who had a previous STEMI anterior wall, post lysis with streptokinase in 2014. Systemic hypertension and type 2 diabetes is there and presented with acute anterior wall STEMI. Echo showed mild LV dysfunction. So this is also a total cutoff of LED with almost insignificant or 40-50% lesion in the proximal RCA.
Dr. Natarajan, So this patient is coming to you. What will be your line of management? Step by step, can you detail how you manage a patient with an acute STEMI? Because it's very important for us also, you know.
When somebody comes with ST elevation myocardial infarction, prompt revascularization is the order of the day. Particularly if the patient comes within a crucial window period, let's say 6 hours or so.
Right.
You can delay it up to 24 hours if the patient continues to have angina, electrical frequent ectopics, or LV dysfunction, patient is in advanced Killip classification, basal crepitations, etc. You can always take up to the first 24 hours. I want to make one point very clear here is, if an angioplasty cannot be done expeditiously, one should not wait endlessly for arranging the logistics of doing an angioplasty.
Right.
Because time is very, very crucial in the context of ST elevation myocardial infarction. And if there is going to be an anticipated delay, even in a cath lab enabled hospital, it is better to thrombolize the patient and do an angiogram and revascularization at the end of, let's say, 12 hours or 24 hours, because you will be still salvaging muscle. In other words, one should not delay recanalization of the artery just by harping on only doing angioplasty. If a prompt angioplasty can be done, that is superior to thrombolysis, as Dr. Jayaprakash said. When you talk about step-by-step management, the patient is seen in the casualty, early administration of loading dose of dual antiplatelet drugs, aspirin and clopidogrel or aspirin and ticagrelor. Patient is rushed to the cath lab without as delay as possible, and radial access is preferable because these patients have high bleeding tendency, and we address only the infarct related vessel as far as possible and not address culprit vessels unless it is very easy to do them.
So that is a next question to you, sir. So you have done the successful angioplasty to this one, but patient has got triple vessel disease. How will you manage the non-culprit lesions?
Yeah, that is another gray zone in cardiology, where what is the current data on non-culprit lesions. So after revascularizing the culprit lesion, for example LED, if the patient is having a RC and circ lesion, and we have to assess angiographically itself what is that, magnitude that lesion is. And if any lesion is more than 70%, that qualifies for a non-culprit vessel lesion which is to be done or not. Lot of trials has addressed this, and they had addressed with angiogram, they had addressed with FFR, IFR, IVUS, OCT, and even recently with the NIRS spectroscopy regarding the whether the non-culprit lesion to be done or not. Most of the trials except 1 or 2 has shown that the non-culprit lesions should be tackled. If the non-culprit lesion is not tackled, they had shown that the 1 month mortality, the 6 months mortality, as well as the 1 year mortality is going to be high. So the non-culprit lesion has to be tackled by revascularization. There is no doubt on that. Any lesion more than 70% after clearing of the culprit lesion has to be revascularized. The only question is the timing of revascularization. That's our only controversy. Yeah. Whether we should do it along with the primary PCA other lesions, or during the hospital stay, or 45 days, or later. That is the area where controversy is there. And now we have recent data throwing light into that. It has been shown that in a certain subset of patients, it is better to do in the same sitting non-culprit, especially after a very large scale trials which has come now. So which are the scenarios that we will do along with this? One, if the non-culprit lesions are not going to be tackled by a CABG, first of all. If you think that the non-culprit lesions, it is not amenable to PC and goes for a CABG, don't touch the non-culprit lesion. Right. Second, if the non-culprit lesion is more than 70% and the contrast load has been high during that angioplasty, we may defer it for the not on the same day we will be doing. And next sitting is that the contrast or the radiation has been high. For example, the PCA took a lot of radiation and died. In such sitting, we may not be doing it. Otherwise, if a more than 70% lesion is there in the non-culprit lesion, it is better to do it in the same sitting if it is amenable to PCA. Yet another situation is there. Very often we have a tendency, if the patient is having a cardiogenic shock, to open the non-culprit lesion. But all the trials and the current guidelines say that it's a class 3 indication. So definite scenario is that during a primary PCA, patient is in cardiogenic shock, don't touch the non-culprit lesions. Right. Otherwise, you can do the non-culprit lesions provided the lesions are not being planned for a CABG.
Thank you, sir. Can we read the guidelines, what the guidelines say?
The guidelines says that a patient who presents with STEMI less than 12 hours is an indication for primary PCI, which is a class 1 recommendation. And who presents late, the only class 1 indication for revascularization is cardiogenic shock or heart failure. Otherwise, it's a less strong indication for revascularization. And as said by the panel, it is contraindicated in totally occluded infarct after 24 hours.
So another hypothesis,
It's a non-infarct related artery.
Yeah.
So if the patient is not in cardiogenic shock, this low risk patient and low complexity, then also it's a 2B recommendation, but otherwise it's contraindicated in acute setting.
Right. So you wanted to talk something about culprit lesion, sir? That's okay. Okay. So another hypothetical question is to the surgeons. So you have loaded this patient with a ticagrelor 600 milligram. What is that? How much is that? 180 milligram or prasugrel, and you are not able to cross the lesion. He is referring you the patient for surgery. What is going to be your management strategy?
Hemodynamics?
Patient is not doing well.
IABP put?
IABP put.
I'd wait.
You'll wait.
My personal experience of doing surgery in the acute setting of STEMI without any mechanical complication are not very good.
No, what about ticagrelor?
No, all of the factors come into play in the decision-making process.
Yeah.
So if I can stabilize the patient with STEMI, with a balloon, I would like to wait.
Only one point about procedural. The landmark trial of procedural versus clopidogrel as an add-on antiplatelet drug. Procedural was only given after the anatomy was known.
Okay.
Do an angiogram, ensure that this patient is a PCI candidate and PCI is eminently possible. Only then you should give procedural. You cannot give it in the emergency room.
So what about this tirofiban? This is another dangerous thing for us. Yeah. Can you comment on this tirofiban?
Nowadays, glycoprotein antagonists like tirofiban are being less often used. It used to be used very often. With the advent of newer antiplatelet drugs like ticagrelor and procedural, etc., this tirofiban group of drugs has taken a backseat. If there is an extensive thrombus burden, we still use tirofiban when there is no flow. You open the LED opens up, there's so much of thrombus, the flow is not good, there continues to be ST elevation in the ECG, etc. You can give it as a rescue option. But these all will shut the doors for a surgical revascularization in the next 24 hours.
Is there anything that can be given to counter the effect of ticagrelor? Is anything available?
I don't think so.
Any MAB or anything? Nothing. Because I couldn't find anything. The only thing I found was if it is a desperate situation, you can use that cytosorb. Cytosorb reduces the effect of ticagrelor. Cytosorb is a thing like a cytokine absorption thing which we can use in CPB. But in desperate circumstances, it is found to be very useful, cytosorb. That's one point I wanted to mention. So we'll go to the next topic, that is revascularization in severe LV dysfunction.
Case 1 is a 45-year-old male, diabetic, hypertensive, severe LV dysfunction in echo, EFS 23%. Shows a left main lesion also, so, ostial left main lesion, and LED is CTO.
So triple vessel disease.
Triple vessel disease, yes.
So we'll start with Dr. Natarajan. Is there any role of PCI in severe LV dysfunction?
You're asking a question or you're making a statement that it is not useful?
No, what's the current, you tell the current data.
left main and severe LV dysfunction or only severe LV dysfunction?
Left main is there.
Left main is also there.
Your question was with
a patient with severe LV dysfunction, is there any role for PCI?
As we already said in the early part of this panel discussion, it depends on the anatomy. Complex disease with severe LV dysfunction, CABG is superior to percutaneous intervention. If complete revascularization can be achieved for discrete triple vessel disease in the context of severe LV dysfunction, I don't think it is inferior to the CABG. Complex disease, severe LV dysfunction, completeness of revascularization, definitely CABG is a superior option. Though the guidelines will keep PCI lower in the preference. It all depends on the anatomy.
Yes. Sir, you want to comment on PCI? Because none of the trials so far have shown that PCI is better than medical management. I think there is only one trial about PCI versus medical management in severe LV dysfunction that is published in NEJM. What is the Pegasus trial? Yeah. So that
revived.
Revival trial.
Last year,
Last
2022.
year.
That was a big setback for percutaneous interventions.
Yeah.
They compared it not against CABG, they compared it to the optimal medical
management.
management.
Optimal medical management. PCI versus optimal medical management. At the end of 1 year, there was no difference there was no survival benefit.
Revived is, what about the old stitch trial? Surgery in LV dysfunction, stitch trial, long-term results showed surgery to be better than medical management.
Yeah, but PCI, the question was PCI, is there any role for PCI?
Not in my view.
Yeah. What about you, Bosa?
In this kind of scenario, always CABG will be the best.
No, not this kind of. Is there any role for PCI in severe LV dysfunction?
Not at all, not at all.
What about you, Jayaprakash sir?
I also thought, as Dr. Nandan has thought, because the data, especially the revived data, has shown there is no difference between medical management and the PCI in a patient with a triple vessel and LV dysfunction. But of course, if that is regarding the maze, that is a total maze. Whereas if you look at the subsequent individual points, it has been, even in the revived trial, the individual secondary endpoints has been better with revascularization. So if there is a role for PCI, there is some benefit with the secondary endpoints, although the primary endpoints, there is no much difference between the PCI and LV dysfunction. So if a total revascularization can be done by PCI, there is some point in doing the PCI.
Right. So this another question is that, what are the investigations you will do? Do you routinely like to perform myocardial viability studies in patients with severe LV dysfunction? So this, if you look at this patient, the patient has got a significant left main. In this patient, will you do a myocardial viability test? And in general, will you do a myocardial viability test before severe LV dysfunction?
Definitely, I will ask for a viability assessment, particularly if the patient has already had a myocardial infarction. I don't know about the ECG of this patient. There was no mention of a previous myocardial infarction. If the thickness of all the segments in the echocardiography is well preserved, then probably there may not be a need for an additional viability option. Otherwise, definitely I will do a viability study either by a cardiac MRI or a nuclear scan.
What do you think is the gold standard for myocardial viability test? What is your preference?
Earlier it used to be the positron emission tomography. The PET scan was the gold standard. But there are increasing data to now show that cardiac MRI is a very good investigation for viability. That's what we have been routinely using in our institution also.
Right. What about you, Jayaprakash sir?
So we were not having both cardiac MR as well as a PET. And the guidelines as well as the data has shown that initially, if you want to get a better sensitivity, the radionuclide imaging may be better. But to be specific that after revascularization the patient will improve, I think dobutamine Sasako is better. So if adequate data can be got by DSC or by the radionuclide imaging, that may be the initial choice. And PET or MR can be reserved for those cases where we are not getting adequate information by the initial test.
So the question is, the patient has got significant left main disease. Will that myocardial viability testing is going to change your strategy? Because it's a significant left main. Patient has got a significant left main. So if the myocardial viability says that many areas are not viable or LED territory is not viable, but so will you?
Two things things can be assessed there. Age of the patient.
Right.
If the patient is relatively younger and the vessels, target vessels are good to be grafted. If the target vessels are good to be grafted.
So this patient is 45-year-old male.
And the target vessels were good, I said.
Good target
Good
vessels.
target vessels, younger patient, no matter what the viability shows, if there is left main involvement, there is still a merit in considering surgical revascularization.
No. Will you do a myocardial viability? That is the thing. If the patient has got a significant left main with a triple vessel disease, is there any role for myocardial viability?
It's good to prognosticate. But for deciding on the need for revascularization, viability may not be very important. But if the patient asks me, how will I do after surgery? Probably they'll give you prognostic information.
What about you, SKN sir?
I think in my personal assessment of a patient, one is the symptomatic status. Even if there's some remote angina or angina equivalent, definitely I would go for surgery right away.
Now, will you ask for a myocardial viability test?
I'd like to, for the reason of prognostication. But otherwise, in a 45-year-old man with good targets, no renal issue. For me, severe renal dysfunction, either due to diabetic nephropathy, that combination in my hands is not a good a good outcome. Severe LV dysfunction with diabetic nephropathy, 2+ proteinuria in a routine urine examination. I am extremely nervous of doing CABG in such a patient. I think for that patient.
Your opinion, sir? Will you go for myocardial viability?
Basically, in left main disease with low ejection fraction, in the papers it is written that it is not an important thing that you should go for a cardiac MRI and go and decide when is going to be a revascularization strategy. But as said by my esteemed colleagues, that it might work towards prognosticate. But I would not actually go for this thing and go for a bypass surgery right away.
So we are gradually running out of time. So I'll ask you.
Younger surgeons here, I think that looking at the ECG is very important.
Yeah.
Loss of R waves
is
a very important.
Very important. So the next question is to Dr. Bose. Is there any role for total arterial grafting in patients with severe LV dysfunction?
Severe LV dysfunction, if the heart is well preserved, I mean, if the LVDP is low, the NT-proBNP is low, and the IVC is quite good, and the patient is compensated, total arterial revascularization. But in a situation where he's going into recurrent failure, I'll just settle for a lima and vein and be safe and sound rather than,
SKN sir, what do you think?
I think I would go for 2 arterial grafts in this patient in any case.
Yeah. I asked this question because it's a very controversial thing. Because the benefit of second arterial graft occurs only in the second decade of life. So if you look at the stitch data, even if you do CABG, almost 54% of your patients are dead at the end of 10 years. So total arterial grafting is it's a little controversial. Second thing, there are a lot of scar in the myocardium. So whether the coronary flow reserve is good also is a concern. So whether the arterial graft will work is also a little bit of concern. So it's a very gray area. I just wanted to have your opinion. So this is the next question to Dr. Natarajan. AICD. When will you put the patient, this patient has EF of 23%, we have done a CABG, patient is doing well. Will you consider AICD and when will you consider an AICD for this patient?
This is a very important question. We have had some accidental cases where after a successful surgical revascularization, in the immediate follow-up period, patients have been found dead, presumably due to arrhythmic sudden cardiac death. So it's a very relevant question that you are asking. So in a patient with severe LV dysfunction who has undergone a surgical revascularization, if the ejection fraction to start with is less than 35%, and there is, if the expected improvement in the LV function is not going to be great, it is better to consider a pre-discharge ICD implantation. In contrast, there is significant viability on pre-procedural assessment. You expect the LV to improve, you should wait for 90 days.
90 days.
90 days is the cutoff, but you can restrict it to before 90 days, provided you are very sure that I have done a surgical revascularization. It is very surprising to know that I was going through the Western statistics. Nearly 50 to 75% of patients, if the pre-surgical EF is less than 35%, it continues to be very bad even after surgery.
Yeah.
I don't know whether you'll agree with me.
Right.
So one should lower the threshold to
So
consider.
we are running short of time. I will ask one important question to Dr. Jayaprakash. So briefly in 10 seconds, what is the role for goal-directed medical therapy in ischemic cardiomyopathy? Because I think that is the cornerstone for managing ischemic cardiomyopathy.
Of course, that is a cornerstone because now we have a good number of drugs which has come in the armamentarium of treating ischemic cardiomyopathy. Of course, barring revascularization, the medical guide-directed therapy include the 4 cornerstone drugs. That is, we have the one of the important drugs is SGL2 inhibitors, which has to be start first. Second, the ARNI, that is angiotensin receptor neprilysin inhibitor, sacubitril valsartan combination. Then the MRA, eplerenone or spironolactone and beta blockers. So these has to be done mandatorily in all ischemic dilated cardiomyopathies. And subsequently we can have add-on drugs like isosorbide dinitrotoluene, or we can have ivabradine, or we can have newer drugs added on like vericiguat and all. So the 4 pillar drugs are the SGL2 inhibitors and MRA, the mineralocorticoid receptor antagonists, beta blockers and ARNI. So one has to see that these 4 drugs, these are the pillars of the therapy. It has to be mandatorily be there.
So thank you, sir. For lack of time, we will conclude this session, and thank you all the panelists. We didn't have a time for any discussion on the floor, but I think we covered most of the thing. Thank you, sir.
Thank you, sir. Thank you, organizers, on behalf of the panelists. Thank you all.
Thank you, panelist and moderator, for the impressive educative session.
There are a couple of important announcements. One, there will not be a separate tea break in the morning time. Tea is served in the next hall. So in between the sessions, you can go and grab the tea and come back and hear the sessions. Second thing is, today's wet lab session is planned in the afternoon. It will be conducted after the live demonstration in this hall. So once it is finished, the wet lab session will be for the 10 to 20 students registered in the conclave hall and the other building. And third is, today we are conducting a quiz which is totally in a different way. In all of your tables, there will be answer sheet placed in the middle, and a quiz can be attempted by all of you. So it is for the consultants, all the delegates, faculty, and for the students. Students can participate in team of 2, and delegates and faculty can participate as single participants. So all of you take one paper. Students can take one paper. Be prepared with your name, your institution written, and the write whether you are a student or a consultant. And the quiz will be conducted after finishing the next panel discussion. That is before the issues in CABG, day-to-day CABG session. There will be 30 questions which will be projected onto the screen. Each question carries 15 seconds. So in 7.5 minutes, we will be completing the quiz. This is a preliminary round, and the results will be announced in the afternoon. The final quiz will be conducted on stage by 4 top scorers in the student section at 6:30 today, and a non-student participant, that is the consultant getting the highest score, will be awarded a prize. And 2 finalists will also be awarded prize from the student section. So please, all of you attempt the quiz. There is a lot of answer sheets provided in each of your tables. It will be conducted after the next panel discussion. Thank you.
So we move on to the next panel discussion. As the famous saying goes, a smooth sea never made a skilled sailor. The heart never makes it easy always, and provides hurdles to bring out the skilled cardiac surgeon in you. Now we have our best cardiac surgeons to share the experiences to overcome the unexpected challenges in coronary artery bypass grafting. We have a panel of expert surgeons across the country to share the experiences.
The panelists are Dr. Anil Tendulkar, former professor of cardiac surgery, KEM and Lokmanya Tilak Municipal General Hospital. The panelists are Dr. Anil Tendulkar, former professor of cardiac surgery, KEM and Lokmanya Tilak Municipal General Hospital, Sion, Mumbai. Dr. Jostako Periyapuram, senior consultant cardiac surgeon, Lizzie Hospital, Ernakulam, Kerala. Dr. Manoj Dureraj, president IACTS, director of Marine Cardiac Center and Research Foundation, program director, heart and lung transplant and mechanical circulatory support, Sahyadri Hospital, Pune.
The session will be moderated by Dr. Shaji Palanadan, Senior Consultant, CTVS, KIMS Health, Thiruvananthapuram, Kerala.
Good morning all. So the next panel discussion is regarding troubleshooting in CABG. At the outset I would like to thank Dr. Jayagama, Dr. Vinitha, Dr. Nitish and the excellent team for the good conduct of Techno College. And we have eminent panelists in this session. So Dr. Anil Tendulkar from Mumbai, Dr. Jose Chacko from Cochin, Dr. T.K. Jayagumar from Kottayam Medical College and Dr. Manoj Dureraj from Pune. So the topics we would be covering in this session would be diffuse coronary artery disease, intramyocardial LEDs, how to tackle RV injuries in off-pump CABG, poor conduits, small caliber vessels, and selection of suture materials and needles in difficult scenarios. So we'll start the discussion with diffuse coronaries. So my first question to Dr. Anil Tendulkar. Sir, what are the risks involved in conventional CABG in a diffusely diseased coronary vessels?
Good morning to everybody. Diffuse coronary artery disease carries the risk of incomplete revascularization that could be, and as a result of which the long-term benefits, survival benefits in the diffuse coronary artery disease are much less. And usually diffuse coronary artery disease goes with small size coronaries. So the anastomotic challenges are also more in the patient with diffuse coronary artery disease.
So to add on, what are the surgical strategies you take up to tackle such coronaries? Question to Dr. Anil Tendulkar.
Yeah, Dr. Shaji, just one more comment on diffuse coronary disease. Basically, it's a palliative disease. It's quite progressive. So what happens even after revascularization, it's very important to follow the guideline-directed medical therapy with these patients, because we have seen patients after 15-20 years coming with ischemic cardiomyopathy, end-stage heart failure. So this is a very rapidly progressive disease. I think we should be very careful on how we are dealing with it medically also. That is also important as a strategy to understand for regular follow-up of these patients.
So a question to Anil Tendulkar sir again. So what are the surgical strategies you have when you deal with some such diffusely diseased vessels?
Strategies depend upon where is the block and which vessel is involved in the block. So let us assume it's LED. So usual choices you have got, if the blocks are very close to each other, you can join the blocks and make it into one. Or second choice is to put jump grafts. So these are the basically two types of strategies you can work out. And if it's an LED and with multiple blocks in the LED, we conducted an open house discussion around the country. So the opinion of some surgeons was you can put a jump vein graft, and on that vein graft you can suture the lima, because the lima may not reach the distal LED. So in the previous discussion, there was a, I think yesterday's discussion, there was a extreme distal block. So people have done a proximal lima LED and a distal endarterectomy. So variety of things have been done. Unfortunately, or Obviously, these things you cannot do a randomized trials on that. So the basic aim is to provide more blood by combination of patches, jump grafts, distal endarterectomies with a patch. So variety of things people have done for managing diffuse coronary artery disease.
What's your take on endarterectomies in such scenarios?
Sorry?
Endarterectomies in such scenarios. If it's a very diffusely diseased vessel.
Yeah, so endarterectomy is done only if there is a problem, because in a diffuse disease, unlikely that endarterectomy will be a local endarterectomy. It's usually a very extensive endarterectomy.
So next question is to Dr. Jose Chaco, sir. Sir, in diffusely diseased coronaries, it's actually more into technical aspects. How will you plan arteriotomy? What's your preference? Like snare versus shunt? If you open and if you are not able to pass a shunt, how you proceed? Then when you need a long arteriotomy, what are the considerations you have in mind and all?
Thank you, Dr. Shaji. Now, I think this diffuse coronary artery disease is no more an uncommon thing. I don't know whether any surgeon gets coronary artery disease which is discrete. Almost 90% of the work which we do carries diffuse coronary arteries, mainly either on the right side or onto the LED. That's where the diffuse disease is most commonly happening. So I think it is very important to study the angiogram thoroughly. Like when Dr. Anil Tendurkar said that we can do tandem graft, it's very important to know whether we will get the proximal part of the disease, because a lot of times the proximal 1/3 is intramyocardial and you may find it difficult to dig it up. And even if we see in angiogram that the disease is confined to certain areas, when you palpate, when you try to do an arteriotomy, you find that the disease extends much beyond what we see in the angiogram. So it is very easy to say we can do tandem graft, but it is so difficult to execute it because of anatomical and disease distribution pattern. So studying the coronary anatomy, angiogram thoroughly, look again and again, discuss with your colleagues and make a plan much earlier than when you go to the theater. So that plan has to be in your mind. Also, when you're in theater, when you see the coronaries, if you have got any doubt, review the angiogram while you are in theater. I'm sure most of the surgeons will have angiogram visualization facilities inside the theater. If not, go out and see the angiogram again and again and make out a plan, where you have to enter to a lumen and where you do anastomosis is on the right side. Of course, if you have got two discrete diseases and you want to revascularize both proximal as well as the distal part, a tandem graft is actually what is advisable, as Dr. Anil Tendurkar said, but I would use the mammary artery itself to do a proximal anastomosis and a distal anastomosis. And sometimes when you come to the distal side, as he rightly said, we may end up in doing an endarterectomy, which may not be needed for the proximal disease. So you can have a side-to-side graft onto the proximal to the disease, and you can have an endarterectomy on the distal disease so that you will revascularize the apical side also. When you talk about endarterectomy, if you want to do an endarterectomy, I think any vessel which really merits an endarterectomy doesn't bleed. If you are going to do an endarterectomy onto a vessel which doesn't need it, it will torrentially bleed and you will have a lot of problems. Most of the time, the vessel which merit an endarterectomy are very diffusely diseased. Most of them are chronic diseases with multiple occlusions. So even if you pull out the disease from proximal side, still it may not bleed as much as we expect. So if it bleeds, that means the patient probably doesn't need an endarterectomy. And most of these endarterectomy vessels are well collateralized, that the hemodynamic stability also will be there during off-pump endarterectomy in most of the patients also. So there are two types of endarterectomies. One is a closed one and the other one is an open one. The closed one is...
I think that question...
you're going to come back again.
Come back. So our main focus is on technical aspects of selecting the arteriotomy site, how to place the shunts, and in case the long arteriotomy, what are considerations you have in mind.
Yeah, the
so
shunt...
in endarterectomy, I think we'll pass on the question to Dr. Jayakumar.
Okay.
No, just can you highlight on these aspects, sir? How do you select the site of arteriotomy? Then if you open up the arteriotomy and then you are not able to pass a shunt, what next strategy you have in mind?
So in a diffuse disease, as I said, if you have got, if you know the anatomy quite well and if you can palpate the disease, you do an arteriotomy proximal to the disease if you want, and then another tandem graft distal to the, so it's mainly by palpatory method. And also when we make a cut through the disease, like we were saying, if you're planning to do a long arteriotomy through a disease, we have to make sure that the disease is palpably soft. When you touch, you will realize whether your forward cutting or backward cutting scissors will go through the disease. If it doesn't, then you will end up in doing an endarterectomy, or then you may have to plan for a tandem grafting. Suppose if you are cutting through the disease and you are making a long arteriotomy, you have got a choice of snaring or using the shunt. But I am sure all the surgeons are familiar with the long shunts nowadays. We have got very long shunts which may be up to 3 centimeter, 4 centimeter long shunts are available. The ordinary shunts are only probably about 2 centimeters. So we should have that shunt in hand. But if you are using a 2 millimeter shunt, the proximal bulb may go into the coronary, but the distal may not go. So what I normally do is that I cut the distal bulb. I pass the proximal bulb into the proximal LED, and the cut end, which is smaller, will go through the distal part of the coronary artery, maintaining the flow, during which time you can do the anastomosis in a long arteriotomy. Have I answered that?
Yes, sir.
Okay, thank you.
And one more thing. As I know, the long shunts are available from 2 millimeter above only. So, is it like that? Or
no, you get 2, yes, you're right. 2 and 2.5.
So, why they are not making shunts, long shunts, 1.75 and 1.5? That's very, very, very useful for us. I think we should ask the companies to make shunts, long shunts which are smaller in size also, 1.5, 1.75 also, because it's in the future it will be required extensively. That's what I feel.
Especially in Indian scenario where we deal with the smaller conduits, yes.
So, in the same diffusely diseased vessel, if the aorta is also severely calcified, will your surgical strategy change?
The aorta is calcified. I think every surgeon doing coronary arteries bypass surgery should be familiar with Y technique, an aortic touch technique. There is, I think a lot of us do Y grafting. And if the aorta is not suitable for side biting or making an arteriotomy, I think whatever, either endarterectomy or not endarterectomy, we should be able to do a Y grafting whereby the total arterial revascularization can be maintained by not touching the aorta. And most of the surgeons now do it, whether it is a good aorta or bad aorta. I think there are a lot of studies showing that there's better results with non-aorta touch technique, especially with regard to the cerebrovascular accidents.
And people who are junior surgeons and who are not competent to do complex Y grafts and all, what's your take on this anastomotic devices like enclosed tube, where you can have a soft spot and do without side clamping?
I haven't personally used it, but it is being recommended. But one main problem is a cost factor. It's a disposable diaphragmatic thing. I think it costs about 20,000 odd rupees per top end, or per case. It can be used, but still, when you have got a wonderful technique of Y grafting, I don't think we should, whatever care which we take, there will be some chance of embolization if the aorta is that bad. I think for junior surgeons also doing Y graft is not a major challenge, provided they start training themselves from early days itself.
So, yes, Dr. Anil.
Dr. Veteth had described a technique.
Obturator.
Yeah, he has used
Is he here?
Yeah. Is he here?
No, I don't think so.
He has used an obturator with a slot. So the slot is for passing the needle, and the obturator is used without putting any partial clamp on the ascending aorta.
But it bleeds profusely and it's taken blindly. The bites are taken blindly. So
yesterday Sri Krishna was showing me one law that the results are best only in the hands of the person who describes it. So, right from Osaki to wet technique, people have passed technically Foley's catheter. Yeah. And before that, there is a way of thinking that this could be a calcified aorta, because most of us don't do a pre-op CT. Only if the high risk case, like patients in renal failure, diabetic patient, heavy smokers, or on X-ray you see some calcified knuckle, you do a CT of the ascending aorta. Epi-aortic probe, many hospitals have it, and if the adventitia is said to be plastered to the media rather than loose, you must suspect underlying plaque and avoid clamping that area.
So next question to Dr. Manoj.
Sorry, same question?
No, next question, yeah. Do you want to add on to that, Manoj?
Yeah. I think we all should be well versed with bilateral mammaries, pedicle grafts, so that you have in situ grafts. So you can use a right mammary to the LED, you can have the LED to the OM, and then you can go ahead with the Y graft to the PDA. So we should all have different strategies in place. Think ahead. Think the worst case scenario before you go into the theater, so that you can plan ahead. Because sometimes you have to use skeletonized mammaries. So I think all of us need to have different techniques working with us. Yeah. And the patient obviously needs to be prepared also for a porcelain aorta with strokes and all, no? So, yeah.
So I think a hybrid should also be considered. Maybe in difficult situations, if you're not competent to do Y grafts, in rare situations, if you go for a Lima LED, and then if the other vessels are revascularized by PCI, you also have the option of doing a hybrid procedure in such scenarios.
Yes.
So regarding tandem lesions, what is your take on that? Tandem lesions.
Yeah,
do you cut across the lesion or you do jump grafts?
Yeah, so depends on whether we are planning, if it's a severe LV dysfunction, depends on whether you're doing an off pump or an on pump. Most of us are off pump surgeons. So in this case, if you have tandem lesions, you're looking at a long arteriotomy. I would also have two octopus on both. So you have an octopus from the distal, which is there, and the proximal also. So you have stability throughout the lesion. So there are two options. One option is you bridge, like bridging, grafts on the mammary. I would prefer a mammary. And then you take a long mammary. You need to skeletonize the mammary so that it goes right up to the apex. You need a long length of conduit. That is number one. Two is that you start with the proximal anastomosis and do the bridging graft on the tandem lesion. If the plaque is soft, you cut across the plaque throughout. That is another option. But we have to stabilize the plaque. It's not, and the technique to use here is inside out all the time, not the outside in technique. And the sutures also have to be very strong, because if you're cutting across such a lesion, the suture pass, the needle has to be very good. So you need to have you need to have confidence on the needle, because that will damage not only the LED, but will damage the mammary also. If you're using a vein patch, it's fine, but if you're using a mammary, you need to be very sure that the needle is very good and fix the plaque. So two options. One is bridging technique with the mammary, or you can have cut across. Again, I would use an arterial patch with the same mammary patch, or a vein patch, depending upon the quality of the LED. We have to ensure that the septals are well seen, because there will be a lot of septals along the way. That has to be, the revascularization has to be perfect for that.
Does the Lima size decide on if you're putting a small Lima to a long arteriotomy? Are you happy with that?
See, the mammary, of course, if you have a small mammary, you are looking at the flow of the mammary. Ultimately, if you are not happy with the mammary quality, I would directly go for a vein graft also.
No, mammary flow is good, but size is small.
Yeah, you're talking about the caliber of the mammary. Yeah, then you can obviously use a vein patch and put the memory on that as long as the flow is good. I hope that answers your question.
Yeah, exactly. So, next question is to Dr. Jayakumar. Sir, this is the technical aspects of endarterectomy. So, how often you do endarterectomy? Do you prefer an on-pump endarterectomy on a beating heart or on-pump arrested heart, or are you comfortable doing all endarterectomy on off-pump? Whether you do it open or closed technique. After endarterectomy, how do you select the, LED? Is there any preference for a graft? Or you do lima to all cases, or in some cases you are happy with vein also? And during endarterectomy, if a plaque fractures proximally, fractures distally, how you tackle those situations? So it's an extensive question, but I think these are the things that happen in our daily life.
I feel I have to write an essay on that. So basically, endarterectomy, on pump versus off pump. I'm comfortable doing off pump endarterectomy. But everything depends upon the patient, depends upon the situation, like the patient, whether the patient is hemodynamically stable, and the anesthesia side I'm comfortable, and the collateralization part. So depending upon that, okay, I'll decide, okay, this patient is good. But if I feel that the patient is going to be unstable, or I'm not comfortable at the head end, or I feel that the collateralization is not at all good, the moment I'm going to snare it or put this thing, the patient is going to go down. Maybe a single vessel which is supplying the entire thing, I may prefer to go on pump. Okay, so based on that, we have to decide whether you are going for on pump or off pump. And then, the graft choice. So once you do the endarterectomy, always lima, LED lima is the one I always prefer. And total arterial graft, probably if it is diffuse disease, all the vessels are bad, I may not go ahead with that, lima or lima radial sort of thing. Probably if it is OM and RC is diffusely diseased and I have to do an endarterectomy, most of the time for those two, I may put a vein, unless it's a very young patient sometimes. Then
whether you go open technique or closed technique for endarterectomy?
I'll come to that. I think Joseph was about to discuss about that. I'll come to that. So then about the proximal versus the distal. Like the proximal, even if it is a proximal LED, that area I have opened, and the proximal graft is retracted, I may just leave it like that. I'm not that worried about the proximal
plaque.
Yeah, the distal one, if it is there, so I may just cut it open till I get it fully, or do an endarterectomy distally, or I may just fully open it and fix the distal end somewhere. Fix the distal end with an H0 proline. Make sure that it doesn't dissect distally any further, and then fix it and do the anastomosis. And I think Sir was about to discuss about the open versus closed, so I request Sir to continue with that.
And Dr. Jose has also a video of how he does endarterectomy on beating heart. So I'll show that also.
By the time the video comes up, people who do on pump feel that the beating heart provides you the resistance required, provides you with the resistance required for endarterectomy. So
exactly, when you do an endarterectomy, we have to really play your hands along with the beating of the heart. So
that is the advantage
if you pull against when the heart goes away, we have to really pull so that the heart itself pulls it, or allows us to do that. This is an endarterectomy which I did just yesterday, and I just kind of told one of my assistants take a picture. It came out nicely. It came up, the stuff came out till the end. I don't think it is playing properly. But generally, most of the time we can do a closed endarterectomy. I think it is getting stuck again. I think you can show the next specimen, which may give an idea about how long it was. I think it came out from the proximal quite nicely. We can see the endarterectomy specimen till the end of the coronary artery. The advantage of closed endarterectomy is that you have got smaller incision. Definitely you can put mammary into the arteriotomy. But if the specimen doesn't come out properly, definitely we have to do an open endarterectomy. The advantages of open endarterectomy is that you can identify small side branches like diagonals. When you open, you can see, and you can pull out plaques from the diagonals also, so that the diagonal flow or even septal, I think is very difficult proximally, can be preserved. That's an advantage of open endarterectomy. But if you are doing open, we definitely have to use a patch. If the arteriotomy is more than 1.5 centimeters, I will always use a patch. If it is a shorter one, less than 1 centimeter or 1.5, I will directly anastomose the lemur to the arteriotomy.
Dr. Anil?
Dr. Bhattacharya talks about a dimple on the epicardium. When you pull the plaque, and he says that's the place where the plaque is adherent. So look more for the epicardial dimples and clear off that spot. So it's a one hand unsleeving and other hand pulling. That's what sir was telling. And this synchronized with contractions of the heart. That's the art of endarterectomy.
To release that dimples, a lot of surgeons use a fine forceps. But in the past, when we were trained as juniors abroad, we used to use peanuts. On the tip of a mosquito or a Roberts, you can use a peanut, a dry peanut, and keep it on the epicardium while you are pulling, so that it will slowly get released without damage to the adventitia.
It should be done very slowly and very patiently. Don't pull hard, pull fast. It will slowly come off. That's the usual thing that happens. So if you are, if the plaque fractures distally and you need to do a long arteriotomy, how do you control the bleeding in such situations?
It doesn't bleed actually, to be honest. I was telling in the early talk also, if the endarterectomizing vessel has got diffuse disease, retrograde bleeding is not an issue. Proximally, one should not break the endarterectomy specimen. When you have a good resistance and when you are reaching a point of it breaking, we have to have a sharp cut. That's very important to have a sharp cut on the proximal part of the endarterectomy specimen so that we don't injure the septals or diagonals. Distally, there is no need of anything. I mean, obviously, as I said, we can use a long shunt, or even if you allow that endarterectomy area to bleed a little bit, doesn't matter. You can do a quick anastomosis without too much of a hassle. But if there is a lot of bleeding, you can use a long shunt, or you can snare it, or just put a loop with a 5-0, which I normally use. I don't put a snare on it, but I just put a double suture and try to control it.
And are you worried whether if you do a proximal plaque, if you remove the proximal plaque completely, will it affect will there be a competition between the graft flow and the native flow?
Oh, I don't think so. I mean, obviously it depends upon how the proximal disease is distributed. But very seldom it comes out completely unless the plaque is limited to the mid LAD, and the proximal LAD is absolutely normal. The endarterectomy specimen may come out completely, otherwise it doesn't. If you try to pull too much, probably you can occlude one of the proximal diagonals, which may not be diseased. So I don't think the surgeon should put too much of pull pressure on the proximal part of the endarterectomy specimen.
So next part to Dr. Jayakumar sir again. So after endarterectomy, what's your anticoagulation strategy? Do you anticoagulate all patients? What anticoagulant do you use? For how long you use?
Yeah, this is again a controversial point. With the arterial anastomosis, people have different opinions. For me, I think we give anticoagulation for 3 months. We give heparin full dose for 5 days, and then we continue with anticoagulants and dual antiplatelets. But I know it is not scientifically supported. I think Tendulkar sir was conducting a survey all over India with the senior surgeons, and I think sir may be in a better position to say the common consensus on that.
There is absolutely no consensus. People right from not reversing the protamine on table and continuing heparin to starting late, all sorts of strategies are used.
So what is, Dr. Manoj, what's your strategy?
Yeah, I think we should have a good anticoagulation strategy, because I have seen patients, I don't believe in endarterectomy, frankly, but if required to do, definitely on table it comes out, but not as a planned procedure. But post-operatively I've seen VTACs, I've seen the graft going down very, very badly, and then you need to revise with a vein, lot of stuff with IABP which is not required. So anticoagulation is a must, because thrombosis could happen. There could be small flecks of plaques also which sort of, migrate. I don't know what is the cause of that problem later on, but arrhythmia is a major issue later on.
Yeah, definitely perioperative MI is high in such scenarios. And also, what is your anticoagulating strategy? Means vitamin cannabis or NOAC or?
I would use NOAC.
NOAC.
At the moment, NOAC is better, because that is something which, you don't have to titrate at the moment. Glexane first, obviously, and then bridging therapy with Glexane and then NOAC.
And single antiplatelet, or?
No, NOAC and as well as aspirin.
So single antiplatelet plus NOAC?
With NOAC.
Correct.
May I suggest to ask Dr. Shivkumar Nair, because in the previous discussion he confessed that his threshold for endarterectomy is very low. So what is your anticoagulation strategy?
I anticoagulate all the patients for 6 months.
With what?
With warfarin. I don't use
But
NOAC.
how early you start heparin?
I start heparin on the same evening if there's no bleeding, once the case is over by 6 o'clock or so.
So, and what dose of heparin?
2,500 units IV 6 hourly.
6 hourly. And simultaneously?
Next day I give warfarin first dose, and once I get the INR up, I discontinue the heparin.
Warfarin with aspirin or only warfarin?
Aspirin always added, 75 milligrams.
So heparin immediate, then warfarin and aspirin, and warfarin for 6 months.
And after stopping warfarin, you change to DAPT.
To DAPT.
And what is the graft Dr. Shiv uses? You use vein grafts, or would you leave?
I don't change the strategy for grafting, as I would continue to do as I would have planned earlier. Means Lima to LED, a second arterial graft, whether it's Rima or radial, and supplementary vein grafts, whatever is required.
So if endarterectomy is required for a PD alone, would you use the same strategy, or you use DAPT alone? If the endarterectomy is for a PDA alone, and
I would use anticoagulation even if it's PD alone. I may not use anticoagulation only if there is a limited endarterectomy in an OM or a limited endarterectomy in a diagonal, in which case I would just balance out and continue only with DAPT. But otherwise, if it is a regular endarterectomy, I would proceed with anticoagulation for 6 months.
So
thank you.
Coming to a real life scenario, this is a triple vessel disease. The OM and PD are good targets. So this is the diffusely disease LED. So so how are you happy to take up this case, and what is your strategy to tackle the LED lesion? So I want opinion from all. We'll start with Dr. Jose Chaco.
Now, here are two things which we need to observe carefully in this angiogram. We can see, sorry, can we go to the previous view? We can see a septal, which is one of the very important branches of the LED, and that septal is not deeply digging into the interventricular septum. It is actually running on the anterior wall of the right ventricle for a long distance before it goes into the septum. And by doing an endarterectomy to the LED here, we are not going to perfuse the septal. So I would try to locate the septal vessel, which normally we can see as a small intramyocardial patch on the RV wall. But the RB ball is very thin. One should be very careful when you touch it, but I would rather like to graft that also without an endarterectomy. I think if you can recap the picture, you would realize that. Then definitely we will go for a LED endarterectomy after that. And whatever graft we had been discussing about it. This endarterectomy will come out quite well. I'm talking about the previous picture. I think this may be the one. Can we play this one? Can we see a septal going medially? That's a very important vessel, and that is not going to be revascularized by any method being done on the LED, either endarterectomy or not. So I would try to catch that as well and try to graft that with a lima sequential to the medial branch, which we call it septal, but it is not really septal. The way it's running, it is on the anterior wall of the right ventricle. And then bring the lima down to the LED, mid-LED. After doing an endarterectomy, we can do that. Can we see the rest of the LED through the retrograde fashion from the right or from somewhere else? I'm sure that it's
I have only these two pictures.
It's a CTO. Definitely we can see the apical part coming up somewhere there. It's actually the LED is a type 4 LED where it winds around the apex. So I think it's a very clear-cut case where we have to do an endarterectomy onto the mid-LED by a closed method and try to revascularize the medial branch if possible.
Any difference of opinion from co-panelists? Any difference of opinion, or everyone will have the same strategy?
Sorry to again refer to that national open house discussion we had. Dr. Ganesh Mani from Delhi very specifically mentioned that he may give up off pump and go on pump, and what sir said, that endarterectomy and revascularization of the septal first has to be done, and for that LED is pretty proximal, almost to the left of main pulmonary artery. So he said he will go there and ensure that the septal one, particularly one which is so prominent, is running parallel to that LED, giving you a feature, feeling that the innermost one is the septal actually. So such septals should be revascularized, irrespective whether you are on pump or off pump surgeon. Go on pump and reperfuse that part. This was only by Ganesh Mani in the entire country.
Dr. Manoj, do you think is it possible?
Yeah, I think, when you open up, actually you'll be happy to note that you might see a good LED also distally. So let's not be pessimistic. We need revascularization. You might find a good LED later on table. Also look for the diagonals around, because in case you have diagonals and that little parallel lateral wall needs to get perfused, I would suggest be aggressive with diagonals also along the way. If you might find there is a diagonal which is taken over the blood supply. So along the septal, LED, distal LED and diagonals, I think we should revascularize that anteroseptal region. Look at the LV function also because of prognostic factors. There could be scarring in the echo. Maybe you need to do an inducible ischemia test also to look at that, just to prognosticate that peri-infarct viability, so that post-operative also you can study these patients later on.
So do you find that the incidence of AF, Dr. Jagamma sir, do you want to add on? Do you find that incidence of atrial fibrillation is high after endarterectomy? Do you routinely give amiodarone for such patients?
It is not routine to give amiodarone. If the patient develops, or suppose if the patient has severe LV dysfunction also, we give amiodarone. Otherwise, this endarterectomy is not an indication for amiodarone for me. And about this case, I was thinking, of course, I fully agree with what Joe sir and said. Like, we have to revascularize the septals, we have to revascularize the LED fully after endarterectomy. That's one thing. And probably if the lima can be hitched onto the diagonal and then to the endarterectomy LED, then that would be fine. But about the septals, I have a question to the cardiology colleagues, because many people may find it really difficult to dip down and get it. Sir, what is your opinion? Can you do a hybrid procedure in such cases, or one mic.
Sir, one doubt. I'm asking about most of the time.
This is a panel discussion, so we will. If you go to the floor for, so I think, Dr. VLJ.
Thank you. I was about to ask that question. How often you do a grafting for a septal? Because I had an occasion where a primary angioplasty was done for an LED during anterior MI. A big septal getting occluded, and after 48 hours the patient getting a VSR. So how often you graft a septal? First thing. Second, regarding Sir's question, I think hybrid procedure is possible. We can have a subsequent PCI to the septal. That is what you meant. So hybrid procedure post CABG, we can go for a opening of the you mean the septal has to be revascularized.
Septal.
We can do that. Hybrid procedure is possible.
Okay, sir.
Provided the septal is having
I think we are running short of time because already it's, next important topic we have to discuss is regarding intramyocardial LEDs. So, question Dr. Manoj. So, how do you suspect intramyocardial LED in a pre-op angiogram? And what's your opinion regarding on-pump versus off-pump in a deeply situated intramyocardial LED?
So, most of the intramyocardial LEDs you can clearly see on any oblique view. It's a deep dip, then a straight, and then it just comes up. It just depends on the location, and most of them are usually straight. You don't find a tortuous course intramyocardially. So it's not that difficult to locate an intramyocardial and plan it out preoperatively through an oblique view from the angiography. So that's not a problem. Regarding off, I think I would definitely go for off pump because we are all used to that. I think we can locate the LED usually maybe with a palpation. Sometimes, you can see the dimple going in, then you see the groove in the fat.
That question is coming up.
Okay, but on pump, I would prefer to go off pump unless, you dig a bit, you find that it's getting a little risky. You start seeing the RV, muscle, and then you know that you might have to perforate. Then it's better to go on pump. Sometimes even arrest the heart because then that resistance of that RV can actually perforate. So it's better to collapse the heart, decompress the RV, put on an arrested heart and then dig around. That would be my strategy if it's very deep. So have a low threshold for going on pump and also arresting the heart. Now most of us try to do it beating heart. Of course you go ahead, but then it's a better strategy to arrest also.
So the next question is to Dr. Jose Chaco, sir. So what are the strategies you employ to identify an intramyocardial LED intraoperatively?
See, there are multiple ways of locating an intramyocardial LED. The surgeon, as I said earlier, should study the angiogram perfectly well. And he should have an idea about the diagonals. When they see the diagonal, how far away would be the LED? You have to make a picture of the LED in your mind. And that picture which you see before the surgery has to be carried onto the operating room and has to overlap that picture onto the heart with the diagonals to mentally locate the site of the intramyocardial LED. That is number one. Now, number two, there are certain indicators which we will get, like in the obtuse marginal and ramus, we have got clear indications of some brown color as if the vessel is there. But that you may probably get it in LED if it is relatively free of fat on the surface of the heart. Otherwise, it may be difficult because most of the time it may be what you see is the fat. So there is sometimes you get small lymphatic channels running on the anterior interventricular area, some white, small, worm-like structure, which are the lymphatics, epicardial lymphatics. So that probably is just above the LED most of the time. So we can go down with a knife deep into that lymphatic channels, most likely we will meet the LED. But I think I will discourage every surgeon not to go deeper than 3 or 4 millimeter into the muscle. You can go down on the fat, but if you dig down through the muscle, do not go beyond 4 millimeters. You may end up in having trouble digging into the right ventricle or not. Now, if none of these techniques can detect, we can always see the LED at the apex. We can very carefully make a small arteriotomy there and put a 1 millimeter probe through the arteriotomy proximally into the LED and probably put a finger and feel where it is. And keeping the probe there, we can probably dig where the tip of the probe is felt. The same method can be done on a diagonal. Instead of piercing the apex, the distal LED, we can actually nick onto a small diagonal and put a 1 millimeter probe with a slight bend proximally so that it will easily go into the LED. Also is another way of locating the intramyocardial LED. And I think these are the standard techniques. If the vessel is diseased, of course, we can just pass a finger on the anterior intraventricular groove. We can probably feel the plaque and probably locate the intramyocardial LED. But anyway, I wouldn't on-off pump go beyond 4 millimeter in depth. And if we can't, probably as Manoj said, go on pump and try to locate it, which may be safer in case if you injure the right ventricle.
There are epicardial lymphatics, and Dr. Bhattacharya emphasizes those lymphatics. And now he told us we have started seeing those lymphatics. So these lymphatics give you an idea about the position of the LED deep inside. More important is to go absolutely perpendicular to the epicardium for searching the LED. And it's supposed to be to the right of the vein. So that's another mark. And by chance you have a calcification, you can feel proximally the calcification and go on exposing all along from the calcification. So from proximal to distal, you can go.
Similarly, from distal to proximal also you can go.
And
also
one more technique described, just like OM, whether you are doing on pump or off pump, just like OM, lift the LV. So moment you lift the LV, the interventricular septum, there is a furrow, and that is the site of LED. These are all good in theory, on table.
And in future, I think more of ultrasound and cine angiography will be part of localizing difficult LEDs.
What about the option of using technology? Why can't you use surface ultrasound?
Yeah, that's what I was telling. It's not available in every unit right now. You need very small probes, no?
No. You can use your regular ultrasound epicardial probes.
Yeah.
Shall I make a request to all to avoid discussions, particularly those in the company area? Please, either you come here and talk or go out and talk. This is severe insult. I consider this as an insult not only to the organizers, to us also.
So
you are free. You are free to go to the lake, enjoy the boat ride. Keep your stalls in the boats.
Can I make a comment?
Yeah, sure.
Today, the anesthesiologists have their vessel locating probe for their subclavian and this thing.
Yeah.
That is now very commonly used by anesthesiologists, and that is actually useful for doing epicardial. That's on a site and other thing.
Yeah.
Off pump, when you are having the flow.
Yeah, if it is on pump and you have cardioplegised, again, you can, if you've got a hybrid theater, you can do a cine angiogram to locate the LED, if you happen to have a hybrid operating room.
And if you have an arrested heart, cardioplegia also can be given, blood cardioplegia is beautiful because that actually fills it up.
Provided it should have some flow also, no? Very tight proximal disease the flow may not be adequate also. So next question is Dr. Jayakumar. Sir, what are the technical considerations in lima LED anastomosis in a deeply situated intramyocardial LED? Like how do you avoid angulations and all?
Yeah, one thing is you are anastomosing in depth like here there, because on either side you have the two ridges of myocardium or whatever it is. So, and another thing is if you make a small trench only for the LED, then if you put a graft, it will just get angulated. So you have to go a little proximally and make sure that the lie will be very smooth. So you have to make that smooth lie. Then most of the time the intramyocardial LED will be very thin. So if you try to anastomose and if your movement is just jerky or somewhere goes, it will just cut through and then it will become a very difficult situation. So I would prefer to use a 80 6.5 mm because with a bigger needle, you will not have space for the needle to just rotate around. So here, with a smaller needle, you will have better space to rotate around. So these are the technical things I would make sure that you are doing a perfect anastomosis, because otherwise, once it starts bleeding, then it's very difficult to find out, especially in an off-pump situation.
Dr. Manoj?
When you're digging around, I mean, the first thing is to get hemostasis because you'll have a lot of veins there. So cautery around 10, just see that the field is completely dry before you get in. Other thing is I use 6O with, double running sutures and keep that on a rubber shot on both sides. Eyelid needle, I mean, that retractors are there, but it doesn't allow you to have the space. So the same 6O can be used to actually, spatulate that whole thing later on. So you tie it up on that side and this side later, so that the whole anastomosis lies open.
So, next question to Dr. Anil Tendulkar, sir. So, as described, one technical challenge is RV injury during digging up of intramyocardial LED. So, what are the precautions that we can take to avoid RV injury, RV tear, and if RV tear occurs, what are the strategies we have to repair the RV injury?
So I don't think there is any method of avoiding RV tear. It's usually a retrospective, and that too after 7-8 beats you come to know this is RV tear. But as Dr. Jose just now mentioned, that on pump surgery, avoid going more than 5 millimeter deep inside unless you are seeing the bulge of the LED. Otherwise avoid going deep. And any black blood spurting with bead should be taken as RV. Invariably we think this is a venous bleed. So first is to knowing that there could be an RV injury. And people say that it is basically done by just plugging the RV tear with the surrounding tissue. You don't have to take a plageted sutures. If at all there is a huge RV tear, you are supposed to take under the LED. So plagate on left side, plagate on right side, and under the LED supposed to pass and tie. So if at all, 1 or 2 septals could be blocked. So this is the way to, first is to always remember that spurting black blood, take it as RV. And number 2, immediately plug it with the surrounding tissue, because RV pressure in the coronaries are usually low. So don't have to bother about taking a very strong, deep bites.
Dr. Jose, sir.
Yeah, I think it's very important to avoid RV injury. Once it happens, it is going to be a difficult situation. So as we discussed earlier, be sensible when we go down the muscle to locate the LED. Sometimes in the beginning time, the junior surgeons, when they see a white color, they may think it is a LED, but you have to make sure it is a LED. It may be just a thin wall of right ventricular wall, which if you open, you may directly enter into the right ventricle. So that also we have to be careful. We have to make sure that what we see as a white structure is the coronary artery itself. And if you have got any doubt, when you make an arteriotomy, make it more towards the left side of the coronary artery. Rather than, usually we make the arteriotomy on the middle. So try to err to make an arteriotomy on the LAD, the LV side of the LAD rather than onto the middle or onto the RV side. So that, it will prevent once you, and as Anil Tendulkar said, if there is any small spurt of bleeding, we may sometimes think it is venous. And I had in my initial days, I started bussing it, thinking it is a small vein, and ended up in making the hole bigger. So if at all there is a small spurt coming, don't panic, do the anastomosis, and when you come to the right side, along with the coronary artery, take a very thin brim of the right ventricular wall. Don't pull it, but slowly, gently approximate. It may still bleed, but once you complete the anastomosis, tag the memory, and release the octopus thing, it invariably stops. But I am not very keen on putting a stitch below the LED myself, as you said. It is going to be very dangerous, and probably it will occlude the LED as well, in which case I will still close the myocardium and go to a different site to graft. That would be my strategy in case if there is a big RB wall tear.
So you use 80, 6.5?
I use 80. Unlike Jayakumar, I use a bigger needle. I use a 9.3 millimeter needle. I think it is somewhere in there, which is a beautiful product. The advantage is that you can put it as well as you can hold it nicely with a forceps. I know surgeons say that you should not be holding the needle with a forceps, but being a big needle, you can penetrate it well. As it comes out, you can easily hold with a forceps, and without any traction, you can pull it out. And big needles will help you to take a bit of muscle also along with that. The small needle is difficult to do.
I was about to ask you that whether a small plagette into inverted comma of muscle should be taken when you find a very thin-walled artery. And intramyocardial coronaries are usually thin-walled. So many people, like Joe sir said just now, that take a small bite of the surrounding muscle, which helps as a plagette and it's a good thrombogenic material also. So it helps in stopping the bleeding also.
I think Manoj has something to add.
Dr. Shaji, can I, here, this side.
Yeah.
Can I just add one question which I genuinely do not have an answer to? We were always taught that the intramyocardial LED is usually disease-free. So why do you target to go into that intramyocardial LED to graft? Number one. Number two, it's also known that the muscle on top of this coronary artery can become spasm prone, and there is possibility of calcification in this one. So why not graft distally instead of grafting into this? Or do you believe that you need to do a myotomy over the vessel to prevent this kind of angina?
I think he's talking about intramyocardial bridging, which is which by itself is symptomatic.
Yes, exactly. 2 points, 2 questions in that. One is, why are you going after an intramyocardial LED which is not diseased? Second, why? I mean, would you do a myotomy for an
electromyotomy?
So, Dr. Jagannath, just to answer that, basically we are looking at where you can't see the LED at all. If you have a distal, it's not seen at all. So the first question goes, I mean, I hope that is answered. And once you do the, exposure, your answer of the myomectomy or whatever, myotomy is also sorted out with that. My only thing is when the RV tear is there, I mean, we should use the anesthetist help to actually decompress the right ventricle as soon as possible, because they should be watchful. And off-pump anesthetist is always looking, and actually they prevent you from getting into big mess. And Dr. Lalit Kapoor, I'm not sure whether he's here, he's written a beautiful paper on why we should not be putting a blower mixture into that hole and causing air embolism, pulmonary embolism. That is also something which we need to look at. So we can put a, what do you call, anti-Trendelenburg, no, sir? Or Trendelenburg. You put the head end up, that's how we normally, to lower the PA pressures, decompress the RV, take your bites under proper, exposure, and prevent and not blow into the hole.
Use of carbon dioxide in the blower, which is officially prescribed, is very useful in such situations. Because carbon dioxide being 25 times soluble doesn't form any bubbles.
So next we'll move on to our conduit selection. So in a normal coronary artery bypass grafting, how do you select your coronary conduits? How do you select conduits for coronaries in a normal situation?
Well, it depends on the surgeon's personal priorities. Some of them go for mammary vein, which is a standard technique, and some of them go for radial, some of them go for bilateral mammary. And that actually, if the patient is younger, young age is, there is no definition for a young age. When I started doing total arterial many years ago, I was putting arterial only for patients below the age of 55. Now it has become 65 because, you don't get normally younger patients. They all go to JP or somebody else for So we don't get young patients. They say that the young patient don't go for bypass, older the patient don't go for bypass. So I don't know who goes for bypass. So anyway, younger patients definitely needs arterial graft. Then the patient's priorities there. Some patients come and tell doctor, I don't want an incision on my leg. I don't want an incision on my hand. So then you may have to choose a bilateral memory. That is on a broader perspective, but on the basis of the disease demanding a particular conduit. Definitely there is no controversy about Lima to LED. Now if you have got a disease which is kind of equivocal and you want to graft it, which conduit we use is a question which we need to address.
That's exactly what I meant.
Yeah.
A 60% OM lesion, are you happy putting a radial? I'm not talking about Y grafts.
Well, a 60% I would rather leave it alone. I mean, in case if you decide to graft a 60% disease, I would only choose a great saphenous vein if the aorta is healthy and if we can execute an aortic anastomosis. If it is equal disease, like about more than 80% in all vessels, my choice will be a mammary radial Y grafting. I used to do bilateral mammary long time ago. Now that I've changed to radial artery because I got excellent results with the radial as good as the right, and you can reduce the time, and you can probably reduce the bleeding like that. So radial is an excellent conduit, but only problem is that a lot of radials become calcified. Some of them are thick walled, some of them are having scattered specks of calcium around there. So we should take it with a pinch of salt. But generally, critical disease in all coronaries, ideal is to go for an arterial irrespective of the age if you have mammary shoot. But as we have got leading cardiologists here, nowadays 90% of the patient coming with a triple vessel disease does not have a mammary shoot. This is something which we had been seeing in the last few years. I don't know about other surgeons. Previously, whenever the cardiologist decide this goes for CABG, they always used to put a subclavian thing. Now, for all the vessels, they put PCI bar CABG. And now, almost 80% of my patients go to cath lab the day before surgery for another angiogram to find out the mammary. I think I thought of writing to my cardiology colleagues about that. So, we should have a mammary shoot and make sure the subclavian is all right before doing the Y grafting. Because I had a patient who came back with angina after total arterial many years ago to find he had a tight subclavian disease, which when he was angioplasty, the patient became normal. So there are many criterions choosing the conduits. If the aorta is okay and the disease is less, go for vein. And if it is an emergency, we don't go for a total arterial, we put a Lima and rest the vein. If the patient is on a lot of anticoagulants, of course, Y is better because we can avoid a top end, we can avoid many proximal anastomosis with reduction in bleeding.
And if the radial artery is diseased, as you said, so what is your criteria to use the radial and discard it?
Well, once we open, the assistant would say that you have palpable calcium, white plaques seen there. So then we will say that stop dissecting it, then we go to the vein. If there is no vein, no conduits, and if it is diseased, still we may use the diseased radial artery because we don't have an option, or go for a bilateral memory.
That's exactly the next question to Dr. Manoj. So if you are short of conduits, so what's the...
I think you just have to pray to God. You have to pray to God. Anyway, so we need to understand that right memory is also there, left memory is also there. If you don't have veins on the legs, you can just go up to the thigh. So I think we have to just persist and just do all the tackling on the table.
This especially happens in redo situations.
Sorry?
This especially happens in redo situations.
Redo situations. Now, as Sir said, Dr. Joe said, the assistant normally, 1 centimeter to 2 centimeters, we palpate the radial. But then don't keep the hand away immediately because you never know that you might not get a good vein also. And but the right memory usually is pretty good at that point of time. That's why I'm saying. So all of us need to tailor our approach according to the patient. We should also know that all the conduits should be available. So keep your mind open and don't freeze. Many people start freezing, ki Baba, what can I do? You don't get good inputs. Many of us don't have good assistants also. We are working with just brothers, sisters who don't, give us the inputs. So I think keep your mind open. Keep it open for all strategies when you get in. And prepare for the worst case scenario. I might not have the right radial, I might not have the left radial. Ask the anesthetist obviously to put a femoral artery and use a right radial. So, you can do permutation combinations on table.
Have you ever used a gastroepiploic?
No, I don't have any personal experience on gastroepiploic.
Any of the panelists have used it?
I know Dr. Sandeep Honekeri in Mumbai very regularly uses gastroepiploic.
To the right, to the PDA.
To PDA. So I think perhaps in Mumbai he has the highest experience. But he doesn't use it every day. As you said, only in...
So we'll ask this question to the floor actually.
Sure. Anybody from the floor who has
gastroepiploic?
assisted gastroepiploic? But indication?
I tell you, there were no veins and the sternum was small, so the lima rima would not reach the PDA. So in those situations, right gastroepiploic artery coming and revascularizing the PDA, when we were working as juniors to him, I've seen him.
Almost same. Sternum small means short stature person.
And the heart is bigger.
So that is usually the situation where Dr. Sandeep Honekeri very regularly uses gastroepiploic.
I used to at one time do lima, rima and gastroepiploic as a routine operation. But then I'm not a high volume coronary surgeon, and the main reason I stopped doing it is the time taken for getting so many grafts. But it was working well if you are using a critical right. In fact, it is very useful graft. But then the only problem is so much of time. But the beauty is...
Total arterial, if you start thinking time
it is,
I think then you better not do total arterial.
No. The thing is that
you
if you
better put only veins.
No, what I'm telling is that you take bilateral IM and do a Y, or you take a lima radial Y, is lesser time than taking this.
I think sir wants to.
Yes, sir.
See, I have a little experience using the right gastroepiploic. That was almost 1.5 decades back. When the radial artery we are not using, in the redo cases, when the patient came for redo, both long saphenous veins were taken out at the first time, and the mammary mammary artery, left mammary also, I think it anastomotic narrowing. So that's the time we used the right gastroepiploic artery. So, but most of the time these the experience is from Japan. Suma, yes, he published the long-term patency of the gastroepiploic, but after the usage of radial artery coming into use, the usage of right gastroepiploic has come down because we have to open another cavity, so that takes the time. And for all the multi-arterial grafting, particularly if you take the radial artery endoscopic harvesting, it has become so simple. I think that because instead of right mammary, particularly in diabetics and all, I think that the way we should go is using the radial artery, particularly if you take an endoscopically, because a physician assistant when he trained, he takes much faster than the surgeon, and he takes only 20 minutes. I think this is the conduit which has to be explored, but it has to be given in a critically diseased coronary artery. Thank you.
So we have two more topics. Those are two small topics. So one is regarding small caliber coronaries. Dr. Jayakumar sir. So please highlight the risks involved in small caliber vessels and what are the precautions you take during surgery.
Yeah. One thing is to deal with small caliber, especially if you are beginner, it's better to go on pump and do it, because off pump many times it may be really difficult, especially for your the initial period of your career. And then the thing is, if you look at the heel and the toe, even if your suture, the needle goes little, they say 0.5 millimeter or even less also into the vessel, that area becomes stenosis, it crumbs up. So it's very important that you take it, the arteriotomy should be proper, that is number one. You can injure the posterior wall, so you be careful with that. And second thing is the anastomosis should be through the edges, not go deep, especially at the heel, at the toe area. If you take the suture little closer, also that area will get occluded. And so here also again I take the 80 6.5 mm needle for the small caliber vessels to ensure that you are there.
Do you experience that they have more mortality and morbidity post-operatively?
No, it's like no, because ours is a training institution. Like when we give to the juniors who are just starting it, I have found that many times once you give the small coronaries, then you have intraoperative and immediate postoperative problems, and you may have to go ahead and redo it. But if you are doing a proper job with a proper vessel, definitely I think the revascularization is going to be good. Because if you look at the thing like women's small stature, diabetic, small vessels, we thought that the mortality and morbidity is high, but I think with a lot of experience of the surgical fraternity, I think we can give good results if you anticipate the problem and is done by the proper person who has enough seniority or experience rather than giving it to juniors. And if you follow the proper techniques, definitely you can do a good job. That's what I feel.
Dr. Manoj has something to add?
Most of these grafts are proximal, in the sense near the AV groove sometimes. So again, if you're doing off pump, I normally cut open the right pleura, cut it down next to the diaphragm, subluxate the heart properly in, and then go right closer to the AV groove. And the anesthetist is also very happy because the hemodynamics don't change. So comfort level, exposure and proximal grafts would be the strategy for these cases.
Joe sir?
Yeah, coming to the small coronaries, what we will find is that patients with small coronaries will have more number of coronaries. Like if you have got a huge coronary, you probably may end up in doing only 3 grafts. But if you have got small coronaries, sometimes you end up in doing 5, 6 or even more than that number of grafts. Because, obviously myocardium need multiple small vessels if it is. Like Jagamar said, we should be, but I would be rather happier to do it on off pump because small vessels are full. And putting a 11 blade onto the anterior wall and nicking it, definitely if the vessel is full, you have less chance of injuring the posterior wall. And we may definitely have to put a small shunt. Definitely use only 80 sutures. Needle selection is a priority, 6.3 or 9. I definitely use all my distal anastomosis with 9.380. And also try to do more sequential graft when you have got small vessels, so that you will have a controlled flow. If you put a big vein into a small coronary artery, you will have a flow problem. So if you have multiple small vessels, try to do sequential grafts. Even if they are very close, we can put the octopus, the one straight and the other one you can slant it so that you can easily, even 1 or 2 centimeter close vessels can be grafted in a sequential way.
Anybody uses 2 sutures?
Dr. Bashi uses 2 sutures.
Dr. Bashi uses 2 sutures.
And I think the Australian trained surgeons...
And take multiple bites rather than classical 12 bites as per the clock. You try to take more bites. So more the number of bites, less chance of pulse stringing. And one of my students who was in UK, he used to say that for small coronary arteries, the suture tightening is done while the cardioplegia is given. So ensure that just adequate approximation is done while tightening the suture. So in cardioplegically arrested, tightening may result in pulse stringing. So intentionally cardioplegia is given and tightening is done just adequate.
I have a doubt, practical doubt. Small vessel with eccentric lumen. You have eccentric lumen. How do you deal with that?
You open in the center.
Yeah, but the lumen is eccentric on the side.
But you open in the center. The secret of small vessel arteriotomy is opening the center. Many people say that 50% job is done if you open in the center.
You cut on either side and
you find the plaque is sitting there. Small vessel, plaque is there. And
so don't open at a region of plaque. Open it where there is no plaque. So you have got a case of small vessel, plaque everywhere, and
I end up getting
then
such cases.
whatever comes to your parietal lobe at that particular time.
So what he's saying is the vessel has become small because of the plaque. Then you open in the center of the soft area or the normal place. Then it's better. So you may actually be going off center, but still it would be in the center of the healthy place, which is what he wants you to say. That's fine.
So the last part of the question is, the topic is needle and suture selection. So in a small vessel, is there any advantage of using a vascular suture? Have you any experience regarding vascular fill, because that suture itself is elastic and 30% it enlarges? Have you heard of that? No. No experience?
Not really. I don't know.
Okay, so
but I use always the standard 80.
You have got experience, you can enlighten us.
No, just I have used it in rare situations because my previous surgeon had used it, and then there was some stock left behind, so I had to use it up. But I find it very useful, but it's very costly. Vascular.
Other thing, Dr. Shaji, we are always talking about needles. Also think about the proline, because what happens is if you get a batch which is bad, while you're suturing, while you're tying, the damn suture breaks. And so, I mean, I've seen batches actually changing and the suture breaking just because it is manufactured somewhere else. Same brand comes differently, and if it breaks once, don't keep blaming yourself because you're using it all the time. Ensure you change the frame, because you can't keep doing it again and again. I've actually seen that as a practical problem.
So
and robust, I don't know about Everpoint needles. I mean, have people used Everpoint needles? That's also very, very tough needle to use for these kind of, especially we have overseas patients from Middle East. Their coronaries are like hard rock. And then sometimes, you know, you need to have a good needle to go through that.
So I think the best person to answer this question would be Dr. Anil Tendulkar, so regarding suture and needle selection
So he has almost told everything. Only thing, let me just tell everyone that Everpoint is not a needle, it's a metal. It's an alloy. And in that you have got a variety of needles. So what we should really have, and I very strongly profess it, I accept that I am consultant to Johnson & Johnson, that Everpoint CC needle, what we must have in our operation theatre, one box perpetually. It is like the fire extinguisher. How many times you had a fire in your hospital? 0. But you have a fire extinguisher all the time. So according to me, Everpoint CC needle 70 should be kept. CC is calcified coronary. The tip is further sharpened, and because it's an extremely hard metal, the tip can be sharpened. Otherwise, moment you make a needle fine, it becomes a spaghetti. The whole thing is, it is 175 micron, still it is very hard. So that is what is really required.
Dr. Jose Chaco wanted to show this, some sutures and all. So, sir.
Needle priority, if you ask me, this is a suture which I use for the top end, the proximal anastomosis of great saphenous vein, or rarely if I attach the radial to the aorta. 70 is made by Centennial, and this one is 6.3. Is it 6.3? 6.3. That is the one which I think Dr. Jayakumar was referring to, small needle 80. Yeah. But my priority is the one after this, next one, 9.3 millimeter. This again is an alloy. And I would recommend this, multipass, yeah. And actually, I have to disagree with Dr. Anil Tendulkar in using this CC Everpoint needle for calcified coronaries. If the calcium doesn't, the needle cannot penetrate. If you try to use heavier needles or metals, it will definitely break. The plaque, not the needle.
No, sir.
The plaque will crack. Just believe me or not. The the calcium will crack, and you will dissect and end up in doing an endarterectomy. But if you use a fine needle, don't go through the plaque. Just take the edge of the plaque and the adventitia only.
I'm talking about where there is extremely hard.
Even if it is extremely hard, don't go through the calcium. Take only the very edge of the arteriotomy and the adventitia and do an anastomosis with a fine needle in a very heavily calcified vessel.
Let us agree to disagree.
Me a lot.
Yeah, so I think we have exceeded the time and we have covered all the topics. I thank all the
panelists. I think,
panelists.
Shaji, before you finish, shall we just add one? It's about Dr. Murali Vettet's obturator. I think that's one of the very fantastic thing about our Indian contribution. He initially made those grooves.
Yeah, I think I saw Murali somewhere here.
Is he there?
He was here sometime.
Anyway, I can talk better than
the man himself is there at the back.
So, yeah, great. So those little grooves which actually made it bleed were removed. And if you don't get his obturator, use a Hagas dilator. You can conquer almost all porcelain aorta. All you need to do is just get one proximal onto it. Then it will be absolutely fine. Your vasophil sutures, yeah, that's for the aorta, I thought. I'm not sure about the coronary, but it's, for the aorta it's very good, especially dirty aortas, which bleed. And this CV needle, which CC needle, the Everpoint which Dr. Anil Tendulkar was talking about, it never breaks a plaque. It very beautifully goes through the plaque. I don't think you need to search for any edge to use a fine needle. You can go right through the plaque and do a very robust anastomosis. It's like a fire extinguisher, but we do get occasional fires in coronary surgery.
Yeah, okay. One last comment. And also I'd like to ask Dr. Murali Vettal to come forward so that we can highlight a little bit more about the obturator.
One last question regarding small. One last question regarding small coronaries and intramyocardial LED. In cases of non-CAD myocardial bridges, like we have a type 2 LED with mid LED myocardial bridge, and the vessels are usually small. So you have to do unroofing of mid myocardial LED. So what would be the extent of de-roofing? What policy to be followed to unroof the mid LED myocardial bridge, which is around 5 mm deep, or just beyond that? Because distal part of LED is usually small size.
So who is
non-CAD myocardial bridges? Patient present, like 45-year-old male, he presented to us with anterior wall MI. He had no coronary artery disease. There was a mid LED myocardial bridge.
So I think the first option would be strict medical management with.
He presented with anterior wall MI.
Yep, with MI. Okay.
Oh, I mean, you have non-occlusive coronary artery disease. Mostly, it's medical. I mean, it's you're either having a calcium channel blocker like a Dilzem, which works beautifully.
He was not symptomatic. He presented with MI.
But at the moment, he's not having an MI. He's not having angina. Then why are we doing anything?
The myocardial bridge was significant, so his EF was 45%. So if second attack, if he...
I think we'll discuss these things over lunch because we are already running short of time and we are exceeded the time actually.
Cardiologist?
Yeah,
I think the cardiologist would be able to answer.
Yeah, both Minoka and Inoka, it is there. Myocardial infarction can occur in non-obstructive coronary artery disease, and I don't think that is an indication for a revascularization. It goes medically.
If even on medication patient is having symptoms, then you have two options. One is go for angioplasty or go for a CABG, but never use lima in such cases. Always go for a vein graft. That's the recommendation I have seen.
So, but those vessels are usually small and mid LED myocardial. Unroofing has also been described. You can do unroofing of deep myocardial bridge, and there is no need for grafting in that. So, what should be the extent of the unroofing in beating heart surgery, or you have to go arrest the heart and then do unroofing? So, in that also,
actually, this is a grey area, and it needs further discussion, and no one will have a perfect answer for that. So, I think we will stop the discussion here. I thank all the panelists. And I thank all the delegates. Thank you.
Thank you, panelists, moderator, and audience for an outstandingly excellent interactive session.
So, dear ones, next is a time for quiz. So, 2 minutes for preparations, exact 7.5 minutes for covering 30 questions. Students, please sit in groups. Consultants, please don't leave the hall. Please attend the quiz. Consultants, please write in single participants, and students as group of 2. So everybody please put your mobile phones on the top of the table, please. Mobile phones on the top of the table. We have an excellent team of supervisors supervising whether you are Googling it, the answers. Copying is not allowed. No malpractice is allowed. You will have to share your prize or you lose your prize. Our organizing secretary Jayakumar sir has offered a wonderful prize for the consultant who wins the prize, who gets the top score, and 4 student teams will be selected for the final quiz today evening, and the first and second finalists will be given prizes. So 30 questions, one question gets 15 seconds. Everybody be ready with the pen. Answer sheet is provided. Whenever you are ready, we will start. Okay, these are the rules. 30 questions, 15 seconds each. Please write the name, designation just as consultant or student. That's enough. Institute and phone number, one-word answers. No need to write explanations, just one-word answer. Questions won't be repeated. Please keep your mobile phones on table. At the end of 15 seconds, bell will ring and I will change to next slide. And please, please, no malpractice. Pen, please. Every bag has a pen inside. Pencil is okay. Highest scorer in the faculty will be announced. Okay, so I think everybody is ready. Let us start. Give a bell at 15 seconds, okay. So, ready? Starting. Question number 1. Most common arrhythmia after CABG. First PDA ligation was done in the year. This is Robert Gross who did the first PDA ligation. You have to write the year when he ligated the first PDA. Snowman appearance in chest X-ray is seen in which condition? The aortic opening at diaphragm is seen at which level? Which thoracic level? The first end-to-end coarctation repair was done in 1944 by this person. Who is this person? The first BT was performed in this hospital. Which is this hospital? Which papillary muscle is named as muscle of Lancisi? Eustachian valve is present at the opening of which venous structure? Who was the mentor of Lily Hay at the University of Minnesota? Who is this person? Which structure is related to the commissure between non-coronary and left coronary cusp of aortic valve? Which anatomical structure? The vein which accompanies LED in the anterior interventricular groove. Loop of Vuesens refer to collateral circulation between two coronary arteries. Which are those two coronary arteries? In fractional flow reserve, significant stenosis is indicated by the value of FFR less than what? Which vein carries the most deoxygenated blood in the body? Which electrolyte imbalance is implicated in the occurrence of tosa pointus? Who proposed this classification of thoracoabdominal aneurysm? What is the maximum value of Wilkins score? In Carpentier classification of mitral regurgitation, chronic rheumatic MR is included as which class? The atrial well technique of ASD closure was described by which surgeon? Modified Duke criteria is to diagnose which cardiac condition? Chamberlain classification is used in which condition? Ligamentum teres is the remnant of which fetal structure? Which is the most common cyanotic heart disease in a newborn? Cyanotic congenital heart disease in a newborn. Heath-Edwards grading is used in which condition? Masoka staging is used in which condition? Onion peel appearance in radiology is seen in which chest wall condition? In Light's criteria, pleural fluid lactate dehydrogenase to serum lactate dehydrogenase ratio more than what value indicate exudate? Rest pain is Boyd's grade what? pulseless disease in young females is called what? Last question. Which syndrome occurs in aortoiliac occlusion causing bilateral gluteal claudication and impotence? Time's up. Please collect the answer sheets. Please give all your answer sheets. Please ensure that your name is written. Shall we just go through the answers in 1 minute after collecting the questions? Yes, sir. After collection, only. No negative marking. No negative marking. ಅದನ್ನ ಒಂದೂടെ ಇಡಣೆ. Everybody have given the answer sheets? No further answer sheets will be accepted. So shall we start discussing? The quizmaster's answer is final. No discussion on answers. Most common arrhythmia is sinus tachycardia. First ligation done in the year 1938. This is in supracardiac TAPVC. This is at T12 level. This is Clarence Crawford, who did the first end-to-end coarctation repair. This is Johns Hopkins Hospital. Johns Hopkins. Okay, medial papillary muscle of tricuspid valve is termed as Lancisi. Inferior vena cava, the opening valve is called Eustachian valve. The mentor of Lilhe was Dr. Owen H. Wangenstein. Anterior mitral leaflet is related between NCC and LCC. Great cardiac vein accompanies LAD in anterior interventricular groove. Loop of Usens is formed between LAD and RCA. Fractional flow reserve value significant is less than 0.8. Coronary sinus carries the most deoxygenated blood in the body. Magnesium imbalance is implicated in tosa depointis. Specifically magnesium, sir. Crawford classification of thoracoabdominal aneurysm. Wilkins score maximum is 16. This is 3A, class 3A. Robert Gross described ASD closure by Well technique. Infective endocarditis, modified Duke's criteria. Chamberlain classification for carotid body tumor. Ligamentum teres is remnant of umbilical vein. Most common cyanotic congenital heart disease in newborn is transposition of great arteries. Heath Edwards used in pulmonary hypertension. Thymoma is staged by Masoka. On-in-peer appearance is seen in Ewing sarcoma. Value is more than 0.6. Rest pain is Boyd's grade 4. Takayasu arthritis. Lerish syndrome. Thank you very much for the overwhelming response.
Now moving on to the next session. In this session, we have assembled a diverse range of presentations that tackle the everyday issues we encounter in coronary artery bypass grafting. Our presenters will share their experience, insights, and innovative solutions to the common problems.
The chairpersons are Dr. Manoj Dureraj, President IACTS, Director of Marine Cardiac Center and Research Foundation. Dr. Varghese Sri Panikar, Professor CVTS, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Thiruvananthapuram. Dr. E.V. John, Chief Cardiac Surgeon and Managing Director, Pro Heart Cardiac Surgery. We would also like to request Dr. C.S. Hiramat to join as a chairperson. He is a Secretary of IACTS, Senior Consultant and Chief Cardiac Surgeon of Sri Satyasai Serala Memorial Hospital, Karnataka.
Good morning, all. I think we are already running late, but 10 minutes. I can see that it's a very tightly packed discussion. There's hardly any time to be wasted. I would request all the presenters to stick to at least 10 to 12 minutes so that we have some time for discussion with the audience. So I would like to invite Dr. Sajid Bose for the first presentation on aortic CABG.
Good afternoon, ladies and gentlemen, and respected chairpersons. Thank you for having me here, and what a wonderful hospitality on behalf of the organizers. So what is aortic CABG? Essentially means it's a complete surgical coronary artery revascularization, and without cardiopulmonary bypass and without manipulating the ascending aorta. So considerations of aortic CABG is that it should be increased with more survival because of use of arterial grafts, and reduced neurological injury by avoiding the aortic manipulation. And also, in an emergency situation when we combat the porcelain aorta, we should be adequately equipped to handle this and avoid putting vein grafts on the aorta. So the survival benefit of a single IMA graft has been shown by Professor Floyd Loop, and it has shown that 10 years after CABG, IMA to LED decreases risk of death, angina, revascularization, increased patency at 10 years. And after 20 years, it has also shown that the patency of a Lima to LED is also higher than any other grafts. So what are the survival? So, and we must also know that the internal mammary artery has a potential to grow. And a recent study has shown that the blood flow to the lactating human breast goes up to an average of 126 liters of blood over 24 hours, and about 70% of that flow is from the internal mammary artery. And interesting part of this discussion is that it also involutes after lactation is over. So long-term outcomes associated with total arterial revascularization, it shows that improved long-term freedom from major adverse cardiac and cerebrovascular events, death and myocardial infarction may be the procedure of choice for patients with reasonable life expectancy requiring CABG. And there are various configurations of arterial grafts. One is over there, the Lima Rima Y, this one. Can't show it there. And then we have the Lima to LED and radial artery as an eye graft, and then going behind the oblique sinus and anastomosed sequentially over various grafts. The other one is Rima crossing the midline and going to the LED, and Lima to the obtuse marginal grafts. The other one is Lima and radial Y, and Rima going into the Lima to the oblique sinus and anastomosed to the OM. And there are various other configurations also, the K grafts, which is a radial, another Y graft and going into the diagonal or ramus. And obviously, we must not forget the right gastroepiphytic artery, which can be used as a pedicle. And also in many Korean and Japanese studies, they have done it as a Y as well. So the saddest part of this is, of the entire thing, is that CABG, we need to outgrow this Lima to LED and vein graft to non-LED arteries, because for us, many of us, CABG remains a commodity item, commodity surgery, and despite having strong evidences for multiple arterial grafting. So this, in the New England Journal of Medicine, radial artery has been shown to be, when compared to the saphenous venous graft, to death, myocardial infarction and revascularization is more in saphenous veins over a 9-year period, and graft failure is less in radial artery when compared to the saphenous vein over a period of 9 years. Subsequently, another paper comes showing that saphenous venous grafts causes severe progression of native coronary artery disease. Now, this is a very important thing when we consider CABG, because there is an immense flow in the native coronary artery with the saphenous vein, causes a drop in flow in the native coronary artery. So the progression of the native coronary artery disease is very fast, and what happens is that when the vein graft clogs off, then it is very difficult to revascularize these patients. But in the case of arterial grafts, the progression of the native coronary artery disease is slow. I will show you in a series of angiograms. Strokes following surgical versus percutaneous coronary artery revascularization, this is an important thing to consider, is that following CABG, in the first 1 month, the incidences of stroke is higher. But from the second month onwards to the 5th year, the incidences of stroke is almost equal. But if you take the overall period, then the stroke following CABG is higher in cases of CABG. So also the syntax trial shows that in cases of, when you compare CABG with PCI, the only thing which is important is that death from CVA is higher in the incidence of stroke is higher in CABG, but the rate of revascularization and all that is lower in CABG. So there is another one, why early versus delayed stroke after cardiac surgery, and it was done by Mario Godino, and it shows that the main causes of increased stroke after CABG is because of aortic manipulation. Myocardial infarction, renal failure, bleeding complications, and atrial fibrillation is lesser in anaortic CABG when compared with other things like even for a heartstring device and other OPCAP methods. So anaortic CABG decreases the risk of post-operative stroke by 78% and when compared with ONCAP, and reduces the incidence of stroke by 66% when compared with partial occlusion clamping in OPCAP, and 52% when we use the heartstring device. So the guidelines, ESCAT's guidelines in 2018 gives a 1B, is that we must identify surgeons who has got that potential talent and interest in advanced coronary surgery. First, they should be doing bilateral mammary, lima and radial artery, then go to bilateral lima and rima, then go for Y, and then go to composite arterial grafting and doing many other things by total arterial, like doing endarterectomy, and still be able to do coronary artery, lima, rima, Y and aortic CABG. And then taking it forwards and doing it in a smaller incisions also. So I would like to share how I do this thing. Initially we take down the lima as skeletonized. Now, doing bilateral mammary artery in a skeletonized manner, it reduces the incidences of deep sternal wound infection. So this is the rima harvest. We must go right up to the top, and we must not dissect the lima or the rima beyond the bifurcation. This is how I do the Y. And it is very important to know at which level you should do the Y so that the rima reaches right up to the PDA. Because if it is 1 centimeter above or below, then it will not reach, and cannot do multiple arterial grafting with lima, rima, Y. So I make a longitudinal incision in the lima and then do an oblique incision thing. If the ramus has to be grafted, I would go for a T rather than a Y. This is the lima to LED. I take a deep pericardial stay between the phrenic nerve and the IVC. And if I have to do the ramus, I would also take another stitch close to the upper edge. So again, we need to pull that rima a bit more so that when we place the heart back, it will be the ideal length. So this is the PDA, the rima taken to the PDA, shunt has gone in. And in all cases, we do a deep pericardial window. So this is the completed lima to LED, and the rima going to the OM, and then going to the PDA. So, oh no. This is another case. So I'll show you exactly how we take the lima. First, we cut the endothoracic fascia, and the rest of the lima then just comes down like this. Hardly takes 10-20 minutes, 10 minutes or 15 minutes. So the lima coming down, and an incision on the lima. The same technique. Here you see that we are almost doing a T because we have to graft a high up OM. And you see a good flow in the rima. So this is the first graft to the diagonal. The heel goes into the kind of 1 o'clock position. One more minute here. So the lima going to the LED after doing a sequential to the diagonal. How do we kind of accelerate this? Okay. I'm going to the next slide, in which I will show you so this is a case on whom I done a lima Y with a ostial left main, and this is an angiogram done in 2009, in which you show that we can see that the lima and with the native arteries are still kind of some blood is flowing. And then we took the graft angios. It's not going forward. Have you blocked the slides? It's not going ahead? Yeah. So we can see that the grafts are still flowing. The lima going to the LED and the rima going to the ramus and OM. But there is some competition of flow, but still the grafts are flowing. But what is more important, I want to show you. So this is an angio done after 24 years. 22 years. Patient is still doing. So native circulation has become 0. So same patient. So when we do a graft angio, you see that the lima and rima has actually grown. And the patient is virtually living on that graft only, lima to LED and the ramus and it's a left dominant circulation. Patient is virtually living on the grafts alone. So because we have done a total arterial revascularization, the progression of the native disease has been slow and the patient is still living in 2022 as well. Well, thank you very much.
Thank you, sir, for the wonderful presentation. And we have 2-3 doubts for the audience. Aortic CABG is your first choice, even if the aorta is normal. Is it true? Is it correct?
For me, for the initial period of my life, I've been doing this aortic CABG from 1998 onwards. Ever since I got trained by my mentor who was only doing that. So that was the procedure of choice irrespective of any case, of the kind of disease or whatever. But of late, after having looked at various angiograms, post-operative and all that, I have started reserving this total arterial grafting for coronary artery natives with only more than 80% or 70 to 80% stenosis.
Okay. Is there any difference if the patient is diabetic?
Because initially when we were doing pedicle lima and pedicle rima, what used to happen, there used to be about say 5 to 7, maybe 8% cases having deep sternal wound infection, and I've lost patients because of that also. But certain things after 2000, I think 11 or 12, once I heard an American, Dr. Subramaniam, talking about skeletonized mammary, and I asked him, how do you take down skeletonized? I don't know. He just said one thing, that you just cut this, with the scissors, you cut the endothoracic fascia, and the mammary just drops down. I just came back home and did it, and it started working. And thereafter, the incidences of deep sternal wound infection has really, really diminished. I mean, don't see any of them at all, unless, of course, it is very, very uncontrolled, this thing, or and the person who has done the sternotomy, most of the time I'm not doing the sternotomy, he has not done in the middle, it is on one side, then, the problems start happening. Then we have to give the Robichek ways of closing the sternum. That's I think the best way to do it.
Have you come across any experience that if aorta is bad and the internal mammary flow is not that good, how will you tackle that situation?
If that is a situation and the left mammary artery, there's a subclavian block as well, it's a difficult situation, no doubt about it. I have seen one colleague of mine, I have not done it personally. He has anastomosed the vein, he's done a thoracotomy and anastomosed the vein to the descending thoracic aorta and then brought it to do revascularization. Having said this, in such cases, I would do an aortic ultrasound and find out a soft spot. We have liberally used to do heartstring devices, which I have in my armamentarium. I would find out a soft spot, try to do a top end somehow, and come out.
Okay.
Okay.
Thank you, Dr. Bose. We call on the next speaker, Dr. Shiv Nair. The topic is best second arterial conduit.
Chairpersons, ladies and gentlemen, the topic that I have been asked to speak about is the second best arterial conduit. So I believe that grafting strategy has to be individualized. And what is our decisions based on? One is, of course, age, the clinical characteristics of the patient that includes LV function, acute coronary syndromes, recent MI, the coronary artery anatomy, the cardiac dimensions, conduit availability, what is the planned configuration, and most importantly, what is the surgeon's experience and comfort level. Now, before I proceed, as has been mentioned by the previous speaker, Lima and Vima was proven by the Cleveland Clinic Group and Dr. Floyd Loop to be more beneficial to the patients in the long term. But after the starting of the use of the radial artery, there are other studies which show that multi-arterial grafting is superior to a single arterial graft. And therefore, we need to make a choice of what is the second arterial conduit that we will use. As I mentioned, the first choice and the gold standard, of course, is the left internal thoracic artery. The options for the second arterial conduit include the radial artery, the right internal thoracic artery, the right gastroepiploic artery. But we must not forget that the saphenous vein, either harvested by the conventional technique or the no-touch technique, which is gaining prominence, is the most commonly used conduit for multi-vessel coronary artery bypass grafting. So let's start with the radial artery. The radial artery, as we all know, is a muscular artery and therefore is prone to spasm as well as calcification. And the viability of the arm, of the hand, must be assured before we sacrifice the radial artery for a better cause, that is for coronary artery grafting. So how do we ensure the collateral circulation? Is either by the Allen test, which of course is very operator dependent, but we must also assess it intraoperatively, which is a more objective assessment. Ultrasound examination of the radial artery can be done preoperatively to see its size and calcification. And by default, normally the non-dominant arm is used if you are harvesting a single radial artery, but there has been no proven dissatisfaction by using bilateral radial artery harvest. Now we must remember this point. There is a lot of controversy regarding the increasing use of transradial catheterization for coronary angiogram. We must remember that a 5 to 6 French sheath is used. It is about 7 to 8 centimeters in length. And what has been found is that the diameter following radial artery catheterization is reduced by about 10%. We remember that the radial artery is punctured about 3 centimeters above the wrist, and the maximum damage is in the subsequent 3 centimeters. So basically about 7 or 8 centimeters of the radial artery is very vulnerable to damage. And what kind of damage? There can be just an intimal tear, there can be dissection, or there can be media thickening. All of these are precursors to getting atherosclerosis in the future. There's a very important study which showed that the patency of a transradial catheterization radial artery is about 70% as compared to a pristine radial artery, which was at the follow-up of 18 months, which was 98%. So this is of course just from one study, but we definitely need to be careful regarding use of the radial artery in the current circumstances and whether we can start using it from the side which has not been catheterized. So as has been discussed earlier, there are many ways to harvest the radial artery. That is either by open technique, which of course is unsightly because of the wound and the suturing, and the endoscopic technique. The endoscopic technique, of course, is more prone to spasm, bleeding, endothelial dysfunction, but there is no data to suggest that endoscopic harvesting or regarding the patency. So basically both the techniques are same and depends on the surgeon's choice and the team's expertise. How do you select a target for the radial artery? Should it be more than 90% or more than 70% proximal stenosis? In the RAPCO study, which is one of the major studies regarding radial artery patency, all the grafts were put to stenosis of above 70%, and the minimal diameter of the vessel was 1.5 millimeters. And in their study, which is a very large study, there were only 11 late radial artery graft failures. So at least a 70% stenosis and a reasonably good sized non-LED target would provide for better results. There are a number of other observational studies which show that more than 90% stenosis improves patency. And the RCA has a very much poorer patency if the stenosis is less than 90%. So the 70% rule may not apply to the RCA. It has been unproven whether radial artery has better patency in small vessels compared to the saphenous vein graft. Now this is what the literature says. And an FFR below 0.8 or 0.78, most of the studies have been done for the internal thoracic artery grafts rather than for the radial artery grafts. So these are various studies for comparison. This is a forest plot showing various studies done by a number of teams, both in long-term mortality and in repeat revascularization and MI. The results of radial artery are superior to those from saphenous vein grafts. This is another such study where the primary outcome in graft failure was poorer for the SVG as compared to the radial artery, and therefore, and even in the subgroup analysis, radial artery showed better results than the saphenous vein, and therefore we can probably safely conclude that the radial artery is a better graft than the saphenous vein. This is the big RAPCO study done by Brian Buxton, one of the early proponents of the radial artery, where the incidence of graft failure between the radial artery and the saphenous vein was better. Results for the radial artery similarly was for the mortality as it was for the composite of death, myocardial infarction and repeat revascularization. So in conclusion, the radial artery is a better graft than the reverse saphenous vein, and therefore it is probably a good graft to be used as the second arterial conduit. Now what about the use of calcium channel blockers? Because this really contributes to the patency. It can be given IV, oral, topical or intraluminal. And it has been shown that nifedipine and amlodipine are probably more than 30 times more efficacious than diltiazem. However, we often find that we can't use these calcium channel blockers, or their drop in the blood pressure, etc., may preclude the use of more other important secondary prevention therapies like beta blockers, ACE inhibitors, etc. But this is the study by Gaudino in JACC, which shows that there were improved outcomes for death, patency, myocardial infarction and revascularization if calcium channel blockers were continued for at least 12 months. So this is a controversial issue. We all have different periods of time which we use CCBs, but 12 months has been shown to be a good time period to use calcium channel blockers following the use of the radial artery. What about the radial artery proximal anastomosis? Actually, in a Y or the T graft, there is obviously a risk of competitive flow if the grafts are put to vessels with less than 70% stenosis. In the aortic anastomosis, there is less risk of failure because of competitive flow, but the graft is exposed to a higher wall tension. SVG patches, SVG interposition grafts have been used, but the data currently is insufficient for any meaningful guidance or evidence to suggest which is the best technique to use for the proximal anastomosis of the radial artery. Coming to the right internal thoracic artery, a network meta-analysis of 6 RCTs published recently and with a 4-year angiographic follow-up showed that the saphenous vein graft is associated with a 4-fold increase in the risk of graft occlusion. And in this particular study, which also did an analysis of the RA, radial artery and the gastroepiploic artery in the same group of patients, Rita achieved the highest probability of being the best conduit. So following the radial artery, the Rita is also a viable option for the second arterial graft. What about the patency? This article published in the Journal of American Heart Association, 14 RCTs, 3,396 patients, 3,651 grafts, 5-year follow-up, patency of, angiographic patency of SVG was 81.8%, of Rita was 90.9%, and the Rita, their conclusion was associated with lower rate of graft occlusion than the saphenous vein. Now the other controversy is always about what graft to use for the right coronary artery, because it has got a lesser vascular bed and lower patency. But in this group of patients of 7,223 patients, 15-year survival in a propensity match group, till the 9th year, there was a similar risk of death. But after 9 years, Rita to the RCA showed a lower risk of death. So as mentioned earlier, maybe probably the benefit kicks in the second decade, where the graft failure is higher in the saphenous vein. What about comparing the Rita to the SVG? Rita has a lower long-term mortality at 5 years when compared directly to the saphenous vein graft. SVG grafts alone, without use of a Rita, showed a higher late mortality and operative mortality and perioperative MI. Of course, we know that deep sternal wound infection is a risk with the use of the bilateral mammary, but as mentioned by Dr. Bose, skeletonized right mammary artery and left internal mammary artery probably have a lower risk of deep sternal wound infection. And therefore, we can again conclude, because we have to compare it with the SVG, because most of the grafts used worldwide are SVGs apart from the left internal mammary artery. What are the long-term results of beta? The ART trial, as you know, that showed no benefit of bilateral internal thoracic arteries on outcomes, etc., for 10 years. And but the subgroup analysis did show that there was some improvement following the 10-year mark. In the interest of time, I'll skip this. So how do you select? What about target selection and inflow configuration for beta grafting? Bypassing non-LED targets perfusing large myocardial mass results in better long-term outcomes. Larger target vessels are better suited for beta with a reduced rate of graft occlusion. They, of course, have mentioned of 1.93 millimeters, but we don't get those kind of arteries here in India. In moderate proximal stenosis, composite grafts may fare poorly. Long-term Rita patency is independent of inflow configuration. I think that's important to note, so composite grafting is not the only way to go. And composite graft offer better complete revascularization at the potential risk of an imbalanced flow because of competitive flow. And there is no difference in the results of an in situ Rita or Rita to LED. Selection of targets, one of the criteria used is the distance to the apex. Shorter the distance to the apex from a non-LED target, better are the patencies. So regarding in situ grafting and composite grafting using the second arterial graft, actually speaking, in situ grafts seem to show a better result than composite grafting in these forest plots of various studies done across the world, both in MACE as well as in all-cause mortality. So what about the graft patency and the harvesting technique? Skeletonization maintains the structural integrity, it maintains the physiological responses, acute graft flow is good, sternal perfusion is better, but of course there was a COMPASS study, a post-hoc analysis which showed that the occlusion rate was slightly higher in skeletonized Ritas as compared to pedicle internal mammary, thoracic artery. Finally, the right gastroepiploic artery, very rarely used nowadays, but one important aspect to look for in the use of the right gastroepiploic artery in the RCA is the size of the vessel. The vessel size is extremely important for use of RGEA. A size less than 1.1 millimeters shows better patency for the RGA rather than a big vessel. So it's mostly grafted to the PDA. Are there any contraindications to a second arterial graft? The right gastroepiploic artery may be contraindicated in patients who are obese, elderly, or who have the potential for future abdominal surgery. The radial artery, of course, as we know, if there's inadequate collateral circulation, if there's vascular disease, if there's an AV fistula for CKD, or there has been forearm trauma and operative repair. In conclusion, I think there is no doubt that a second arterial graft is absolutely necessary in most patients less than the age of 70 for better long-term outcomes, and we expect life expectancy to exceed 10 years, and therefore even if the benefit kicks in after 10 years, that is a useful addition for the patients in the long term. Thank you.
Thank you, Dr. Nair. Any questions from the audience? Sir, one question from my side. How frequently do you use bilateral radial arteries? Any situations like that where you happen to use bilateral radial arteries? Arteries as a conduit? When the conduit shortages? Thanks.
So, thank you, Dr. Shivnaya, sir. We'll move on to the next topic, how to improve saphenous vein patency by Dr. Rajesh. Dr. Rajesh is the head of the department at Calicut Medical College. Over to you, Dr. Rajesh.
Respected chairpersons, seniors and colleagues. First of all, let me thank the organizers for giving me an opportunity to present this topic. We have been listening to all multi-arterial grafting strategies and improved patency. Now let us see what is there in as for the veins. Sort of a devil's advocate. Let us start. So, saphenous vein grafts, as we all know, have been used in about 3/4 of coronary artery surgeries. The reasons are obvious. As you all know, the ease of harvest and availability. And the 10-year patency has always been a cause of concern. Around 50% of 50 to 60% of grafts only will be flowing by 10 years. That is what the literature says. And whereas the arterial grafts patency is around 90%. So it's the first year itself the occlusion rate is high. So we'll see what is vein graft failure. So it's a slow insidious process which starts from the moment incision is put on the vein. So in the very early weeks, initial weeks, it is mostly technical and technical only. So it can cause thrombosis. Whereas towards the later part of the first year, it is intimal hyperplasia, where the smooth muscles proliferate from the media, they grow on to the intima and cause occlusion. Whereas in the later part of the natural history, atherosclerosis catches up with the veins as is seen in the native coronary arteries. Let us focus on the early graft failure, where the surgical strategy modification can really improve the outcomes. Technical, mostly it's graft trauma, that is taking the incision on the veins itself, take the vein to a higher oxidative stress, whereby all these prothrombotic mechanisms outweigh the antithrombotic mechanisms like nitric oxide and prostacyclins. And the interplay of these factors create a prothrombotic state. Along with that, the conduit-related factors like mismatch and pre-existing graft pathology all will contribute to early graft failure. Just as the comorbidities affecting coronary artery disease, these same comorbidities can affect vein grafts also. The most important being smoking and dyslipidemia. Looking at the comparison of the patent and occluded grafts, as we can see that the 20%, about 15 to 20% of grafts blocked by first year. And there is a plateau thereafter. So from till about 6-7 years, it's almost like that. And then there is a climb. So around 7.5-8 years, there is an increase in occluded grafts again. So the first year itself, we can prevent occlusion to a certain extent by modifying our techniques. Vein grafts patency will be more. We'll see in the next slides. See, again, there is a rule which is called a 7.5-year rule. That's corresponding to the number of angiograms which were taken in this follow-up of these patients. So most of these patients after the first year had an occlusion around the 90th to 100th month, which corresponds to the 7.5 years. So which brought the patients to the clinicians and more angiograms were ordered. If you look into the histology of atheroma of the saphenous vein, it is basically layered thrombus with inflammatory cells and a very thin or even absent fibrous cap, which can break at any point of time and cause a significant occlusion. So vein graft atheromas are more friable than native graft atheromas. So let us see what all techniques we can adopt to improve the patency. As this does not need any mention, there are several techniques, conventional, bridging, and finally the endoscopic has come. It is the state of the art technology now. So in a conventional technique, as we have been practicing so for years, it is harvested as a skeletonized. So even those tissues are around, we used to take out those tissues and take it as a skeletonized way. And there is so much of handling with instruments, and there is pressurized distension also. Whereas in a no touch, it is just like harvesting with a pedicle, like an internal mammary artery pedicle, you are taking the vein along with the perivascular adipose tissue, which preserves the vasa vasorum. So this is the first picture, shows a no touch open technique. The second one is a conventional that we harvest, we practice all through. Third is endoscopic vein harvesting, and fourth is the endoscopic no touch, which will be the state of the art in years to come as we look towards increased patency rates. In the first left side of the diagram, you can see that no touch technique, there is no distension, the lumen is not distended, and the perivascular PVF is the perivascular fat is all present, which will preserve the vasa vasorum. And the second one, all the perivascular tissue has been taken out, the vein is skeletonized. So advantages of no touch, the most important being the preservation of vasa vasorum, which will allow the graft, the blood from the lumen to retrogradely perfuse the vein wall, which will decrease the transmural ischemic damage. And the surrounding tissue will act as a cushion or which will prevent kinking in years to come. So if you see the decreased occlusion rate, the first year occlusion rate is around 7.5% for no touch technique, whereas if you use conventional, it will be around 15 to 20%. All the trials and RCTs which favor no touch, compared no touch with the conventional are favoring no touch technique. The improved CABG and the suite graft trials are going on, and there is a trial which the last one, the SAVE RETA trial, which compared the outcomes with when the saphenous vein was used as a composite graft to Lima against REMA. So they have found comparable outcomes in both. So again, there is a hope for veins. You see that the Japanese study, which shows 20-month patency of veins is around 98%, whereas 60 months the patency is 95. Somewhat it can be compared to arterials also. The cushion surrounding this pedicle will prevent any kink. Most of the time we are worried about the excess length, kink and all. But if you keep as a pedicle, it doesn't. It's like internal mammary artery having an extra length, it will take care of itself. Venous external support. This is another area where you support the veins with a mesh-like device which will prevent dilatation and intimal hyperplasia. The picture shows a mesh-like device applied around the veins, which will have a positive effect on vein wall thickness in the follow-up. Endoscopic vein harvesting is the order of the day. So initially there were some arguments against endoscopic, like the quality of the vein was not good. But now because there is a better wound healing and cosmetically appealing, the studies also have not found any difference between endoscopic and open vein harvesting. The best is to combine a no-touch technique with an endoscopic, which will be the practice in the years to come. Again, that is an endoscopic no-touch technique. The vein is seen in the middle, and the star tissue is the perivascular adipose tissue, which will preserve the vasa vasorum. There is not much difference, as we discussed, between open and endoscopic. Vein preservation solutions, as we all the previously used was isotonic saline, which is acidic. Then we all use the autologous whole blood or the God's own solution, which is easily available, which is again alkaline. But there is an interest in buffered solution, which is a pH adjusted Duragraft, which have been used in some of these institutions. So that also finds favor. Anastomosis and graft configuration is one thing that we surgeons are always concerned about. So you select good targets, it's all basics only, more than 2 millimeter in diameter with proximal significant flow, and the arterial venous composite graft that has been studied in the RETA trial also, SAVE RETA trial. So SVG is subjected to a dampened pressure than the direct aortic pressure, which will reduce the atherosclerotic problems. And it experiences the beneficial effects of IMA, like the vasodilatory properties of the nitric oxide is carried over to the internal mammary artery. And sequential, as we all do, there are certain principles to be followed. Small coronary sequentials have a better flow. The last anastomosis should have a greatest runoff. As we all know, the distal runoff is something that maintains the patency in whatever conduit we put. So, a graft to LED will have the maximum patency, whereas RCA will have the minimum. Again, avoid vein segments with valves and dilated segments. Then thickened veins have to be avoided. Then cobra head anastomosis. All these are basic things that we practice every day, but has to be followed diligently in each case. Sequential grafts, try to avoid C-gulling. Angle of anastomosis is also important. You have to create an angle of anastomosis which creates very less energy loss across the anastomosis. So ideally 45 degrees is recommended for venous grafts and arterial grafts, somewhere around little less than that. And orientation of proximals, as we all know. Intraoperative graft flow measurements. So we have to have a quality control in surgery. So TTFM or the transit train flowmetry or the Medistim device has come. So it will help us in identifying the technical problems with anastomosis and outflow targets. And we need to revise grafts which have a pulsatility index more than 5 and a low flow less than 20. Pharmacological treatment. Aspirin is the mainstay. We have to start aspirin within 6 hours of surgery. Double antiplatelet is recommended in OPCAB as per studies. Second antiplatelet we need to add, it is better ticagrelor than clopidogrel. Both the trials have studied this in detail, and the benefit is, as per literature at least, the benefit of double antiplatelet is more in patients who undergo OPCAB. But in on-pump also there is no harm in giving, but it is basically OPCAB. Target of LDL is less than 100. Secondary prevention, as we prevent all the lifestyle diseases, there are certain interest in ezetimibe, which is a drug which improves the potentiate the action of statins. And immunomodulation, gene therapy, and vector delivery strategy, all have been tried. These are all in experimental stages, will come up in the future. These are trials which favor the no-touch technique and endoscopic. So whenever there is a failure, we need to address that. So no need to address failure in a clinically stable patients. We know that many grafts block off, but the patients are stable. But if the patients have symptoms like ACS, persistent symptoms or proximal LED disease, we need to do PCA. If possible, do PCA to native vessels, and PCA to graft PCA will be more difficult. And consider redo surgery for patients who did not have a internal mammary artery at the first surgery, and younger patients. In this era of interventional cardiac surgeons, we need to know, we have to tackle our own problems. So we need to know which catheter to be used for a proximal problem or a graft problem. So usually we use Judkins right for hooking almost all proximals, if not the Amplatzer. So finally, the peri-procedural strategies, as we have discussed, select good targets, proximal significant flow, which assures a good distal runoff, and buffered solutions if available. No-touch technique. No-touch technique combined with endoscopic vein harvesting is the order of the day. We have to practice that to compare veins to somewhere near the arteries at least. Dual antiplatelet, especially in OPCAB, and high-intensity statin administration. This is a pictorial representation of the last slide. Thank you.
Thank you, Dr. Rajesh, for the excellent presentation. And a properly harvested vein graft and carefully done, it has got a patency almost equivalent to radial artery. That is what he presented. How long you will put the vein in the Duragraft?
Duragraft we are not used on a regular basis, but 20 minutes is what is recommended, I think.
Okay.
Not experienced in that.
I think I will have a question for the PGs here, and I think Dr. Vinitha will give a prize for that. How much pressure is we exert when we try to distend the vein and assess the competence?
So it said that question. You're asking
question to the PGs. how much pressure is there in the vein wall that we exert, that is on the endothelium. Anybody can answer. Dr. Vinita will be giving a prize.
There is a study.
It is 100, 200, 300. You can have the choice. Yeah. Any other answer?
It is more than 200.
Okay. It is more than 300.
Why? I am generating a pressure of 50 with my thumb, guarantee. Still the pressure is 300. Why? Guarantee. My thumb is trained to generate a pressure of 50 mm of Hg. But the pressure inside the vein is 300 plus. Why? Simple. Disparity between
size of syringe.
Between
the syringe and
you are acting more than talking. Disparity between the diameter of the syringe and the vein graft. So it is the square, the pressure is increased. So if you are taking a 20 cc syringe and injecting into a 3 mm vein, okay? Thank you.
There are studies which compare.
You give him prize?
Yeah, he is getting the prize. I think Vinita will arrange a prize.
You are
Injection.
You are from Kottayam? You are from Kottayam? Calicut, my God, enemy.
See, the studies have compared injection with small syringes as well as big syringes. The pressure generated by big syringes are in fact less than what we inject with small syringes. So it is recommended to inject with if at all injecting, you are injecting with a big syringe.
All studies have come up with injecting with 20 ml syringe.
20 or even bigger. Bigger syringes are recommended, not to inject with small syringes. That will generate more pressure.
Okay, thank you, Dr. Rajesh.
Thank you.
Now we'll invite Dr. Vivek to hear on pump beating heart surgery and on pump arrested heart surgery.
I've been asked to speak on pump beating, arrested heart, and I've added also OPCAB with IABP because that's a real life situation that we do face. I know what most of the youngsters are thinking, yet another evidence paper, but what to do, evidence is boring, so I will try to keep it short. I cannot make it interesting. First, I'm thanking Dr. Jayakumar for this opportunity. Also, I would like to thank one of our residents, Deepak, for giving me the material that I've used for this presentation. As most of us are aware,
in a real-world scenario, there are very few conditions that really require special techniques or special strategies, because all of us are very proficient in doing off-pump in probably 90-95% of the cases. And there are certain situations like those that were discussed in the morning in acute coronary syndrome with a patient with ST elevation MI presenting with shock, or a patient with a non-protected left main, or a patient having very poor ejection fraction where they cannot tolerate much of, when you disturb the heart, the hemodynamics are not holding. These are situations that we require, to think outside the general op-cap strategy. So I have divided my talk into basically three. First, we'll speak about the situations, what is the evidence available for situations when we are facing a patient with in acute coronary syndrome with an ST elevation MI, maybe in cardiogenic shock. Fortunately for us, in most of the cases in acute MI, CABG is not a solution. The indication for CABG comes only when it's refractory to thrombolysis, or patient is ongoing ischemia due to a failed PCI, left main disease with complex coronary anatomy. First I have compared actually the papers differentiating the results of op-cap with the conventional CABG. Advantages of op-cap is, as is evident, better renal, respiratory, neurology outcomes, as well as lesser incidence of AFib, and the cost in countries like ours. But the major disadvantages across many studies has been the incomplete revascularization, particularly the circumflex area, leading to poor long-term survival and need for repeat revascularization. So this is a paper from Khalil Fatoush that compared off-pump versus on-pump in patients with ST elevation MI, and the primary endpoints were in-hospital death and the major morbidities like low cardiac output, requirement for mechanical or inotropic support, then mechanical ventilation. 128 patients randomly assigned. This was actually a prospective trial. And they have found that off-pump reduced early mortality, particularly if the timing of surgery is less than 6 hours, which probably we do not generally get. Most of the patients we get are in the around about 24 to 48 hours post symptoms. They have found that in off-pump patients, the requirement for aortic support and reoperational for bleeding, etc., were much less. This is another paper that actually tried to bring out an algorithm on which strategy or which patient can benefit from an off-pump. So they have taken 3-4 criteria like you evaluate the coronary angiogram and then see the hemodynamic status. After you harvested the grafts, see whether the grafts are of good quality and the target vessels are non-calcified, good for grafting, and then you just move the heart around and see if there is a patient is able to tolerate the cardiac positioning. In such cases, they said go ahead with if all these criteria are fulfilled, go ahead with off-pump. Otherwise, if one of them, if you are doubtful, I think in acute coronary, better to go for on-pump, because the conversion carries a very high mortality. Once you've decided to go on pump, whether to go for a beating heart or go for conventional. This is a paper, this is probably a retrospective paper with around 61 patients where they have retrospectively analyzed the data regarding on-pump beating heart versus on-pump arrested heart for acute MI, and they have found that there's a significant reduction in the mortality if you go for on-pump beating rather than arrested heart. And even though these on-pump beating patients were higher risk, had a higher Euroscore as well as were on pre-op IABP, but the mortality was significantly less in the on-pump beating group, as evidenced, and also the morbidity as evidenced by the lower limits of CPKMB and all that. This is another paper, similar results, that showed that the early mortality was around 31% for the arrested heart versus the 13% for the on-pump beating, and then they have attributed it to generally to the less global ischemia due in beating heart patients. It's a meta-analysis of patients that was done. It went through a lot of articles, 279 articles. They selected 17. They compared off-pump, on-pump beating with off-pump as well as conventional, and found that they had reduced post-op mortality, reduced stroke, as well as reduced requirement of IABP in the on-pump beating. And when they compared the number of grafts or the completeness of revascularization, they found that the conventional on-pump was the best, followed by the on-pump beating, and the worst for the off-pump group, particularly in these high-risk conditions. These are just the forest graphs showing favoring on-pump beating in most cases in high-risk patients, as well as LV dysfunction, and in post-operative blood loss and ventilation. All those features favored. So they came up with the conclusion that factors associated with potential benefit of on-pump beating would be acute coronary, cardiogenic shock, LV dysfunction, reduced surgeries, unstable hemodynamics, intramyocardial vessels, and poor targets. This is a meta-analysis of from a large group. They had compared almost 4,000 patients, on which almost 1,000 were on the on-pump beating as compared to around 2,000 in the conventional. But they have found there is no difference in the significant overall mortality or midterm survival between these two. But beating heart definitely had significant post-op myocardial events, as well as reduced requirements for IABP. And they have concluded that the beating heart is non-inferior to conventional in particular situations. This is another paper that compared actually 4 strategies, that is the on-pump, off-pump, beating on-pump, as well as the right ventricular support without an oxygenator. And they have found that even though the patients they had taken for the on-pump beating were much sicker, had renal dysfunction and all other comorbidities, with more people on IABP, but then they have found that pneumothomic CPB with the beating heart is a safe and efficacious, and maybe the method of choice that they have. We could comment on that in patients with cardiogenic shock and previous CABG. This is a paper that came out in India recently. I think one of the authors, Debashish, is here. Yeah, and then this came out actually contrary to most of the other papers. They had shown that actually on-pump beating is worse. But then if you take the patients that they had enrolled in the on-pump beating group, most of them were emergent conversions. Half the patients were emergent conversions from the off-pump. So if you see, all of the published data shows almost a 30% mortality in emergent. So we cannot definitely be really sure, because the bad patients went for the on-pump beating. Then for left main, if I say this, it will be controversial, but data shows that off-pump mortality in 3 years is much more than on-pump, because in India most cases, people are doing most cases off-pump. So regardless whether they are left main or otherwise, but it's a TAGARD, it's a paper, it's a multinational paper from UK, US, and so many nations where they had shown almost double mortality in the off-pump group at 3 years, probably due to incomplete revascularization. Just before this, regarding this off-pump, on-pump beating, there is, of course, you might think that it's a very safe strategy, but there is a the cardiac MRI have shown there is a small element of subendocardial ischemia associated with on-pump beating. They have shown hyperenhancement as well as poor, disadvantages remodeling. That is because once you have put the patient on pump, the myocardial flow is basically based on the mean arterial pressure once it goes below 50. So it is perhaps not the ideal strategy, but it's one of the safe strategies. Next is just a little bit about the IABP use, whether IABP uses, does it really, I think in the morning somebody mentioned the patient can just put the patient on IABP and then continue. But then if you see that pre-operative IABP did not show any actual, 30-day improved survival, though there was improved convalescence in these groups. There are a lot of papers that have come out regarding this. there is no significant, most of these papers show no significant difference or advantages of prophylactic IABP in patients even with left main undergoing CABG. And this is, they have actually downgraded the indication for IABP in cardiogenic shock because long-term survival, I think 6-year data didn't show much of survival difference between the IABP group and the other. So finally what? So for all these young surgeons, they will be facing. So what I would say is if you're getting a patient in less than 6 hours, op-cap probably will be a safe strategy. And conventional on-cap versus beating heart on-cap, though it doesn't have much of a long-term survival benefit, but short-term benefits will be there. And then for left main, which is better, it's yours to choose. Like Dr. SK mentioned, the current evidence doesn't favor anything particularly. And IABP, how much is it useful? But as Varghese will testify, we also generally, patient goes bad, immediate post-pump or off-pump patient, we put the patient on IABP and then we almost get away with it. So I think in the short term, I do not have data on that, but definitely it's something to fall back on when you are in trouble. Thank you. It's more of a show-off slide than a thank you slide.
Thank you. Thank you, Vivek, for keeping time. Just one scenario. You have a patient who is, forced you to go on pump because of hemodynamic instability. Now, once you are on pump, whether to actually clamp, give cardioplegia and do it, or do the on pump beating. What do you think? What will be your choice?
No, our choice. We have almost always done these cases on beating heart. And then I think most of the data also supports, if you have gone on pump, the problem with already you have a patient in cardiogenic shock, you arrest the heart and then there's global ischemia followed by this reperfusion, the free radical induced injury. So I think if you're able to do, I think in 95% of the cases we'll probably be able to just support the heart for CPV for a while, and then these patients do not actually require, what we have seen is most patients sometimes may require, if you go arrest the heart and then when they come off they will require IABP, for a larger number. But these beating heart patients, just to support for a while, we are able to get them off without IABP most of the times.
Yeah, that is what I was going to ask you, whether you would insert the IABP when we are weaning off the patient from the pump for these kind of patients with cardiogenic shock.
Yeah, then prophylactically, if the patient had a pre-op very poor ejection fraction and all that, then we would probably, just for our peace of mind, we would put in the balloon. But then we have done so many cases when we had to go on pump as an emergent, and then after we have done a beating heart, on pump beating, and then they have come off without any.
One paper I have seen that after 3 years the mortality rate for off pump is high, I think. What's your take on that?
No, it's a controversial thing. So I actually put it out to the audience for them to decide. But it's a large study. I think the result of any procedure is the experience that you have for it. So most of these patients, the studies have been done in the West where 90-95% of the cases are done on pump. And then their experience with, I think, complete revascularization in particular situations might not be so great. But in India, I think, since most of us are doing everything off pump, and we'll be able to put, almost go for a 98%, 100% revascularization. I think the end result of long-term results are primarily based on the completeness of revascularization.
Okay.
So, thank you, Dr. Vivek, very much. And from his talk, we came to know that the myocardial protection, clamping the heart is more dangerous. So, and we would like to invite the next speaker, Murali Vattat sir, for hearing more about his innovations.
Thank you, Jess. Thank you for inviting me to your talk here today.
In fact, when Vivek was speaking and giving all those like talks on pump, I thought with today's scenario, no one would be talking on pump here. I thought we are all off-pump surgeons. That's what my notion was. But as of now, I think all the publications which you were talking was 10 years before time. And I don't think in Kerala there are many surgeons who do on pump nowadays. Another thing which I wanted to mention from that was I don't think we get an acute MI at all. We get only coronary surgeries which the cardiologists cannot open. So we get only the leftovers. So we need to get adapt with off-pump surgery and go from there. And use of IABP has been published so well that we don't have to go on pump at all. So if you have an IABP on a patient with having an issue with ischemia during a grafting, IABP is the way to go. But that's not my topic, but I just wanted to mention this. So mine is to how to avoid a disease aorta in CABG. So like if you know pre-operatively that the aorta is diseased itself, like he's got a stroke history or he's got carotid thing, we try not to use the aorta like an aortic technique. And there are so many ways of grafting them, bilateral mammaries and everything. Definitely it can be done off pump. Mammaries with radial arteries. But I don't think today there is any issue about under grafting. There is only, I think, too much of grafting. So I think that's taken care of. If you have an idea that, if you think that aorta is diseased preoperatively, don't touch the aorta. But in case you suddenly, you don't notice that the aorta is diseased till you are going for a top end. But nowadays we can always, you lift the aorta with your right hand, feel, lift the heart with the right hand, feel the aorta, and when the pressure drops, you can feel the aorta very well. We don't usually do any epi-aortic scanning, but then your plan is to avoid the clamp. So the benchmark for any anastomotic device are usually the reproducibility, ease of use for a short time, like anastomotic time, and the anastomotic device ideally would work with either vein or artery, proximal or distal order of anastomosis, which was done earlier. Now I think we always do it end. And you should know that device should facilitate a broad range of surgical access and should have patency comparable to hands-on anastomosis and must be reasonable bailout too. So there have been so many anastomotic devices, like they've been saying heartstring is still in the thing, but I've been using an anastomotic operator. So the indigenous device like aortic side clamping, the cause definitely everyone knows neurological problem. So anastomotic device had to be there but should not be expensive. So the one which we devised, anastomotic operator, which had all this grooves and stuff in it where the needles could be passed. But like as James was telling, we don't need the grooves now, but just need the hangers dilator. Basically it is purse strings, two purse strings with a 3O around the aortic area where there is no plaque. So you need to feel the aorta, and in that region there should not be a plaque. So you can always feel it when you drop the pressures, like you lift the heart or do something. Then you take two purse strings, and then the purse string, only one needs to be tightened. I use two purse strings because sometime back I had to cut off, or one got cut when I was doing the punch. So, I mean, doing more off pumps, you come to know that usually this normal side clamp can be done. You don't crush your clamps, you just put it slowly. A little bit of leak is fine. And that's, none of these patients have had a stroke. So this is just to show how I put my purse string on this aorta in the area which you wanted. Put a punch, pull it out quickly, and put the anastomotic operator into it. snare it. And the good thing about aortic anastomotic device like BAO is you don't need to drop the pressures to less than 100. Like you're having an ischemic patient and your circ is dependent, you can even have an IABP going on with and then do this. So you can do the top end, but if you're putting a side clamp, you need to stop the IABP, put it on standby mode. So that's one thing which is very important to notice. Yeah, I use a 5/0 or a 6/0 big needle. I don't know the numbers. And this is sometimes we use 2 top ends, and once the first is put, we put a second top end, or you can hook the vein onto the other vein, like you use a piggyback. So the thing is, if you have spots where you can think you need to put top end, you can always use them, and whichever way you're doing your normal top end surgeries should be done. And if you're worried about it, you can always do an angiogram later on and see. So this is just to show that how you can do your top end in diseased aortas. So another extended use of anastomotic device is that in case where you have an aortic valve replacement and you're on pump and you don't want to put a clamp, this is a very useful thing. And also in the redo surgeries, usually the vein knuckle does not have any calcification. You can always find a soft spot. So you don't have to dissect on both sides and try to put a clamp. Usually these diseased vessels are calcified. So this is a very useful technique on top ends on this redo patients. So in conclusion, the proximal and distal anastomosis or like proximal or distal can be put first. Some people put it top end, whichever way you want. And the thing is, no need to drop the systolic pressures, and it's so reusable and it can be used in redo things. Definitely the not clamping is the important thing. If you're using total arterial, that's the way to go. Thank you.
Sir, thank you very much for your fantastic presentation. Sir, when you really have a porcelain, almost like a porcelain aorta, and you have only a soft spot.
I don't touch. If there's a porcelain aorta, it's always bilateral mammary, and don't touch the aorta. Only in the time when you take the vein graft, come to a top, and you put a side clamp, and then you feel this, that's when you do all these things. I even hook the vein graft to right internal mammary and just let it go. This is always a salvage mechanism.
Okay. One question which I wanted to ask, there's 2 minutes left, so to Dr. Satyajit Bose, when you are harvesting, sir, question to Dr. Satyajit Bose, when you are doing anaortic surgery and you are harvesting the lima, you said you have to harvest till the top. Do you always open the pleura, or you do it extra pleurally?
Initially, I used to do extra pleural. Then what happened was, one case came back to me with angina. And then we did an angiogram, and I found that I had left that first intercostal artery. So I stopped doing extra pleural, and I open the pleura in all cases. And I go right up to the top in cases of rheuma, for that extra length, and avoid clipping it, and always clip it before the bifurcation.
Yeah, this is one point I wanted to highlight, because I take skeletonized mammaries extra pleural, and if you want to really go on top of till the top in a beating heart situation, while harvesting, you can actually put the lung down and use your retractor, octopus, to actually push the lung back and then go right up to the top if you are doing it extra pleural. But it's very important to...
The only problem with that extra pleural is sometimes you have to make a little groove for that lima to fall in, then it consumes a bit of lima. If you have that bit of extra length, you can do a D1 LED sequence, you can use it for something.
No, just a technical...
just taking it down, you mean?
Why actually you are doing everything extra pleural?
Right, definitely reduces the amount of pleural collections, post-operative pulmonary complications. Definitely, post-operative pulmonary complications, the left lobe collapse, all that is much less. Very, you can see on the X-ray itself, you can see the difference in these patients.
Because I've never done it that way. That's what I was wondering. You learn every day, isn't it? Thank you. Thank you.
Thank you. I think we'll close the session. I think time for lunch. Thank you, everybody. Thank you.
Thank you, panelists and speakers, for such an informative session. Now we shall adjourn for lunch, which is arranged outside the hall at Green Arch. Kindly assemble back to the hall at 2:15 p.m. for the most awaited session of the day, which includes live demonstration of aortic root widening techniques.
Almost twice as common in Southern Europe compared to Northern Europe. So again, there is a definite relation to body size and the aortic valve implantation. So what is the problem with the small aortic annulus? Once we establish that the aortic annulus is small, we're going to put in a valve which is inherently obstructive into that small annulus. And this has also been shown in multiple publications, most recently popularized by Bo Yang when he demonstrated his new technique of root enlargement, that the inner diameter of the prosthetic valve is always 5 to 7 millimeters smaller than the labeled valve size. So that is the problem in TAVR with the TAVR. TAVR valves are more obstructive compared to TAVR. And even in the TAVR valves, balloon expandable valves have a high incidence of PAPM compared to the self-expanding valves. So how to calculate this EOA? That has always been the issue, and there are two ways generally recommended. One is the conventional method, which is the measured EOA, which we do using the Doppler echocardiography. And then there's not a new concept, but probably the recommended concept should be something called the predicted EOAI. So the problem with the measured EOA, there's a lot of fallacies in its estimation. There's a lot of inter-observer variability. So one echocardiographer does an echo on one patient with a particular valve, and another echocardiographer does a same study on the same patient. He can have a completely different value for the EOA. So to avoid this inter-observer variability came this concept of the predicted EOA. In this technique, you do not need to do any echo measurements. You just take the reference value of the EA for that particular valve and that particular size of valve which you are planning to implant or which has already been implanted, and divide this EOA by the patient's body surface area. So then the question comes, where do I get these reference values? Surprisingly, even this is widely available in the literature, and this has been collected from multiple studies from CoreValve Ecolab estimations, and they've given the values of all the commonly implanted valves. So if you look at this, like the Carpentier-Edwards Perimount Magna valve, we'll just look at the size 19 valve. The EOA of that valve is 1.3. And another commonly implanted valve that we implant here, the BioCore, the EPIC valve, if you look at the EOA of the 19 size valve, it's only 1. So it's significantly less than the Perimount. Coming to mechanical valves, the St. Jude region is a fantastic valve at the smaller size. If you see the EOA, it's 1.6. And when you compare that to any of the other mechanical valves, it far outperforms the other valves. Similar thing in the bioprosthetic field. If you look at in the size 19 valve, the Perimount valve does outperform all the other currently available bioprosthetic valves. So this is important because generally this is the chart that we have in our OT conventionally. This is actually provided by the valve companies. But when I went back and looked at the values provided by the valve companies, they're giving much higher EOAs, which is not correct. So it lulls us into a false sense of security that we're putting in a bigger enough size valve. But actually what we should be having in our OTs is maybe these kind of charts to give us an accurate prediction of whether the patient will have PPM post-implantation. So those who are interested, this is where I took this particular chart from. It's from the European Heart Journal in 2016. So what is the impact of PPM on survival? Yeah, it does have an impact. There are multiple large studies showing the effect of PPM, and the conclusions of these studies were that the increasing grades of PPM are associated with increased long-term mortality. Severe PPM was associated with increased heart failure, and moderate PPM, though common, its clinical significance may be negligible because the differences in clinical outcomes was small. So just quickly going through some data from our hospital. When I was just looking up, I was wondering what was our incidence of PPM. So I took number of AVR patients done for the last 7 years from 2017. The total number of patients were 399. Most commonly bioprosthetic valves were implanted. And our most common implanted valve size was the 21, followed closely by the 19 valve size. And if you look at the model, most commonly implanted bioprosthetic valve was the perimount, and the most commonly implanted mechanical valve was the St. Jude Regent. So looking at our incidence of PPM, so again just looked at 17 and 19 valves. So taken just the 17 and 19 valves and looked at the incidence of PPM. So if you look at the St. Jude region, which comes in a 17 size, we had 23 patients which we put in a 17 size valve. Only one patient had severe PPM, which is quite good, amazing for that size annulus. And if you look at the 19 St. Jude region, we had 0 patients with severe PPM and only 4 patients had moderate PPM. So this is a fantastic valve for the small aortic annulus. And if you look at the bioprosthetic valves, one surprising finding was the EPIC performs extremely poorly at the 19 size. So we put in 14 valves of 19 EPIC, and among those 11 had severe PPM. Whereas in the perimount, the 19 perimount, none of them had severe PPM, but a good number of patients had moderate PPM. So our incidence in the overall group of patients was, I'm just mentioning just the 17 and 19 size. Out of the 132 patients, 12 had severe PPM. So it leads to an incidence of 9%, but this is primarily driven by the high incidence in the 19 EPIC valve. Again, in our cohort, moderate PPM most common. 53% of the patients had moderate PPM, but again, that was driven mainly by the 19 perimount. What is the clinical relevance of this? We'll have to follow up. So how can we mitigate this risk of PPM? One is obviously a complete debridement of all the leaflets and the calcium in the annulus. Suture techniques we can modify, use non-pledgeted sutures, use simple sutures, use continuous sutures and facilitate a bigger valve being implanted. Choice of valve, again, we have multiple choices now, so ensure you can use a supraannular placement. Mechanical valves have a better EOA, so mechanical over bioprosthetic. Otherwise, use a sutureless bioprosthetic or a stentless bioprosthesis, or even consider TAVR valve in elderly patient with a small root. But then it comes on to the last and not the least, our topic of today's wet lab, aortic root enlargement. So aortic root enlargement is basically categorized into 2 types, the posterior root enlargement and the anterior root enlargement. That's based on where in the aortic annulus you make your incision. So it's divided into an anterior and a posterior root, and the most common done by the adult cardiac surgeons is the posterior root enlargement. So there are 4 techniques in the posterior root enlargement: the Nix, the Nunes procedure, which is the modified Manugian, the Manugian, and the newer procedure, the Bow-Yang technique. The Nix procedure was the first described technique in 1970, which is basically an incision made in the middle of the non-coronary sinus, just extending across the annulus, just across the annulus. The other 3 techniques of posterior root enlargement are done. The incision is made at the junction between the left and the non in that commissure. And the difference in the techniques is the extent of the incision, wherein the Nunes is exactly similar to Nick's procedure, where you just go up to and across the annulus, whereas for the Manugian, you go much farther in, you cross the aortomitral curtain and also enter into the base of the anterior mitral leaflet. Concomitant with this, you also enter into the roof of the left atrium. Whereas in the Boyang, you go into the aortomitral curtain and the incision is extended laterally on both sides beneath the non-coronary and the right coronary sinus. The anterior root enlargement is the Konno. This is more commonly performed in the pediatric patients, but can also be done in an adult patient where the incision is made to the right, to the left of the right coronary ostium. So the operative steps, I'll just skip here, but the basic setup is just like an AVR. Once you do your aortotomy, you decide which type of enlargement you want and extend the aortotomy in that direction. So as mentioned earlier, the incision is made in the middle of the non-coronary sinus, whereas in the Manugian, you go across the LCC, NCC commissure into the base of the AML. And then into that defect you sew in your patch. You sew in a patch. We'll discuss about which patch to use during the wet lab. Size the annulus, place your valve sutures, and implant the valve. The Boyang technique is a newer technique described 3 or 4 years ago, which is another type of root enlargement through the LCC, NCC commissure. But instead of the Nunes or the Manugian, you make your incision into the aortomitral curtain and then extend it on both sides beneath both sinuses of non-coronary and the left coronary sinus. So this allows us to actually put in a much larger valve because you sew in a rectangular piece of whatever material you use and implant a much bigger valve size. The Konno, like I mentioned, is more commonly performed in the pediatric population. The incision, like I mentioned, is to the left of the right coronary artery. It extends across the annulus into the RVOT, and then you open into the interventricular septum. So you are opening both the RV and the LV in this procedure. Then you patch the interventricular opening that you have created and extend that patch across the annulus to enlarge your root. And then, like the other steps of the other procedure, size the annulus, put in your valve, and then close the RVOT with a second patch. So just a quick comparison. If you do look at the Nix and the Nunes, the degree of enlargement is much less compared to the other two. You can generally go up by one valve size, but it's easier to do. But the disadvantage is that only one valve size up you can go. The Manugian, a little more complicated procedure, but you can go up probably up to 2 valve sizes, but it's more complicated. You can have mitral valve problems and more chances of bleeding. The Boyang technique, it's been reported that you can go up to even 5 valve sizes, so it enables a much larger valve. And one advantage it has over the previous techniques is that you can also be done in the patient with a prior mitral valve replacement. Problems are again bleeding, and there are some reports about the valve being tilted. It can cause problems in future for the valve-in-valve TAVI if required. And coming to the last procedure, the Konno, the degree of enlargement is something in between, around 3 valve sizes, but it's a much more complex procedure. It can be injury to the septal LED, and you can have a residual VSD. But this procedure can also be done in a patient with a prior mitral valve replacement. So what is the data on whether we should enlarge or not to enlarge the root? Again, lot of publications. Basically, the conclusion is conflicting findings on whether a root enlargement causes any increase in mortality, but all papers agree that it decreases the incidence of PPM. So take-home messages. So small aortic annulus by definition is implanting a valve size less than 23, but probably in an Indian setup, we should think of a valve size less than 21. Prosthesis patient mismatch is real, but clinical significance is only probably present when it is severe. When doing only valve replacement, choose which valve you implant wisely. And aortic root enlargement is relatively safe and cost-effective way of mitigating PPM. Thank you. across the whole cohort, it's around 5%. We've done 5%, yes.
So out of 339 cases, around 17-18 cases underwent root replacement. More in recent years or?
More in recent years.
Okay. I'm asking this question because recently in a meeting in Mumbai, I was the chairperson for narrow aortic root, and every Tom, Dick and Harry, believe me, I mean those words, students sitting on the podium, slightest chance of PPM, they were telling me, sir, we will straight away go down and widen the root. So it sounded to me as if alternate case is root widening. So wanted to know from an institute like Amruta that what is the percentage. So it's not more than 5%. Thank you very much.
Even in the literature, when I was going through the literature, like partner 3 is at a low risk trial for TAVR and SAVR. The incidence of root enlargement in the partner 3 was also 5%.
Okay, thank you.
Ours, currently we do the Boyang.
How does the PPM clinically translate? Because how many patients have real symptoms?
I've not looked at that, but I think we found severe PPM in epic valve, and most of those patients did come back with dyspnea on exertion. What happens to them in the future, we will have to follow up.
Can I make a comment, Rajesh? So one of the, more than the clinical implications we are facing now, it's that the patients who have been implanted a smaller valve with a higher gradient, they are tending to degenerate earlier, the bioprosthetic valve. That is one problem.
Whether that high gradient is due to STD that causes the PPM now, or the PPM, which worsened the PPM?
No, it was, I think, the initial PPM that is causing the, yeah.
Like PPM is defined as a non-structural valve deterioration. So the PPM leads to structural valve deterioration. Just because of the flow hemodynamics.
PPM, when will you measure?
So that's why it should not be measured immediate post-implantation, because
when at the time of
ideally what is recommended is at the first visit on review. That is when you should
first visit after a month or 3 months. When will you fix?
So the first clinical visit in your practice, ours is at 1 month. Ours is at 1 month. That is the baseline value which you should take.
Okay. Then how often you will follow up? Then when will you say that?
That's again it will be based on his clinical situation. So if the patient is completely asymptomatic, I think it will be fine to follow up 6 months or 1 yearly. Because even aortic stenosis, we do serial echoes at 1 year intervals.
So I wanted to make another comment about that difference between what they give and the chart you. So the company gives, because that's an average of all the studies, the company gives you the best one that is reported. But the average is what you said is probably the correct one. The companies always gives that best values reported.
Another interesting thing, this value, the EOA value for the 17 St. Jude region is not available in this chart. So this EOA concept was brought out by one cardiologist called Philippe Pibero. So I actually emailed him and asked him, do you have the value for the 17? So he said, yes, I have the value, but I didn't show it because we don't implant 17 valves in the Western population. So, and he said that's when we got the value for the 17 from him.
So there is no data to say which number of valves we used in India. So I checked with the company, what is the most common size used in India. Right? So they said 19 and 21 together contribute almost 67% of our sales. 19 and 21. As compared to the US, which is only 21%. So which is only 21% they use. So the morning was... So all the companies said the same thing. That 19 and 21, they contribute 65% of the total sales. So that is in India as compared to the US in 20%. As Sir was mentioning, so since that as a Poisey's law, when the valve radius is small, the gradient tends to become very high in an earlier phase as compared to when the valve size is much larger. So we see an early degeneration as compared to the Western world.
Another one, you missed a very important paper by Dr. Pradeep Narayanan published in Asian Hearts. So he has some 50 or 55 patients with 17 and 19, I think mostly St. Jude region, the incidence of PPM was almost nil. So small, even in a small patient, so the average BSA was only like 1.4 in that study. So small ladies, most of them were small ladies, implanting at 17 and 19, according to their study, there was no incidence of PPM. It's
also status, I believe, that mechanical valve is better than biological valve.
small aorta.
So, very rightly said. Similarly, sir said about the St. Jude valve. So we are using TTK Chitra valve, which has a greater orifice area in comparison to the other metallic valve. And at aortic position, there are no chances of subvalvular obstruction or preservation of leaflets. So my question was regarding the Boyang technique. While enlarging that, we are able to enlarge the root. So what are the other precautions so that the coronaries, we do have to look at the, just by doing TAVR, we have to know how high the coronaries are, they are whether 1 centimeter above or not. And are these things to be taken care of while doing Boyang technique? What precautions should be taken?
I'm not very clear.
Are the site of the coronaries important while doing
Boyang, yes. Especially the left coronary can be a problem because you're going underneath the left coronary when you extend the incision. So the bigger the valve, the more problem that you can cause a rotation of the left main. So that has been described actually after the Boyang technique.
So while doing this root enlargement procedure in DVR cases, so should you undersize the size of the mitral valve? So while enlarging the aortic valve, the mitral valve tends to come beneath and it might cause subvalvular obstruction again.
Yeah, so that's what. So in general, for a double valve, we do undersize the aortic valve a bit.
Not undersizing the aortic valve. The aortic annulus is already small. While doing DVR, the mitral valve can be, if we put a larger size mitral valve, so that tends to come beneath the aortic valve and it might cause subvalvular obstruction. So that too has to be taken care of. The mitral valve should be undersized while doing root enlargement if we are doing DVR. And similarly, the coronary site of the coronary, how high they are. If a larger valve is put, obviously the left coronary might get stretched up.
Okay. Move on to the...
just one question. You said your preferred method is Young's now. You're doing. What is the maximum size you have got enlarged?
We've only done, I think, around 5 and we've gone up by 2.
5 mm?
No, we've done 5 and we've gone up by 2 valve sizes only.
2 valve sizes.
We've only been able to we're still learning.
Because the articles say you can even go up to 4 and 5.
Yeah, 5 is what has been described as the maximum.
And have you found any practical problems? After implanting, have you found any?
So far, no. It's been too short term, but immediate post-op, no problem.
I did 3 cases. After enlargement, I thought there was a shelf which comes, under the aortic valve, and that's quite scary actually. It's like you are enlarging in a place, but there is no real enlargement below that.
And that's because actually it's collapsed at that time. Once the heart distends, that shelf will come over.
I hope so.
Yeah, it happens. So first thing is that Boyang is not an annular enlargement procedure. It is only a sinus enlargement procedure. So you are not cutting into the basal ring. So if you have to enlarge the annulus and put a bigger valve, you have to go either Manugian or Konno. So Boyang is only a sinus enlargement procedure. So
now I think we are running short of time. We will continue the discussions during the procedure. I think Dr. Kiran and Dr. Aravind can take over, and then Dr. Idris, please start with that. And while he is doing that, along with that, we will continue the discussions. Please, thank you.
So good afternoon again. So we will start our much awaited wet lab session. First will be Dr. Idris. He will be demonstrating the next procedure of aortic root widening. He will first just go through the basic anatomy of the aortic root and then start the procedure. Over to Dr. Idris.
Good afternoon all. So I thank Jaykumar sir and the organizing team for giving me this opportunity.
Camera.
Obstructing sir. Too bright sir. So, your position, we'll keep the anatomical position. Is it okay? Okay. So the aortic root is actually the most center part of the heart. So across, this is the like a tent. The center pillar is the aortic root, and then the entire structure, entire heart is surrounded by this central structure. So unless we understand this particular anatomy, we won't be able to do a root procedure in a proper way. So we have 3 sinuses. So this this is actually this commissure is the non and the left commissure. This commissure is a non and the left commissure. Front. So this is the non and the left commissure, and this is the non and the right commissure, and this is the right and the left commissure. So we have 2 different type of structures. The annular structures which is surrounding the heart here, and the other type of structures is one which is within the heart. So we have to understand both these anatomies when we are doing a root widening procedure. If you could see inside, the most important thing is the mitral. The most important thing is the mitral valve. So what I am holding is the non-coronary cusp. The mitral valve. Like light agana podu illa brightness koracha light out brightness koracha light out brightness koracha noku brightness koraki ha better ana. So this is the non-coronary, this is the non-coronary. The mitral valve starts just at the nadir, just at the nadir of the mitral valve, nadir of the lowest part of the non-coronary, and extends into the left valve here. So this entire region is the AML region. This entire region is the AML. So it starts from here, the mitral valve starts from here to here. The belly of the anterior mitral leaflet is here. So all the procedures which we are going to do may have to cut across this mitral valve. Okay. So outside, if you see, this is a non-coronary. You will have the atrium, right atrium here. From this structure, you will start having the left atrium here. That is almost from the level of the commissure. Oh, sorry, right? Okay. So almost from the level of the non-coronary cusp, we will have the left atrium on this side. All the other side, we will have the septum, the muscle part on the interior structures, on the interior. So this is the septum here, this is the septum on this part, and below this we have, this is the right and the non-commissure, below this we will have the bundle. So the septum is in this region, so the muscle part will be here. So as Dr. Kiran was saying, when we are doing the anterior root widening, we have to cut in this region. When we are going to cut in this region, we will be cut across the muscle part. We will be able to cut here. When we are doing the posterior, we will be encountering the mitral valve. Yes, sir. We will be encountering the mitral valve here. Okay. So for root enlargement, so posterior root enlargement, what I am going to talk is on the next procedure. Okay. So the aortotomy is usually an oblique aortotomy, like what we do for regular one. The aortotomy is done, and if you plan a root enlargement procedure, turn towards towards the left coronary commissures. Turn towards the left. Okay.
So Idris?
Sir?
So like suppose for your exposure of the root enlargement, would you advise to do a transection of the aorta or just extend your aorta?
No. Transect the aorta, again you have to reconstruct. Already the bleeding part will be a lot. So if you're going to transect, you will have another posterior also will be bleeding, and reconstruct again becomes a bit difficult. So without that, you will be able to do it.
So in general, you would just extend the aortotomy.
Extend the aortotomy. So this is the non-coronary cusp, and this is the right coronary cusp. Right. So this is the, you can probe here and show them. This is the right coronary arteries here, and the left coronary arteries here. So for root enlargement, first we have to remove the aortic valve.
So again, Idris, why and what patients would you choose to do a NICS, and which patients would you choose to do something else?
Okay. So when we want to enlarge the root, as one size is enough. So when we think of that, NICS procedure, NICS is the easiest of all the procedures and simplest. So whenever anybody wants to start, the NICS is the easiest procedure to start as compared to all other procedures. And then if you want to enlarge the maximum, when you see a root of around 16 and want a long-term results, a young female is there and a younger, when we want a long-term results, anterior root enlargement is the best way, where we can enlarge up to 5 or 6. As Kiran was showing, Boyang can extend up to 4 or 5 as per literature, but in reality it may be difficult because it is actually a not root enlargement, it is more a sinus enlargement, and the valves will be placed in a, there is no Boyang. So the valve will be placed in a very tilted direction in a Boyang technique. So next procedure, just one line, maximum we will be able to enlarge 1 or about 2 sizes in the next procedure. So here what we do is we remove all the aortic valve. Another important thing which I forgot is, so here always dissect out the root here. Dissect out the root in this region. In this region, dissect out the root as you do for a Bental, so that when you are extending this incision here, it will be much easier, and you have to go up to the annulus. So here the left atrium will come, here is the right atrium. So this is the division here.
So
on this side is the left atrium and this side is the right atrium.
Yeah, so whatever you worried about when you dissect in that, why do you want to dissect that area?
So if there is any bleeding point here, it will be very difficult to after reconstruction. So better to remove this part. Otherwise what happens is, see, if you are not able to cut, I'm showing you, just hold this one second. See, if you are not able to remove, if you don't remove this part, what happens when you are going to make a nick here, we may cut on the LA, even on next procedure, we may encounter bleeding. So dissect out the root a bit here. So here is a bovine heart, so the roots are actually separated. Otherwise, in a human heart, sometimes this may be adherent. So we have to remove till the root, till the annulus, as we remove for a Bental's procedure, and then we will be able to get a better exposure here.
So your concern is you might inadvertently enter into the LA.
Inadvertently, and second, and then when we are reconstruction, and if there is any bleeding point, it will be much accessible. So this is the non-coronary area. Here, the next procedure, the incision has to go in between this is one commissure and this is another commissure, and this is a non-coronary sinus and non-coronary cusp. So go through the non-coronary cusp. See, if you are able to extend here, the exposure will be much better. What Kiran was asking here. If the LA was here, it will be even more difficult for us to get a better exposure. So the annulus is here. Cut on the annulus. Can you hold it? Cut on the annulus. So once you cut here, this region is aortomitral curtain, and the aortic and the mitral valve starts here. So at this region, we are almost not at the level of the aortic mitral valve. You usually won't encounter a mitral valve in this region. So just cut the annulus here. So once the annulus is cut, the root is widened here, and then you need not go too much inside, otherwise you may injure the mitral valve. So just 1 or 2 centimeters is enough, and after that you can start reconstruction. I forgot prior. Sizer. So when we size priorly, our sizer here it is 17. Here it is 19. 19. So 19 valve. So if a 19 valve doesn't go inside, so when we are expanding, 21. So 21 is going here. So imagine the 17 valve is not going here. We have to expand to a 19 size. Here it is 21. At least we have to expand to a 23 size here. 23.
So Idris, you are planning to put a valve supraannularly?
No, it is an intravalve level. It's an intravalve level. So we have to enlarge at least 21. So our patch should be this large. Our patch should be at least this large in this region to accommodate this valve sizer. Otherwise it will become difficult. So with regards to the patch, each surgeon has a different choice. So the choices are, one is bovine pericardium patch which can be used. Other is the pericardium, native pericardium, which is stand on the glutaraldehyde. What we use is a Dacron graft. So the tube graft, Dacron graft which we take and cut it into a tongue shape and use that one.
Any particular reason why you prefer?
So we are comfortable with that one. That is all. That's a surgeon's choice. And moreover, the root is on the graft, no, it expands much better. The main concern many surgeons have for a Dacron graft is a bleeding, but we use a 5-O-proline, so we never had a bleeding problem in those regions. So here.
So the size of your tongue size patch will be basically eyeballing.
Pardon me?
The size of your patch will be eyeballing, would you say?
Yeah, that is what I'm coming to do. So this size 21, 23 kodangala. 23 kodanga. 23. No. You want to focus.
Is it a mechanical sizer or a bioprosthetic sizer?
So this is a bioprosthetic sizer, sir.
Okay, super.
Is it 21 now? 21 now. 21. 23 kodanga. So 21 was initially not going. So change the size, the next 23 or something like that. 23 size, sir. Silk kodanga. Chinna silk. Just hold this one.
Looks like it was a big pig.
Yeah?
Looks like it's a big pig if it's fitting at 21.
Yeah. So for sizing, when it is eyeballing, so what we can do is where we are going to take a suture, we can measure this one. We can measure with the silk here. So use this silk at least at this level. The patch should be at least this length. At least this length. Hey, don't check. So the valve sutures was not going to come at this annulus level. So usually when the patch is here, it will come at this point at this point where the patch is going to come. So when you're going to expand, when you're going to take a suture, so we have to take a suture at this level. So here at least the patch size should be at least this size. So this is just to avoid an eyeballing. Okay. So now the patch can be taken. So typically what they call is a teardrop patch. So this is the apex of the valve, apex of the patch. The apex of the patch will be like this, and what we are going to use the size here is this size, at least. So what we use usually 5-O-proline. 5-O-proline comes in two different needles. 5-O-proline. One is 3/8 needle. It comes in 3/8 and 75 centimeters. Other is 90 centimeters in a half circle. So 3/8 needle is much more sharper as compared to a other needle, 90 centimeter needle, which is a half circle needle. So it's more of preference. So what we use is like 3/8 needle, 5/0. Here it is 4/0 star, 5/0. 5/30. This is 90 centimeters, 70%.
Once we start suturing, should we start the second?
Yeah, sir. You can, Jai Kumar sir. So take a patch here. What we do is we fix the patch.
So this is like you're doing a continuous suture.
Yeah, continuous suture. Continuous suture. This is.
And
this
you tie the knot first.
Yeah, we tie it and then go on either side. So here. So want of time, I'm taking white bites.
How thick and how close the bite should be?
The bite should be should not take thick bites. If you take thick bites, then you are again compensating on the patch. So keep it more close and make sure it is hemostatic, because this will go, this part of patch will go below the valve, and it becomes very difficult if there is a bleeding in this region.
To control the bleeding.
Keep it very close and so take a few bites and create a tongue.
Should be careful not to catch part of the AML also.
AML will not come here. No. AML will not come here. So take a few bites and you can stop here. Actually what we do is when we are stopping, we lock it and stop here. One important thing, in one case we had, what was for a young patient, what happened was actually patient was having a left anomalous circumflex artery. So we did not do an angiogram for that, some 20 years patient. We did not do an angiogram. So when we are dissecting, we found a left circumflex artery here. So if we have not dissected this region, we might have taken a suture on the circumflex artery. So we dissected out, then separated the circumflex artery which was causing like this anomalous course, and then pushed the circumflex artery towards the left atrium and then took a suture. Sorry, sir.
So nowadays, because of the advent of TAVI, it's now in the West, it's recommended that for all aortic valve replacements before any surgical or TAVI, a CT should be done. What are your thoughts on that? Would it help in the root enlargement?
So that's what I say. Sure, you yourself commented that it's only 5% of enlargement is there. So, and it is not going to, for all the patients, we are not going to do a root enlargement. So I don't think it is personally recommended.
The advantage of the CT, actually what they say is that you can get exact measurements before you go in for surgery, the exact dimensions. So you can, at least in your mind, you can be sure of what size valve you can implant before you go in.
Our valve suture, if you find it difficult, some you can do it.
All the panel says these sounds are to wake us up.
on the patch area, we can mark 23 sizer. So, can you hold the sizer like this? Okay. See, hold the sizer here, and then mark the neoannulus. So the most important part here is the neoannulus should the neoannulus. Can you see this part? See, camera camera. See, the suture, the apex is here, but the valve suturing should come at this level. If you're again going to take the valve suture at this level, then we will not be able to enlarge the root. So this is a patch which we have placed. This is a patch which we have placed. This is a patch which we have placed, and the neoannulus is this region. So if you have any difficulty, so always place a sizer, the new sizer which you are going to place, and then mark it with a sketch pen so that you will be able to take a suture at that region. Otherwise, we usually tend to place a suture at much lower level so that we will not be able to enlarge the valve once again, enlarge the root once again. So valve suturing, valve sutures.
One more point probably, this is probably easier if you use the valve replica side when you mark the level. Rather than the intraannular part, if you use the other end, you can mark it more accurately.
So what happened? You can use this. You can use like this, as was Kiran was saying, and measure it. Okay. But the most important thing, this has to go inside, and after that you should be able to measure.
Correct. That's the thing.
So here what happens is, we tend to tilt it. If you place it like this, we are going to mark it here. If you tilt like this, we'll be marking it a higher position. If you're using without experience, we'll mark at this position the neoannulus.
Is it a Hancock sizer?
So Jayakumar sir, what size is it? Flamingo sir. Flamoro sir. The valve suturing is very similar. No, yes, sir, that area. That's it. So here we have to take a regular suture like this. In this particular region where we have put a patch, what we can do is we usually come from outside. Same suture, sir. Same Ticron suture, sir.
You are using pledgeted sutures, right?
You are using a pledgeted suture.
You always use that.
You always use pledgeted suture. So we come from outside. The pledgets are placed outside.
No, a patch.
From outside the patch, sir.
Kiran? So this is a supraannular placement, isn't it? Yeah.
The supraannular, sir.
Daffodil valve.
The Dacron graft in this region will have some amount of meat in this, so that taking sutures usually will be much easier. For suturing of the patch to the aorta, the bovine pericardium will be much better.
Can I ask a question? Basically, I'm just wondering, because if that whole point of doing this is to put a one size...
Not able to hear you, sir.
If the whole point of doing this is to increase the size by one size, can't we do that by just putting the valve in switches from outside the aorta with a slightly angled, I don't know, you know what I mean, with the non-coronary side of the annulus being, which is taken from outside the aorta, you can actually get one size bigger anyway. So do we really need to do this?
It's correct. No, probably this is a little more safer, probably, because you're actually enlarging it a little bit and fixing it properly. That one is, I don't know, physiological.
The enlargement is marginal, and secondly,
that is all.
you are putting pledgeted stitch from outside. That's what we do when we put the
we tilt the
valve in
valve,
oblique
yeah.
way, isn't it?
Correct.
So once the sutures are placed, all the sutures are placed here, then the entire suture layer, so entire sutures are placed. What you usually do is make sure this proline is slightly above, this proline suture line is slightly above the suture line which the valve sutures which you have placed. Because once you seat the valve, you will not be able to take any suture here. So at least a 2 or 3 suture, create a neo aorta using this patch. So create a cavity like this, same thing on both sides, and then you implant the valve. Because once you implant the valve, we lose another 2 or 3 mm from this patch also, from the annulus level. So it will go inside from here it will go till here. So you won't be able to take a suture. So better to take a suture, create a neo aorta and then implant the valve before. Otherwise, if the bleed starts bleeding, we won't be able to see anything in that region. Just a valve unda valve illa valve work.
While Idris is taking the sutures, we will move to Dr. Manoj, who is ready with the Manugian demonstration of Manugian procedure. Over to you, sir.
Camera, should we switch to camera?
So my task is to demonstrate the Rittenhouse Manugian procedure. So my task is to demonstrate the Rittenhouse Manugian procedure. The NIC procedure was first done in 1970. So this Manugian procedure is 9 years older. That was 1979. And before describing the procedure, I want to tell you a simple procedure where all of us can get away when there's a small root. That is, we can use the normal bulge of the non-coronary sinus, especially many times you can put one valve ahead, especially a mechanical valve. If you can take the sutures intra-annularly onto the left and the right coronary, and you can take plungers outside onto the non-coronary bulge. So you can keep the mechanical valve, the tilting position, and many times you can get away that. I think we should, and you can always put one size ahead in such situations. So even with NIC procedure, it's actually, NIC procedure might have evolved from that particular thought. So the primary difference of the NIC and the Manugian is, Manugian we are going through the intercups triangle that is between the left coronary and the non-coronary. You cut across the mitral aortic continuity, you open the roof of the LA, patch the LA, or sometimes the LA roof can be sutured onto the patch, and you widen the mitral leaflet, you patch the mitral leaflet, come back to the annulus, and then it's completed like a NIC procedure. So that is the basic difference. The advantage of the Manugian is you can have two sizes ahead. The disadvantage is if the NIC procedure bleeds, you can go on bypass and put a suture. But if the Manugian bleeds, especially from the root, you have to give cardioplagia, arrest the heart, and do it. So that's and regarding the mortality of root enlargement, it's not as a small procedures, because there's a mortality is around 7.9%. If an isolated aortic valve, where it's less than 2%, the Western literature, the Cleveland literature says the mortality with a root enlargement is around 7.9%. So it should not be taken that lightly. These are major procedures. The initial steps are almost similar. So what we do is identify the orifice of the right coronary artery, and the aortotomy is made 12 millimeters flat to the origin of the RCA, like the classical aortotomy. So the incision is taken transversely, then obliquely, posterior-inferiorly, and then we continue it towards the commissure between the left coronary and the non-coronary. So here The video is on? The video is on. So this is anatomically the heart has been placed like this. So this is the, you can see the right coronary here. So this is the right coronary orifice. And you can see the left coronary orifice here. So this is the left leaflet. This is the right one. And here you have the non-coronary. So we'll make the incision first. Incision is as a toe, it's taken transversely, then taken posteriorly. And you have to cut it. And you're cutting it between the
Here also, sir, you have to dissect the root first and separate the LA roof from the aortic.
Yeah, here it's very important. What I do is I usually gently pack with a gauze piece. It really helps. And as you, in especially human heart, there is a yellow tissue, the areolar tissue. You gently pack it with a gauze piece. The LA roof will separate away. And the aortic, once you clear this tissue, the aorta separate by itself. That's very useful, maneuver. And I liberally use stay sutures. So you'll be dissecting the LA roof from here gently. And try not to open it now. Because this we are going to electively open at some stage. Like we do in a bendal procedure. Sharp scissors. Always use sharp dissection. And any small veins bleeding, you should control then and there. Don't wait for the cross clamp to be released. Yeah, this is a very avascular field. You never get in real life. Now I have reached the, what I do is I take a stay at the annulus straight away. Where when I cut the aortic annulus itself, I take a stay. And as a rule of the thumb, the patch, the widest part of the patch used for a Manugian procedure is 4 centimeter. It should not be more than double the incision you make in the anterior mitral leaflet. Whereas the nick procedure, usually the patch will be 2 centimeter wide. You have to make a teardrop or diamond shaped patch of 4 centimeters wide. So this really helps. And now you can see the anterior mitral leaflet. I'll be cutting onto that. Now see, I have opened the roof of the LA. The LA has been opened. And LA can be further dissected away. You can see the roof have been widely opened. And some people even have aggressively gone up to the free edge, where you get around 5 millimeter of expansion. Now the procedure is almost the same. You have to, the few points to be taken home is, when you repair the defect in the mitral leaflet, take interrupted stitches. Don't take continuous sutures. Close interrupted 5-o-purulin stitches. Take it and seat the patch well. Because even if it bleeds, it will bleed into the heart only. Don't worry about it. Only from the annulus it will bleed outside. So you can take, you can now fashion the patch.
So which suture material do you prefer for the Manugian?
5-o-purulin. I think my personal experience over the years is the finer the suture, better will be the bleeding. But textbook describe even, projected, trio-braided, and especially old Kirkland and all, but I think I use fine sutures. Dr. Kaushal Pandey, he uses 6-0 proline for aortotomy closure. He was mentioning in one of the meetings. Can I see the patch?
And patch he uses bovine pericardium?
I use bovine pericardium. Most of the time I use bovine pericardium. The patch again should be a teardrop patch, the maximum width of 4 centimeter, and fairly an upward portion should be diamond because we never know the aortotomy how long it will reach.
I think by the time Dr. Manoj takes the patch gets ready, I think Idris, you can finish showing what you are planning to do finally. This one, please. Yeah.
No, the camera.
This will be the final appearance. So the patch should cover the sinuses also. The patch should be covering the sinuses also. So the valve will be somewhere here. Forceps system. Forceps. You could see here, this is the pledget which we have placed for the valve, and below this is still the patch is there. That has enlarged the root. So our patch is here. So we won't be able to access this part. We won't be able to access this part once the valve is placed. Becomes stiff. So our valve sutures are here, and this is the enlargement. Here it will come usually like a triangular patch like this, and then we can close the aortotomy site. So these two sutures we can continue up to this angle, and we can take one more suture from this side of the aortotomy site, come here and tie in the middle. So then it's the usual cross clamp release and same thing. Okay, thank you, sir.
Idris, thank you, Dr. Idris. I think we can show that Dr. Manoj's side again. Yeah.
So I put the stay sutures where the annulus has been cut. Can I get the patch?
So this patch is going to be a single patch or two separate patches?
No, I always patch the left atrium separately because there won't be any tension in the anastomosis. I don't have a huge experience. I think I was recounting, I'd done 11 Manugian. Fortunately, all of them survived, but few of them gave troublesome bleeding. So the widest patch, the widest part of the patch should be around 4 centimeter, 3.75 to 4 centimeter, and this will come under the annulus. Interrupted 5-0.
In both these techniques, since the valve is seated in an oblique plane, is there any tips to safeguard the coronaries? Because some of these cases, coronaries are very close to the annulus. So if you tilt the valve won't it cause some coronary problems?
Manoj sir, there was a question about whether, Manoj sir.
But still some patients can have abnormal origin of
Rajesh, can I? I'm here. Yeah, I do a lot of valve being tilted this way. So what we do is all the annular stitches in left coronary and the right coronary goes into the annulus itself. And then only in the non-coronary combustion on the aorta we take the projected suture from outside, just like what is written down. So I never had a problem.
This obstruction of coronary is more common in the Boyang. More common because when we Boyang technique, sir. Boyang technique. The Boyang actually when we expand the sinuses, we go up to the left on this side and go up to the bundle office on this side. So when we try to place a bioprosthetic valve, what happens is that one of the posts will be almost cover close to the left coronary ostium. So Boyang has that problem. So that is why when you are placing a valve in Boyang, it becomes very difficult. And it is actually there was actually not a true enlargement. And when after placing the patch, what happens? Underneath the valve, there is a small shelf-like thing, always in Boyang.
Why can't you place the strut in the center of the Boyang?
What we place there, another stent will come almost near the.
Other strut are at the commissures.
No, yes, sir. But the valve will be tilted in this way, sir. The valve will be tilted in a very peculiar way in Boyang as compared to the other procedures.
And that problem has been described when you go enlarge more. When you enlarge 4 valve sizes, 5 valve sizes, when the chance of left coronary obstruction occurs. So, more aggressive route enlargement. Yeah, it's not actually because of the valve obstructing the orifice. It's because of the tilt causes a torsion on the left main. The main left main gets torted out angulation changes. So that angulation is like a kink. The left main up. So it becomes like a kink on the left main. It's not actually the valve obstructing the ostium.
Mechanical valve, when you are placing the Chitra valve, the lesser orifice should not be on the patch side. Because the disc which is opening inside will go into the patch area. Shelf is very scary. Very scary. So if you place a larger disc on the shelf area, in the non-coronary area, it will not be a problem. You can place it in another direction.
The same problem happens for the St. Jude valve when you do a Boyang or any root enlargement. You have to make sure that there's a part of the housing that goes intraannular. So you have to avoid that shelf area when you place that intraannular plot. So you have to rotate, make sure your intraannular plot is away from the shelf.
All bi-leaflet companies claim the leaflets move within the housing. They say the leaflets move within the housing. So if your housing goes inside, not to worry. A small mistake, technical, the valve measuring should be first done with a cylinder. And then should be the supraannular measurer which you use.
That's what I think.
So first is cylinder, which tells you the interannular distance. You straight away started with supraannular.
No, I started with the cylinder only, sir.
I didn't see. I must be chatting with Sri Krishna that time.
I think Dr. Manoj is doing that pericardial suture. I hope it's from the mitral valve. He is going on to the aortic margins. Can you just show the way in which you are going to do the suturing so that we will start off with the other?
Yeah, I use the continuous here for convenience, but ideally it is interrupted.
Can you just show the line of suturing from the mitral valve to the aorta, how it goes?
I finished one side. You can see from the apex of the mitral. I did not reach up to the free edge. I reached only 2 centimeters into the mitral valve, anterior leaflet.
Yeah.
I come up to the annulus, and I always kept already I have kept a stay here.
So now, can you, with the forceps, can you show the suture line which you are planning from the mitral valve towards the free edge of the aorta?
So this is, the second layer is almost getting over.
So by the time Dr. Manoj is completing that, shall we move on to Dr. Shaji? Dr. Shaji, please, are you ready?
Yeah, hello. So, can you see that our heart? Yeah. So, actually for ease I am putting 3 stay sutures into the commissures. This is the LCC, NCC commissure. I am placing a stay suture, second stay. This is into the LCC, RCC commissure. Length. Put it here. Artery.
Dr. Manoj, there is a question, like you said you are taking continuous for the demonstration purpose. Are you taking interrupted all the time, Dr. Manoj, for the Manugian? For the Manugian,
one second. I finished the suturing of the mitral valve. You can see the patch seated to the mitral valve, and you can see the gaping hole in there.
Please switch the cameras. Please switch the cameras.
So now as again, like Idris described, you should position the valve. So you can see the valve almost 3-4 plunget size, it has been enlarged at the level of the anus. You can see that.
Okay, perfect.
You can see that there is a wide, it's almost like 3 centimeter enlargement of the where the sutures go. And I always take the stitches from, because the valve has to be intra-annular, I'll always take the valve stitches from outside in. And here also I'll take the stitches outside in. I'll mark with a marker pencil and I'll be putting the stitches. And this will now continue onto the aortic wall to complete the anastomosis.
So how far into the mitral valve do you go? Into the
I
mitral
went
valve?
almost 2 centimeters now. This was very big anterior. But in adults, human beings, we don't many times put that big a mitral valve. So you can see that, you know, the widening has been, can you focus it here? So this much increase in, you know, this area will be sutured with the, and now I'll close the aortic LA orifice because otherwise it will be difficult to suture it. I will put a separate patch and close it. Some people will suture it to the patch itself.
You do it before putting the valve or after putting the valve?
I do it always putting the valve, because before putting the valve, because it's much more easy to visualize. Once you hard structure comes there, no, it is very difficult to retract there.
And do you complete the aortic suture line before putting the valve, the entire up to the free
No,
margin?
no, no. At this stage itself, I'll close the roof of the LA. Then I'll take the valve switches, and then I'll complete the anastomosis with the valve. I'll always put 2 valve switches already at the edges where the aorta annulus has been cut.
Okay. So can we, by the time Dr. Manoj is going ahead with the suturing, shall we have the other camera? Dr. Shaji, please.
Small patch.
So we have taken 2 stay sutures, one into the LCC, RCC commissure, and second into the...
Shaji, your hand is coming in the way. Can you just adjust it? Yeah.
Into the RCC, NCC commissure.
I think your hand is coming again. You can just adjust your posture to one side. Like that's perfect.
Is it okay?
Yeah, that's fine.
So now we are cutting the valve leaflets. Now I am cutting the right coronary cusp. I am cutting the left coronary cusp. And the non-coronary. So, in NICS, we go midway into the non-coronary cusp. In Boyang, it's similar to the Manugian technique where we cut open into the
left into the commissure between the left coronary and the non-coronary. We go beneath the annulus and then put a inverted Y sort of incision and go underneath the aortic annulus. You have to have a close watch on the left coronary ostium, and then you just stop short of the left coronary ostium. Similarly, you go into the non-coronary around midway into the AML and stop short there.
So Shaji, how far below the annulus are you going?
It's up to the trigone you go.
I went from the annulus, how deep inside the aorta?
Just beneath the annulus. Up to the trigone you go, and after that you reach the septum. Stop there, and then you open. You see the difference. You see the difference how widely it is open. So this is the width we got by the Boyang technique. So now we measure this distance with either a forceps or a scale, and then maybe this is around 2 forceps length, and cut a rectangular patch. So I use a Dacron graft, and then
you're supposed to like the next.
Yeah, it never gets open.
You have to separate it out.
So this is the patch we use. Hold it. Then we use a 4017. If the aorta is very thin, we will go for a. Can you get 2 stay sutures?
So one doubt that you are saying subannular extension. Subannular means that is into the ventriculo-aortic junction, or through the annulus only you are extending?
It's just below the annulus.
Below the annulus or in the annulus?
Below.
Just below.
Just below the annulus.
Just below
the annulus. That is. Continue.
In the
continue.
Correct.
Sir, suppose we measure that and we find that it is 3 centimeter. Then how much will be the size of the patch that we use?
We actually measure. We open it up and then measure the length.
If it is 3 centimeter means you will have to oversize it. How much? Little bit.
No, just little bit more. That's all. So we start suturing from this left edge and then start suturing.
What is the suture material which you use, Dr. Shaji?
Yeah, we usually use a 4017 mm needle.
And Shaji, you prefer this graft, vascular graft or pericardium?
What?
Do you prefer the graft, vascular graft?
Graft. For Boyang we use the graft. For Nix, I don't do Manugian. For Nix I use bovine pericardium. And for Boyang I prefer Dacron graft.
Any particular reason?
Because I need a good widening, I think this is better. And the classical teaching is also like that. Boyang advocates.
So you parachute the Dacron graft. Don't fix it and come.
What?
You parachute the graft, or you fix it and then go on either side. The suturing.
Yeah.
Here I see
3-4 bites and I parachute.
3-4 says you parachute and then go down.
Yeah. I will go down now. Yeah. Then release it there. Hold it here. Okay.
So you're not worried about getting into the LA at this point while you're taking these sutures?
No, it never goes into the LA because we are not going into the AML. We are staying just beneath the aortic annulus.
have you found any difference when you use the Bow-Yang, when you implant a mechanical valve or a tissue valve? Do you find it any different? When you do a Bow-Yang, is there any difference when you implant a mechanical valve versus a tissue valve?
No, I have found difference. I don't have extensive experience. We have done a very few cases only, but I don't think there is a difference between mechanical versus tissue valve in such scenarios.
No, there is when we are using mechanical and bioprosthetic, mechanical has to be placed, because as we are discussing, mechanical has to be placed in such a way that the disc movement does not obstruct the patch.
So it's not really a contraindication. The only thing that you have to do is see that the line of this thing is at the zenith to zenith. The sewing
so now we have
the sewing rim has to
up
be
to the
zenith
middlemost extent, and now we are
so the part of the patch has to
going
be
into the ascending aorta.
I think Shadi, you can show the line of suture, and meanwhile I think Dr. Manoj, where are you? We will see the other one. Can you switch the cameras? Can you switch the cameras? Hello, there, Manoj, Dr. Manoj.
Hello. Dr. Manoj has finished. He will just show you this hole.
I think if I taken the patch across the aortotomy, has almost finished the aortotomy. Now I can tailor it. Now there is no aorta left to suture, so I am stopping it here. So the LA roof, I close it directly to the patch here. I use continuous suture to prevent it, to make it faster. And I think fairly 3-4 plugget, almost 3 plugget with extra. I think improved by around 2 sizes easily.
So if not in this case, how do you close the LA wall, sir? As an interrupted suture, LA wall?
No, this case I directly suture to the patch. But usually in real life, I always put a separate patch.
Separate patch
for the LA, because LA will fall away.
Okay, you separate patch from this patch to the LA wall?
No, I take a small piece of patch and roof the LA.
Roof the LA. So that you do after enlarging the root?
Enlarging, that's the first step I do after the attaching the patch to the mitral valve.
Okay, sir.
I'll use
Right.
2 sutures there.
2 sutures, okay.
Yeah.
So when you place the valve suture, you place the pledget outside or inside? How do you place?
It's always outside.
Outside the pledgets will be outside the patch.
I want the valve to be intraannular in all rootal arteries.
Okay, so the pledgets will be outside the patch.
Outside the patch.
Sir, since there is a mitral valve morphology here, sir, mitral valve morphology is changed because we are patching it. Does that reflect on to hemodynamic performance? Is there any problem with mitral regurgitation or anything?
That is the reason interrupted stitches, separate interrupted stitches for the mitral valve. Usually it doesn't affect. Because the problem of putting a undersized valve is redo surgery will be difficult. The coronaries will get drawn to the valve. So it's technically there are a lot of bleeding and coronary issues will be there in the second surgery. So this actually takes care of that.
And how much can you safely cut into the mitral valve? 2 centimeter or?
People have gone up to the free edge and repaired it because now they are doing extensively reconstruction of the mitral valve. So only in the clear zone, correct. Even there are reports where people have gone up to the free edge of the mitral valve and patched it. But only thing use interrupted stitches, simple interrupted stitches, close interrupted stitches. Even if it bleeds solely into the heart.
Thank you, Manu sir, for the excellent.
Yeah. I think Dr. Manoj, can you just show the suture line where you will be taking? Will you with ink, can you just show the suture line where you are going to take? Camera 2, yeah. With ink, with that ink, that marker pen, can you just show where you will be taking the sutures? For the aortic valve.
So this is the mitral valve. You can see the suture onto the mitral valve. And this, I think I already have drawn it. So this is the area where the, edge to edge from where I cut the annulus. and I'll size it with a replica, proper replica of a valve.
Right. Thank you. I think we will move on to Dr. Shadi. I think he has almost finished putting the triangular, the rectangular graft. Now, can you just go on, Shadi, and show your marks?
So this is the completed widening procedure done. So this is the area which we have widened out, and maybe I could get some more than 3 valve sizes extra. So this is a very small annulus, and I will see with a 21 sizer now. So it will be so this would be like, it will be sitting like this. So we'll go well above the previous annulus, and then we'll mark it with
your left hand is obscure. Yeah, thank you.
We'll mark the area with a...
Shaji, it was not very clear with sizer. Can you show again?
So we don't have all sizes, and it's a different company sizes are available. This is actually 21 sizer that's going in freely now. 21. Okay. I think 23 will go smoothly in this patient now. 23. So we'll take the valve sutures and then check again. And skin marking pencil.
I think we are just running short of time. Can you just show the valve suturing line with that? Yeah. So that will be sufficient, I think, so that people will get in. Yeah. Great. And how will you go down it onto the left coronary, means without avoiding without injuring the coronary, left coronary?
Yeah, we have to closely observe the left coronary ostium and never go into just beneath the, stop short of the left coronary ostium.
Can you move your left hand? Can you move your left hand? Left hand. Yeah.
So this is a conventional suturing in the annulus.
So shall I suggest that you can mark it with the pen?
Yeah, already marked. I am planning to take
into the
coronary.
Right. Okay. Fine.
So this is actually just after that a transition stitch into the annulus, normal annulus we are taking.
Dr. Shaji, can you keep a replica and show how close the post is towards the left coronary ostium? There was a question in the floor.
I didn't get the question.
Can keep the replica and show how the post is towards the coronary ostium. The replica. With the neo annulus level. So that the tilt, yeah. The neo annulus. Can you remove your left hand, yeah. The neo annulus has to come up, no, slightly.
Yeah.
Like that. That is how that post will be obstructing the coronary artery. It will come because this is a smaller replica. With a bigger replica, that post will be very close to the ostium.
Last week I was with Boyak. What he has told is to avoid that. When you take the line of the patch, don't take a linear line. He actually tells take a curved line. We tend to think that we will go straight across.
Come from outside
A to point B, but he says take a curvilinear patch.
Outside, blood will come outside.
Yeah, but when you are putting it now on the patch, he tells go in this manner. Don't go linear. Don't go like this. Go in this manner. That creates the space for the gap for the. No, convexity going up. So the the transition patch is transition from the patch to the aorta is down and then climbs up and comes down again.
Green.
So now your left main is sitting here. You are actually going.
Ready? So shall we start with the fourth one? Okay, this is it same now? Can you? Yeah, shall I? So this is the fourth one, the Konno raster we are going to demonstrate. So you have this is the aorta, this is how the RV outflow goes, and this is the pulmonary artery. and say I'm passing the forceps through the right coronary. This is the right coronary. I hope you can see it. And say this is the left coronary. I hope you can see it. There's the left coronary. So what you do is the usual aortotomy. Only thing you have to develop this between the aorta and pulmonary artery a little bit, and then the usual aortotomy is done. I'm just cutting it little short than usual, just 2 millimeter or 3 millimeter from the this thing. So partial aortotomy, that's enough. Now you identify the right coronary. Just to the left of the right coronary you have to go. So I'm just cutting away the leaflets. Okay.
So from here,
there's no light.
We'll go like this.
Put the light on. I think. Is it same?
Like this.
I'm just cutting up this thing. Coronaries. Yeah. But I think it's seen there, no, very well.
Camera on the center. Camera on the center of the screen. Oh, yeah.
Okay, fine. That's good. That's good now. Now, say, just hold it on. Now your idea is to cut it down to the left of the right coronary ostia, up to the aortic root first. So
do you look for any conal branch or any those kinds, sir?
Pardon?
Conal branch on the RV?
Yeah, definitely. Means before going, we have to make sure that the coronary is not crossing and no significant branches there.
Any septal branch also, sir? Any septal branches?
Yeah, that is something we are cutting into the septum. So we have to be very careful and limit your incision. So I have reached up to the annulus here. Now the next thing is opening the RVOT. Get me a right angle or yeah, that one. So if you are not very sure, because many times the pulmonary valve will be much lower than what you anticipate, and if you just blindly cut, sometimes you may land in injuring the pulmonary artery. So better to put a right angle, open the PA and put a right angle like this, and make sure where you want to incise in the RVOT, because sometimes you may go very knife. So I cannot see it very well, but still I feel it's here. So I am just opening the forceps. RVOT, the free wall here.
So you palpate, go below the annulus and then open up.
Yeah. So once the RVOT is opened like that, can you see that?
Yes, sir.
Can you see that?
Yes, sir.
Yeah. Then you can reach it up to the aortic rim. So can I get a stress suture? 2 stress sutures. So it's better if you can put stay here and put it here. Another one.
Second, just tell what the anatomy is here at present, sir. Just whatever is it, sir.
Yeah.
The inner part is septum.
Yeah.
Before cutting, the anatomy alone, sir.
Anatomy?
Anatomy, what are we going to cut? When you are exposed to now, just show the muscles, different muscles, sir.
So this is the interventricular septum which is seen. It's a big heart, it's a very, very thick septum we are seeing. And this is the RV free wall, and this is the aortic annulus. And we have to reach up to the annulus from the RV free wall also. So you are here. Okay. So you have cut the free wall, the aorta up to the annulus, and then you can just go into the septum. And when you are going into the septum, rather than cutting it to that side, I just keep it to this side. The light is gone.
The light is gone.
Please. A light in a loose condition.
You are angling the scissors to this side to avoid the septal branch of the LED.
Yeah. Instead of curving the scissors to the other side, curve the scissors to this side. You just see the light.
Light.
This is a very thick interventricular septum. So I think the LV is huge. Yeah.
This is this thick, okay?
Yes.
So normally we cut, let's say 1 or 2 centimeters is more than enough for that, okay? You can see that? So even this much is not needed because very thick I put it like that. Now, get me a pen. So now you have opened the LVO, the interventricular septum. You are worried about the septal always, so I keep it little bit to this side. And this is the RVOT and the ventricle open. Make sure that you have not injured the pulmonary valve. Now the next step is to enlarge the aortic root. So ink that pen, ink pen. Just hold it like this. Hold it like this. Hold it like this with other forceps. So your suture line will start at the apex of the interventricular septum like that towards the RV side. Towards the LV side we may not get that much of enlargement, and then you suture it across and reach up to the aortic annulus here. So this is how you take the suture with the patch, and then take the patch onto the free wall like this. So get me free wall. So this enlarges the aortic root. The 25, 23 or 23.
So a patch from the interventricular septum onto the annulus and then to the aorta, sir.
Aorta, right. So say this is what says. So you see that this is the normal size which he is going to have, but if you take the maximum size, this is what. So with a anterior root enlargement, you can see such a big size. I don't know. This is 27. So you can now assess how much you want, and then accordingly you just take I usually enlarge it with the pericardium. Fresh pericardium I use, not the glutathione preserved, and then start from there with 40 Prolene 17 mm needle. First start with the projector suture and hold it down with the projector suture and go on to that suture line and hold it. And once we reach beyond the annulus into the aorta, so I can stop the suture line and then say make the markings and then take the sutures. Here actually the RVOT has to be reconstructed with another pericardium. So what I do is, rather than going from outside in, the same pericardium, if it is good and they saying, you can take the usual say inverted sutures from out, down up like forceps. So suppose this is placed like that. Take some sutures with the I don't use plunges for the aorta. So from the LV side to the aorta, you can take the sutures. So that will take care of the valve sutures. Then, so you have a free area here. So the pericardium is used to close this, because into the epicardium you can suture very comfortably. And only thing, this junction where you come down, you have to make sure that you are closing the RV properly. So your one pericardium will be going into the aorta, the other pericardium will be going into the RVOT, and the junction between these two, if you don't close, the RV will be pumping out. So you have to be very careful about that. So this is 40, this is 40 or 50 most of the time. So and then this sutures are taken, and you can complete the procedure. So since time is running short, I am not taking the sutures. I think it's clear what I have told, and we can discuss.
Can you just keep the other patch and show for the demos for students, sir? Don't need to suture, sir. Just show how the second patch will come. Where will the second patch?
Second patch, yeah.
Just keep it and show, sir. Yes. Where will the valve will come?
So this is the patch and the valve. Now the second patch I will show you, right.
Just keep it and show, sir. Sir is using two patches, sir. Double patch.
Yeah.
Patch. Same patch, understood. So, that is the second patch for the RVOT, right, sir?
Yeah, the second patch will be coming like this. Okay. So I think what sir was telling is like you can fold it like this. So you take a bigger one, fold it like this, and then suture it into the myocardium just like that. So once you reach here, you have this going out onto the RV side.
RV side.
And the other one will be going into the aortic side.
Yes.
So that is single patch, something like a butterfly, we can suture and take it. So both ways it's possible. Shaji, anything? Shaji, you are completed? Anything else to say? Yes.
So I have taken the sutures in the patch from outside in, and there is a transition stitch here, and then into the under the left cusp, and this is into the right cusp. The other sutures I have not taken because that's no routine. So this way we can enlarge the annulus by more than 3 sizes. So initially now the 23 sizer is going 23 sizer is going very smoothly. Actually we didn't size the so 23 is very comfortably going. You can even put a 25 here now. 25 you have? So 25 also is possible here. Okay.
So since we're running short of time, any last questions? We're running short of time.
I think it was an experiment. Means I was very much worried about how it's going to go, but I think it is done wonderfully. And really thank the Johnson & Johnson team who helped us. Then our MPI, the Meat Products of India, they have helped us, and along with the entire theatre team, they are here fully. The department, thanks to each and everybody who was really, and of course the audio visuals, Mahadevan. Thank you.
Hello. Sir, he is taking a felt strip around the neo-annulus outside the diaphragm graft and taking the valve sutures on the felt strip. Will it strengthen the neo-annulus? Taking a felt strip on the neo-annulus outside the diaphragm graft. Taking a Teflon felt strip outside the diaphragm graft.
Diaphragm graft, like what Shaji is doing?
Outside the diaphragm graft, sir. Taking a Teflon strip outside.
Yeah.
And taking the sutures outside, from outside to inside on the felt strip. Will it strengthen the neo-annulus?
Yeah, it will definitely, but it depends on, but your pericardium is really good. If the pericardium is really good, fresh pericardium I use very comfortably, no issues. But if you have any problem or if you feel that not comfortable, use a felt. It is surgeon's preference. Okay.
The wet lab sessions will be starting at the conclave upstairs. Thank you everyone for such an amazing thought-provoking session. Next, moving on to the next session. Advancements in surgical techniques and technology have revolutionized the treatment of valve disorders. But mitral valve often takes us through perplexing situations which can be a nightmare for a budding cardiac surgeon. We have experienced faculty talking on different scenarios in surgical management of mitral valve and their solutions. We are also fortunate to have an insight into the trans-esophageal echocardiographic tips to guide the mitral valve repair.
Let me welcome the chairpersons onto the stage to commence the session. Dr. C.S. Heramet, Secretary IACTS, Senior Consultant and Chief Cardiac Surgeon, Sri Satyasai Sarla Memorial Hospital, Karnataka. Dr. Lokeshwara Rao Sajja, Senior Consultant CBTS, Chairman of Sajja Heart Foundation, Hyderabad. Dr. Anil Jose, Senior Consultant, Mitral Hospital, Kozhikode, Kerala.
Assembly. We'll call her. Yeah. I request the first speaker to come down. Mitral annular calcification, how to tackle, Dr. V. Devaguru.
Good afternoon. I thank Dr. Jayakumar and Dr. Vinita for this wonderful opportunity. It has been a great success so far. I really like the live workshop they had conducted now on wet lab. Now we'll move to some serious discussion on complex mitral valve surgeries. One of this is mitral annular calcification. If it is small, most of us will handle, if it is small, it is very localized to 1/3 of the posterior annulus, and we quite often come across it. But if it's significantly calcified, then it's quite a tough job to treat. The mitral annular calcification is a chronic disease which happens because of calcification of the posterior annulus. Most often, the risk factors is similar to what we have in all the risk factors for atherosclerosis. And what is the incidence? The incidence from the Framingham study, around 5,600 patients were seen. The incidence in that normal population was 2.8%. When you analyze further, the incidence increases to more and more if you go beyond 60 years of age. And when you cross 80 and 90, the incidence is nearly 20%. The risk factors are one, age, as we said. As the age progresses, the incidence of mitral annular calcification increases. And it's more common in women. And also it is more common when there is a chronic renal failure. So what is the pathogenesis of this? It can happen with the mitral valve disease, or it can happen in a normal mitral valve disease. If there is mitral valve disease, as we can say, if patient is having a prolapse, then there is stress, increased stress, and that leads to some defects in the posterior annulus, which starts helping in the initial formation of the calcification. Similarly, when we have degenerative disorders like Marfan's or Ehlers-Danlos syndrome, there is some deficiency in the proteoglycans, which can lead to stress and increased fracture, and then similar process happens. If you have a normal mitral valve, there are some factors like happens atherosclerosis, hypercholesterolemia, age, and sometimes if there is a forward aortic stenosis, that can also produce mitral annular calcification. It has a preponderance to stay mostly towards the posterior annulus. 77% of them is most often in the posterior annulus. Once it forms, again there are some factors which allows it to progress. One is chronic renal failure, or sometimes some metabolic disorders in calcium and phosphorus. There are ways of classifying the severity. One is to call it mild when only 1/3 of the posterior septum, P2, is only involved, and less than 1/3 is involved, then it is P2, that most often we get. Then is moderate when we have involvement of 50% of the circumference, up to 50% of it. And beyond that we call it severe, when you have a calcification beyond 2/3 of the septum, or 50%. There is another classification which is more helpful when you are planning to do intervention. That is called, if you have the calcification more than 270 degrees or less than 270 degrees, that is type 1. And again, when we can predict, if you put a valve, transcatheter valve, if it is going to have LVOT, then it is type 2B. So there are two. One, this is presently, the present classification is based on interventions, cath lab interventions. What all things can happen if you have mitral valve annular calcification? It can be asymptomatic without producing anything, or it can just produce AF. Atrial fibrillation is 10 times more common in mitral annular calcification. Or it can produce endocarditis. Or significant stenosis can also produce MS, or sometimes it can be present along with defective mitral regurgitation like Ehlers-Danlos loss or Marfanson, we can have a posterior mitral annular calcification. Then how do we deal with them? If it is mitral stenosis, then this is the chart. First we have to see if it is patient is severely symptomatic or asymptomatic. If the mitral annulus is orifice area is less than 1.5 centimeter, then look at whether they are symptomatic, non-symptomatic. When they are severely symptomatic, then it indicates an intervention. If they are not severely symptomatic, asymptomatic, then we will have to modify the comorbidities. This is one approach. Once we have decided to intervene, what exactly are the options? One is to have a repair. If feasible, we can have a repair, or if required, we have to replace. And the third option, if the anatomy is not suitable for repair or replacement, then there's options of interventional catheter-based techniques are there. In catheter-based techniques, either you can do percutaneously, or sometimes we'll have to do open technique, in which we'll open the, surgically you'll open, instead of decalcifying, you put a transcatheter valve in place after debulking the anterior leaflet so that the LVOT doesn't get obstructed. This is one of the things opted if we are feeling the left ventricular outflow tract is going to come in the way when you are doing a percutaneous. Then surgically we can put a transannular valve. As for mitral regurgitation, is similar to what we do in a simple mitral regurgitation. The carpenters has proposed some techniques where we remove the entire calcium en bloc and then repair it. We make incision parallel to the posterior leaflet, we remove it en bloc and do the repair that is required for the type of dysfunction it has. Some important things are you have to create a proper plane if you want to remove it en bloc. You have to completely have in the right plane so that you leave the tough endocardium onto the atrium and onto the left ventricular surface so that we can suture it back when you are placing the leaflet back, and also to use the interrupted sutures which you are using to put it onto a sewing ring. Some technical things are, instead of using a mattress suture which will reduce the blood supply to the endocardium, it is more advisable to have figure of 8 stitches, which usually we do a pleated suture for putting suture after debridement. Instead we use a figure of 8 suture so that it can be used as a secondarily to keep the ring in place. In addition, when you replace the valve or repair the valve, you put a continuous suture again so that there is no dehiscence in between. This is the cartoon shows how it is done. First you take a figure of 8 suture, then you have a continuous suture, this is for the sewing ring, then you replace the valve, you a continuous suture plus you reattach the leaflet. Similarly, replacement is also done. In the Toronto technique where Tyrone David advises to replace, or once you have decalcified the endocardium, you replace with a pericardium, by the autologous or a bovine pericardium. In Carpenter's technique, if you have a large surface area, then you can dissect the atrium, left atrium, and slide it on top of it. These are the two techniques. This is the sliding, atrial slide technique. One, when there is a defect is not much, you can approximate the endocardium to endocardium, left atrium to the left ventricle. And if you have a larger defect, you can undermine the left atrium and move it forward. Or if you have a larger defect, you can use a pericardium, autologous pericardium or a bovine pericardium. In case there is endocarditis, which most often happens at the annulus side, then we'll have to resect the whole thing and you can have a pericardium on top. So we have three. One is repair using only the en bloc technique and don't do anything else. Then we have a sliding technique of the right atrium, or if the defect is large, you use a pericardium, or if the defect is in the anterior annulus, then you remove the vegetation or the calcification, then use augment with the pericardium. Are the results good with these results? They have shown Carpenter's group, Tyrone David's group, and groups from New York and Leiden have shown similar results when they do decalcification and repair or replacement. There's not much difference between if you do it properly. Of course, there are some complications which can happen. One is bleeding, one is disruption of the atrioventricular junction. These are the two complications, dreaded complications which can happen. There are newer techniques adopted now because it's a very, sometimes you may not be able to decalcify fully, or sometimes you can be able to do a little bit in which you are making sure the suture area is able, you are able to pass sutures, rest of it leave it. So some which has come recently are these: ultrasonic emulsification and aspiration. If the calcium is in, if you want to replace or repair, you can use ultrasonic emulsification and aspiration. You just remove the area in which you want to take sutures, or make that calcium softer so that bites you can take bites through that. The other option is to, if there is a valve area is significantly large, 4 centimeter, and there is a leaky valve, if there are comorbid conditions, then you can always consider a microclip. That's edge-to-edge repair. Then we have also, as I already said, if you have a stenotic lesion with a annular calcification, you can always implant it transannular, because the problem with the percutaneous implantation is there is high risk of having LVOT, because anterior leaflet you are not doing anything. If you are doing surgically putting a transannular valve, then you can remove a significant portion of the anterior leaflet and put your valve inside, so that we can obviate the LVOT obstruction. And of course the latest is having a tendine valve, which we can place it transapically. These are all, these last two are in the study phase, yet to be marketed. And there is a state-of-the-art review paper recently which has come as late as December last year in JACC. This outlines the entire algorithm of what can be offered if you have mitral annular calcification, and there is an indication for intervention and what intervention can be allowed. This whatever I have covered now, it's just a summary of what can be offered. And to conclude, it's a very tough condition. There are places where you will not get all the options. Still, surgery is the gold standard till we have enough armamentarium with us to deal with it either percutaneously or till the studies show good results with the percutaneous options. Thank you.
Thank you, Deva, for a nice presentation on mitral annular calcification. I have a question.
Yes.
When do you advise these patients to go to percutaneous valve implantation?
What's that?
Percutaneous valve implantation for the calcification and then mitral stenosis. Which kind of patients we refer for the percutaneous implantation of these valves?
Sir, one is when elderly patients, it's almost similar to TAVI for high-risk patients. When the patient is very old, when there are comorbidities like renal dysfunction or any other comorbidities, when there is high risk for open heart surgery, then we go for percutaneous interventions.
Last week I had a case, P2 prolapse, severe MR, needing decline, with a MAC, though it's a young patient. So I found the carburetor technique too dangerous because you go really to the back of the LV. The patient was not affording for a transcatheter option, which in today's era would be with a pledget around it, with a cuff around it, it's very, very decent.
It was a mitral annular calcification with regurgitation.
With regurgitation. The options were repair, right? So the P2 prolapse, it was a repairable valve. But my concern was that if you put a ring, there is no, because the calcium, the ring wouldn't hold.
Yeah, the only option is to debug the entire posterior. If you are planning for a repair, then you'll have to debug the whole thing.
Yeah.
Or you simply do a Alfieri stitch and come out.
No, I kind of, what I was testing was that there are options beyond what you have presented. What I would was, the calcification is in the annulus. The leaflets per se are actually decent quality. You go one size less on the leaflet and take a leaflet stitch.
Then you'll...
it is like a common man's option. I mean, if you are not as skilled as people and patients not affording, just do one size down the valve and just put an MVR there?
Yeah, if you are replacing, yes.
The parts of the calcium which is sitting as a rock can be considered as a part of the ring, and whichever is not supported you can do and go ahead and repair. The trouble occurs when you have a subannular spur sitting anteriorly, and for that I use a dental decalcification this thing, and that actually
Ronger also
better than the ronger is. No, that don't put it in the calcified area. You put it in the non-calcified blobs and put it there.
One other thing what I learned was that if you look at the transcatheter, surgical transcatheter valve videos, they always put a pericardial cuff or a PTFE cuff around it.
Because the high chance
of
parallel leak is
so what I did was that the same technique with a surgical valve, you put wherever you feel calcium is there, you put a pericardium there, and then stitch it to the LA inside. It's an extra reinforcement in case of a.
One caution with Carpenter's technique, we have seen in India itself twice when he did it. We had in Bangalore an LV rupture in the same case which Carpenter himself did.
I think in the interest of time, can we move on? Dr. Andres is waiting to present a dreaded complication on mitral valve replacement.
Good afternoon, everybody. At the outset, I would thank the organizers for the excellent meeting and the good hospitality. And my topic is atrioventricular disruption after mitral valve surgery. No financial disclosure and not much of expertise in this surgery as well. So it's been described as early as 1967 when mitral valve replacement was aggressively started in early 60s. And the first two cases were reported by Roberts and Marrow. And the initial incidence in the first series of cases was about 14%. Over the last 20 years, with increased surgical expertise and better prosthesis, the incidence has decreased over the last 20 years. But still, if it occurs, the mortality is quite high. Now, it's always better to prevent. And it's once you get into the situation, it's very, very difficult to get out of the situation. As you may be an individual surgeon, you may not be able to call a senior person to help, and it becomes a really nervous situation. So sticking to the basics and avoiding is better than landing up in this situation. There are three types originally described. The type 1 is at the AV junction, atrioventricular junction. Type 2 is at the base of the papillary muscle, and type 3 is midway between the AV junction and papillary muscles. Now a new type has been described, which is called type 4. This is the advent of percutaneous neocords which are implanted by cardiologists to correct mitral regurgitation. These percutaneous cords can cut through the LV and cause LV disruption or LV hemorrhage and then injury. Now it also has been classified depending upon the time of presentation. Early ruptures occurs intraoperatively, delayed ruptures occurs within the first 6 hours after surgery, and late ruptures occur after 6 hours, and this could be because of pseudoneurysms. Now, even though the initial assault starts with the surgery, it's an iatrogenic injury most of the times, there are a lot of cascade of events which lead on to a complication. The supporting structure of the PML, the posterior ventricular wall, forms a loop with the papillary muscles, attached chordae and the posterior leaflet. Division of this loop by excision of cords or leaflets initiates a stretch injury to the ventricular wall. And on top of this, on completion of CPB, the LV may distend, and this leads on to multiple endocardial tears. and dissection extends into the myocardial fibers and causes rupture or hematoma. So we need to stick to the original concept of preservation of posterior mitral leaflet advised by Lillehei as early as 1964. Now who are more prone for it? The elderly women, the ones who have a small body surface area and a small body, and who have predominantly mitral stenosis with a small LV cavity. Now how do we prevent it? It's always better to retain the PML tissues, and when you are severing the subvalvular apparatus, it should be done at the junction of the muscle and the chordae, more towards the fibrous area rather than to the muscular area, and it's better to avoid pulling the subvalvular apparatus, pulling the papillary muscle at that point of time, and it's better to avoid oversizing of the mitral processes. We know most of the processes now available are low profile processes, and there should be, we should avoid excessive traction on the sutures as well. Avoiding rough instruments or suckers or vents into rough suckers into the LV cavity is very important. And even in a redo, when we release the additions, there should not be undue tension on the left ventricle when we lift the left ventricle for releasing the additions. Now going into the types, type 1 is, as we discussed, it's at the AV junction. It's because of aggressive excision of posterior mitral leaflet. Mitral annular calcification is one of the causative factors, and we should avoid undue lifting the heart after the mitral valve is implanted. And infective endocarditis with abscess eroding into the posterior annulus could be another cause. Type 2 happens in the base of the papillary muscle. This is because of excessive resection, rupture and hematoma of adjacent LV myocardium leads onto it, and releasing of additions in a redo situation once again can be a cause for this. Type 3 is between these two, type 1 and type 2. It is because of high profile valves in a small LV cavity, and it's usually the incidence has come down drastically now. Now the current incidence is about 0.2 to 0.8%, still the mortality is about 60 to 80%. The original series had a high incidence of type 3, but now with the modern era, it's type 1 which is common. The incidence of type 1 is the commonest happening. Other types have sort of taken a backstage now. Now why is it a difficult situation? It is a very, very nervous situation. Exposure may be inadequate. The epicardial hematoma may be remote from the endocardial tear. The friable myocardium does not hold sutures well, and we usually try to avoid the injury to the circumflex artery. If at all it's unavoidable, it's better to graft it off electively. The principle of repair should be a full extent repair. Placement of suture should be into the healthy myocardium, and OM should be grafted electively if needed. Repairs could be endoventricular or external repairs. More favored are endoventricular repairs. There are a lot of procedures which are described for it. It could be repaired with a Teflon felt as a buttressing material. We could use pericardial patch, and if at all there is any PML retained, it could be used as a buttress, and bioglue has also been used for this. In a very rare situation where we can't lift the heart and repair it, there are reports of even autotransplantation where the heart is explanted, it's repaired, and then re-anastomosed there. External repair, once again, is more for type 2 and type 3, and we use various methods have been used. Teflon felts and even the left atrial appendage has been used to buttress the tear. Now in type 1, there's increasing incidence of non-rheumatic valvular heart disease now, mitral annular calcification. I'm not going to go into the detail because Dr. Dev has just given a detailed talk on it. This is mitral annular calcification. This is just showing a massive mitral annular calcification in a case where we recently operated. You could see that the second photo, you could see the bulk of calcium which we could excise and replace it with a valve. Now type 2 is usually because of hematoma and the LV. External repair is preferable, and in a picture it may look easy, but on table it's usually very, very difficult, and it needs meticulous patch repair. Type 3 is repaired by a patch or a sandwich patch technique. Now there are reports of various other methods which have been described for it. It is a sandwich technique or a combination of a patch with the bioglue has been described. Now once we've repaired, which itself is a very nervous situation, we need to be very careful when we terminate this patient off bypass and take them back to the ICU. Now, once we repair it, we should make sure that these stairs don't extend as soon as we load the heart and start coming off bypass. So, if at all needed, an IABP can be inserted to electively unload the heart. There should not be too much of inotropes with vigorous contraction of the heart. And there are reports of even a short or intermediate ECMO run to unload the heart, make these sutures hold on, LV recover well, and then they're weaned off ECMO a bit later. So, to conclude, prevention is better than cure. On suspicion, it's better to go on full bypass and arrest the heart electively rather than trying to lift the heart and trying to repair these things. Lift the, if at all you want to lift the heart, it should be at the axis of the pulmonary vein rather than at the AV groove. Type 1, remove the processes and internal repair is preferable. Type 2 and 3 can be externally repaired. In spite of all these things, there's a high incidence of high mortality, and early recurrence could be due to false aneurysms. Thank you.
Thank you, Dr. Brashu, for that excellent presentation. This is one complication we all fear our life, isn't it? The moment we see that blood coming after CPB, it's like a deadly game then. So, as you clearly said, prevention is the way forward. We should not be saying this, isn't it? But if we land up in a mess, it's a mess to solve it up. If you're lucky, we'll get through. Thank you very much indeed. In the interest of time, I think we'll move on to the next topic.
So I have one question. Once you explant the valve in an AV rupture, do you go back and put the same valve after repair, or do you downsize the valve?
Personally, I don't have any experience. But if a large process has been used, once you repair it, a lot of patch material is going to be there. So I'm not sure whether we can re-implant the same size valve. It's preferable to use a smaller size valve. Because once you have all the patch, pericardium or the Teflon patch sitting there, I'm sure the same size valve is not going to sit back there.
Yeah, ideally we should downsize the valve, yes. Any other questions from the audience? Yeah, please go ahead.
Thank you.
One question we have, Anbarasu, 1 minute. One question is, give the mic to her, please. Mahadev and team.
Sir, in the sandwich patch technique, from the LV wall outside to the inside, usually I have seen them taking bites, but most of the time what used to happen, that needle will not be big enough to come from outside to the inside. So I wanted to know what suture material possibly you recommend for something like that.
We are going to use either a bovine pericardium or Teflon patch.
Yes,
here.
sir.
And the needle has to be a strong needle which can penetrate to this.
Yes, sir.
Preferable would be a 3O or a 4O with a 25 mm needle.
25.
Thank you. You can come over here, sir, please.
Which we learned in the pathology mortality mitigation, they're taking the bites in the posterior annulus. When you're taking a deep bite, if you take a bite crossing the red-white junction, and this is actually a beautiful picture is there in Harlan and Starr. And we had a lot of specimens where AV groove rupture in the earlier years was very high, and even when I was a student, we have seen this. And that was one of the causes which is not very well appreciated, but is mentioned in Harlan and Starr, that when you take the bite and goes and you tie it down, then later on when the heart starts contracting, the blood starts dissecting through along the AV groove, forms a hematoma and then ruptures. And that's one of the ones which occurs 6 to 8 hours after surgery. And that is going to, that they die because 6 to 8 hours later you are in the ICU. And we had a lot of specimens in KM, so those who are in can go and see it in KM. Thank you.
I have a question for you. How do you manage this delayed disruption? Patient has been shifted from ICU to the ward. It can happen, delayed disruption. Anybody got some experience on that?
No. Sir, it is very clear. AV disruption, if it happens in the OR, mortality is 50%.
Outside
if it happens in the ICU, 100%.
Yes. I have not seen a single
survivor. It is very clear. I have seen 9 cases till date. Only 1 survived. Yes. Not me, but in my experience with last 30 years with sir also, with Prasanna Singh, they won't survive. Best is prevention, prevention, prevention only.
Start
Starting from your handling of your tissues, sparing the post PML, very important. Okay, sir. I think we'll go with the next session.
Thank you. There is one mind.
Yeah, the next talk is submitral mitral disjunction, MAD. Dr. Praveen Verma, please.
Again, thank you for the organizers for inviting me, chairpersons and delegates. So I'll be talking on the challenges in the diagnosis and management of mitral annular disjunction. So mitral annular disjunction is the actual definition. It has got 3 points. One is that the valve should be a myxomatous valve. Second thing, it is associated with hypermobility of the leaflets. And the third one is because the annulus actually is separated from the left ventricle in systole. So that's the definition of mitral annular disjunction. So if you see here, in systole, the valve is separated from the left ventricle. So that distance is called as the disjunction distance. So how will you diagnose mitral annular disjunction preoperatively? Yes, most of these patients will have ventricular ectopic in ECG. If you see the ECG, if you see ventricular ectopics, most of the time these patients will have mitral annular disjunction. So cardiac MRI actually is very good. Can you see the posterior annulus separating from the left ventricle in systole, and there is a hypermobility of the leaflet. And third impressive thing is that in systole normally the valve contracts, but in mitral annular disjunction the valve actually dilates. So it's like a systolic curling of the valve. So it's beautifully illustrated in cardiac MRI. Transthoracic echocardiogram, if you know about this condition you can diagnose. You can see that the posterior leaflet, that annulus is separating from the left ventricle, and that distance is called disjunction distance. So as I said earlier, in diastole it will be at the level of left ventricle, but in systole it moves away from the left ventricular apex, and that distance is called as the mitral annular disjunction distance. And this happens mainly in mid-systole and late systole, and it is classified into 3 types. Type 1 is there is just the hypermobility but there is no separation. Type 2 when the disjunction distance is less than 5 millimeter, and type 3 when it is more than 5 millimeter. So you will see these kind of patients where patients will have severe mitral regurgitation. The cardiologist will tell you that it's a bileaflet prolapse, and the patients will have central mitral regurgitation. So if you see a central mitral regurgitation with this appearance, like it's diagnosed as bileaflet prolapse, you will have to suspect that these patients have mitral annular disjunction, and it is one of the easiest thing to repair. So what you do is just put a ring. So just put a ring is the answer. So this patient had mitral annular disjunction, we put a physio 2 ring. See the saline test. Perfect coaptation, isn't it? So if you think that is a bileaflet prolapse and start putting cord A, you will muck up the valve. So if you diagnose this preoperatively, that central MR with mitral annular disjunction, just go ahead and put a ring and you will have a perfectly competent valve. This is the post-op echo. So that is the importance of mitral annular disjunction. So because if you know about this condition, it's a very easy to repair this valve. So the techniques described is most of the time we require only a ring, but Dr. Tyrone David feels that ring alone is not enough. So he actually separates the leaflet from the atria and reattaches to the ventricle like a sliding plastic, but it's not probably required. So the second condition is mitral annular disjunction with a PML prolapse. So in this condition, most of the time it's a P2 flail. Because of the hypermobility, it causes a lot of stress on the cord A, and cord A will rupture. So these patients, you need to actually do a leaflet repair. So if there is a PML prolapse, you have to do a leaflet repair along with a ring. And most of the time what we do is we place an artificial cord A to the posterior leaflet. So that's the artificial chordae. So third part is that mitral annular disjunction. Some of these patients, especially young patients with severe myxomatous valve, will have mitral annular calcium, and it makes our life very, very, very difficult. So in these patients, there are many options, but the best option would be actually when you repair this valve, take out the mitral annular disjunction, mitral annular calcium also, and you can see that C-shaped calcium. So what happens is that because of the excessive leaflet motion, excessive annular motion, that disjunction area the entire thing can get heavily calcified. So once the repair is over, the story is not over, because this is mitral annular disjunction is one of the most arrhythmogenic of all the myxomatous valve. So it comes under the arrhythmogenic spectrum of myxomatous valve, and what happens is that because of the excessive mobility of the leaflet, there is tension on the posterior and the anterolateral papillary muscles. This itself is arrhythmogenic, but it actually disappears when you put a ring or repair the valve. But some of these patients can have fibrosis at the level of papillary muscle head or LV free wall. And if you do a cardiac MRI, you will see that there can be scarring of the ventricular wall. So these patients can have an increased incidence of ventricular tachycardia and sudden cardiac death. So this is the spectrum. So if you have a patient with mitral annular disjunction, if the patient is female and if there is an excessive hypermobility, if the annular disjunction distance is more than 5 millimeter, and if the cardiac MRI shows myocardial fibrosis, these patients have an increased risk of ventricular tachycardia and sudden cardiac death. So once you repair the valve, one way of looking at this at the end of 1 month, have a Holter study, and if the Holter study shows evidence of ventricular tachycardia, they may be candidates for AICD, but the guidelines are not very clear. It's still a very evolving field. So non-invasively, I mean, there are several markers, certain markers which shows that these patients can have increased incidence of sudden cardiac death. One is that a T-wave invasion in 2-3 AVF is an ominous sign. If you have multiple and complex ectopic, it's also a sign of that patient may have the propensity to develop ventricular tachycardia. Third one is this: when you have a annulus, when you put a pulse Doppler in the mitral annulus, and the velocity is more than 16 centimeter per meter square, that means that the annulus is hypermobile. These patients also have a tendency for sudden cardiac death. And of course, if cardiac MRI shows fibrosis at the level of papillary muscles or left ventricular free wall, these are the three markers for patients having ventricular tachycardia or cardiac arrest later. So if you have some of these patients, we can actually do an electrophysiological study. So this is done in patients who have an unexplained syncope. Mitral annular disjunction patients, preoperatively if they have an unexplained syncope, your electrophysiologist can map, they can induce a ventricular tachycardia if it is there, and then they can ablate it. So mitral annular disjunction patients, it's easy to repair, but we'll have to follow up this patient because these patients can have a propensity for cardiac arrhythmias and sudden cardiac death. So there are several markers which are this one. One is the cardiac fibrosis in LGE and increased of the longitudinal, that MAD distance if it is more than 5 millimeter. And this is called as the pickle Hoff sign, that the lateral annular systolic velocity more than 16 centimeter. So these are some of the things which may show us or may give us the clue that this patient can have an increased incidence of ventricular tachycardia or sudden cardiac death. But the guidelines are still not clear how to manage this patient. Only thing what we understand is that all these patients of severe myxomatous disease with mitral annular disjunction should be on beta blocker. That's a class 1 indication. Whether you put an AICD or not is not clear, but class 1 indication for AICD is myxomatous valve who have a documented cardiac arrest or ventricular tachycardia, you may well put an AICD. Thank you.
Thank you, Dr. Praveen. How frequently you come across this case?
What is it?
How frequently do you come across this?
It's actually quite common. Mitral annular disjunction in a severe myxomatous disease like Barlow's disease, the incidence can be from 40 to 90%. 40 to 90%. In that way, it does not come in that fibroelastic deficiency or forming the FED plus spectrum, but it in the last spectrum, the Barlow's disease, it is 40 to 90%.
Can I make a comment? Can I make one comment? For my PG, when I asked him to follow up isolated P2 prolapse patients, and when he followed over for 7 years, surprisingly, this was a time when this MAD was not well described and we are publishing it. We found that out of 72 patients which were followed, 4 of them had sudden cardiac death. After that, we started trying to search for MAD and Pickelhaus sign, and we are doing that. This is something which we never appreciated, but then when we followed up the patients, they all had sudden cardiac death.
Yes, it's underappreciated, yes.
Out of 72 which he followed, 4 died.
Yeah.
Sudden
Right.
Praveen, I have a question. If a patient presents with myxomatous mitral valve and MR, do you suggest a routine evaluation of these patients with MRI to detect it?
Yeah, that's what I am saying, sir. The guidelines are not clear. Only thing we know that if this patient had a history of cardiac arrest or a syncopal attack or a documented ventricular tachycardia, then you can do a cardiac MRI, and if there is fibrosis, your electrophysiologist can potentially ablate the condition, but it's not advised. Cardiac MRI is not advised. So it's an evolving field. But we have to be aware that all these patients should be on beta blocker, metoprolol. Yeah.
Is there any difference to sizing the mitral ring in this condition versus the regular?
No.
So you size it only to the AML?
Just a size. What auto routine sizing we do.
Sir, what are the indications for EP study and ablation in MAD? And if you are planning EP ablation, is it pre-surgery or after the surgery?
It's always pre-surgery. It's always pre-surgery. Yes. It may be very difficult to put the catheter through this. No? So always pre-surgery. So we have placed AICD in only one patient. That patient, the indication was that ejection fraction was also low. So we thought we will put an AICD, but that's 5 years back. But so far he did not have any shocks.
So are these patients also prone for submitral aneurysm? Are these the same segments patients in which?
Whether it is a pre-runner for submitral aneurysm is also something which we don't know. But definitely annular calcium, mitral annular calcium.
Thanks, Dr. Praveen, for the excellent presentation.
Thank you.
Can I call upon Dr. Prasanna Sinha for the next presentation? Thank you.
Oh, Praveen is very tall, so. Please go ahead. Subaortic and submitral aneurysms are now considered as a comprehensive group, and they are all called as subvalvular aneurysms, though many of us refer to it as separate. And submitral aneurysms are in relation to the posterior annulus of the mitral valve. They always they involve the fibrous mitral annulus and the posterior part, and with the enlargement, and there is displacement of the posterior annulus, and therefore it pushes the subvalvular apparatus, and it starts restricting the motion of the posterior leaflet, and this causes a secondary MR related to the distortion that occurs. And this is typically how it looks. You can see that this aneurysm is sitting between the LA and the LV in the AV groove, and this starts interfering with mitral valve function, and it later produces mitral regurgitation. This is actually more common in African population rather than in India, but in India we have seen quite a few of these cases, and we get them probably one or two cases every couple of years. Now, I would like to draw attention, historically, one of the mechanisms that has been described is actually by Dr. Solomon Victor. And he has, with Vijay Nayak, had proposed a mechanism where the fibrous trigone, which is there on right fibrous trigone, he showed that there is an extension of the right fibrous trigone tissue going along the AV groove, and as you can see what I have marked in yellow, and they demonstrated this membrane, the submitral membranous curtain is how they described it. And they showed that this has got a variable extension, and those with submitral aneurysms, it is particularly large, and that is the forerunner for dilatation in these patients. And they proposed this mechanism, which is considered one of the mechanisms. There are other mechanisms, but this is one of the held, and I'd like to draw attention to the students if they are there, because this was an Indian contribution. Professor Solomon Victor was one of the pioneer cardiac surgeons in India. So often they are asymptomatic. They may not present with any symptom, and they may be incidentally detected for something else, or they could present with mitral regurgitation and heart failure because the displacement distorts the mitral valve. The other thing is you have got a pouch there, and there clots can form there, and it can cause embolism and rarely free wall rupture. And remember that it becomes an arrhythmogenic substrate at that point, and sudden cardiac death or aborted cardiac death has been, aborted arrests have been noticed, and they have been discovered. Now there are various types, and they have been called a type 1, which is a single localized neck. Then there can be type 2 with multiple necks, and the rarest one is type 3, which involves the posterior mitral annulus entirely. And what is the surgery for this is you can do either an intracardiac repair, an extracardiac repair, or a combined approach. And though actually we find literature showing even Cooley had described it, but most of the larger series has been described by Antunes. And Schreier and Bernard described an extracardiac approach. And the intracardiac approach is basically a patch plasty. The extracardiac approach is you go and open the aneurysm and patch it. We'll be coming about the problems of this. But the most important thing, and this has been found as a persistent problem, is that incomplete closure is very common in these patients, and it can lead to reoperation or recurrence of the aneurysm in almost 50% of the cases. So the problem is that in the flaccid heart, it's very difficult to identify the multiple openings which are present, especially type 2, and then it's very difficult practically to delineate in the flaccid heart. We had faced this problem, and we had seen these cases, so we were one of the initial, when 3D printing, we had published this paper many years back, where we took the help of 3D printing to delineate the aneurysm. And actually we published it. So now here you could see, I don't know whether the arrow is coming there. Do you have the pointer? So in a particular case, this was a very odd placed submitral aneurysm which we couldn't see properly on echo, and at that time we didn't have MRI with us. And so we managed to 3D print, and I didn't have a color this thing, so I've actually just painted the aneurysm at that time because I didn't have multicolor 3D print. So actually if you can see the slice from here, you could actually, I will be showing you the parallel. This was when we lifted, this is the what is called as the STL file, which is done in 3D printing. And you can see I have flipped it in the position of the aneurysm as you would see externally when you flipped it. And you can see how it matches the position. So that's why the thing. But can you see here, there's a coronary artery crossing over here. This is very important because extracardiac repairs have a high chance of causing coronary artery injury when you approach it extracardiac. That's one of the problems with it. And then intracardiac, what happened is you can see here that it was located laterally. Though it looks like as if it is near the crux, but the actual orifice was here. And we could pre-plan. And actually in this case, we pre-planned, picked the size of the patch which we got, what was the thing, everything was done virtually before surgery. And then you can see this point was retracted, and you could see the exact mouth. And actually in this case, we did not, the classical description is actually to detach the posterior leaflet and do the repair. But because we had such a good delineation here, we could pull back the chordae, could identify the exact margins. We had pre-cut the patch with 5 mm extra, and we could close this aneurysm and we could close it perfectly. This became much easier because what we had, because we knew exactly, previously it used to be a big hunt saying it's here, check whether it is thin and all that sort of stuff. But here when we did the 3D printing, we could do it very elegantly. And it was very easy, and post-operatively we have got it followed. So we have done this in repeatedly in other cases, but this was the index report in which we did it. So so we can use 3D printing and good recon images to help us do. The advantage of the 3D printing is you can pre-plan the surgery before doing the surgery, and that was very helpful for us. So basically, what's the indication? Symptomatic patients, because you wouldn't be otherwise detecting them. Recurrence is high if it is not completely closed, and delineation is actually tough endocardially. It's very difficult to do it in a flaccid heart, and coronary artery injury is higher with extracardiac rapport. So proper delineation by 3D reconstruction helps in pre-planning and helps in approach and also complete closure. Then thank you.
Sir, anytime you have post-op severe mitral regurgitation following the aneurysm repair? If
No,
so,
no, no.
do you
We actually, these patients, the ones which I have had are all having mitral regurgitation. We have actually repaired the mitral valve. As a part of, it was not just that the patch closure was done, they all had MR and we had to repair the mitral valve with it.
And anytime replacements done? No.
I have not replaced any of them so far. All of them I have been able to repair because the leaflets are basically, what is happening is there's distortion and the leaflet is per se okay.
And in follow-up, no MR or no residual?
No, they have been stable. I had recurrences in the past before we used this 3D, this thing, and we had to go back in and put another patch. But with this, I feel we know what we are dealing with rather than imagining.
Thank you. Any questions from the audience? Yeah, please, sir.
So this is a comment more than. So myself and our late Dr. Krishna Manohar sir, we had made a classification for submitral aneurysm depending on the position of the circumflex in relation to the annulus. So we found that there are two types of submitral aneurysm. One is between the mitral annulus and the circumflex. Then it will bulge on the undersurface of the left atrium, where you can approach through the left atrium. The other one was actually into the left ventricle. Yeah. So in these patients, we had difficulty in going through this, so we thought it's much better to approach through the other side. So Satyaki actually published this in JTCVS, and my name was not there. Yeah. Okay. Thank you.
But I have approached, yeah, thanks. But I approached all through the LV. I found it a little difficult doing it extracardiac.
Thanks, Dr. Sinha. Let us move on to intraoperative TE to aid surgical decision by Dr. Manjusha. Thank you.
Wish you all a very good evening, and I'd like to thank the organizers for this opportunity to talk to a group which we are interacting with always in the OT. So in the next 10 minutes or so, I'll share some of the thought processes behind intraoperative TE for mitral valve repair. So outline of my talk will be what is the added value of TE in surgical planning, how can we approach it systematically, and what is the role of a heart team in the operating room. So technology has evolved for echocardiography over the last 30-40 years. Now we have reached 3D TE transparency modes. So what is the evidence for TE? So this was a publication which showed that intraoperative TE used patients had lesser 30-day mortality, lesser reoperations, and lesser incidence of stroke. So this came in 2020 in JAMA. So the ASC has already provided guidelines on how will you do TE in the intraoperative environment. So what are the goals for mitral valve repair? The 3 standard goals. What is the mechanism? What is the repair technique? And how will we assess the repair? Pre-repair echo has 4 steps. I will go into detail. One is quantification of MR. What is the mechanism? What are the geometric quantifications? And what are the predictors for a repair failure? We have to discuss and understand what is the planned surgical procedure for optimal results. Quantification of MR. It has to be done in an awake patient. Severity of MR can be underestimated. You have qualitative, quantitative, and semi-quantitative parameters. Vena contracta may underestimate MR in case of non-circular jets. ERA may overestimate if it is not a hemispherical one. Mechanism of MR can be, we have Carpenter's classification, but at what I'd like to highlight is, in addition to type 1, type 2, type 3, we have an additional classification which came out in JACE, that is type 4 is SAM has a category all its own, and there are now hybrid conditions where you have prolapse and restriction which is happening together. So terminology, because it's like we have to communicate in the common language. Billowing is when the coaptation is below the annular plane. Prolapse is when coaptation is above, but the direction is towards the LV. And flail is when the leaflet tip is directed into the LA. So, and it is very important to understand the pathology. It's a spectrum of disease from fibroelastic degeneration to Barlow's, because Barlow's is multi-segment and repairs will be technically more challenging in these patients. So, since we had a talk on mitral annular disjunction, this is a patient who came to us. He's a 17-year-old boy, presented, again, all disjunctions come as bileaflet prolapse. And what you can see here is that it's very evident that, the marker is not coming. We can see the disjunction second here, and the short axis, so you can see a cleft, and you can make out the disjunction of the posterior annulus. As Sir rightly said, so we only had to put a ring in this patient, and since we saw this, we did a mixed approach for this boy, so that late he was marfanoid, probably he may come back later on for some other aortic surgery also. So metaesophageal 2D TE views are 5, it's very intimidating for most people. If you have a single view, it's better to take the LV long axis view at 120. Most probably you'll be cutting the A2, P2 segments. Another important view is the bicommissural view, where you can see the medial and lateral commissures. So the problem with TE is that 2D is that it's based on those geometric assumptions. So you can see this is another case again present with bileaflet prolapse. Again it was a disjunction we operated 2 days ago. So there are multiple segments of prolapse, whether it is in the 2-chamber, 4-chamber, or even in the transgastric views. We can see the segments here, and there is definite caudal elongation for this patient. So that's where the next imaging modality, 3D end-phase view of the valve. We can see it's like a surgeon's view, and it clearly demonstrates an additional A3 prolapse. And actually that was confirmed on surgical findings also. We can see that. So if you have 3D, it is a very good tool we can use. This is just to demonstrate fibroelastic disease. You can see there is less tissue. There is an isolated P2 prolapse, and this is evident on 3D also. What are the measurements you need? In diastole, you have to measure the leaflet length, especially AML, PML. Here you can see that the posterior leaflet is quite long. Also, you have to measure the septal thickness. So in this patient, again, septal thickness is 1.7. So what is the significance of that? So when you're coming to early systole, this is where you're taking the AL-PL ratio and the C-sep distance. So these measurements are important as an echo predictors for SAM. And it is important because anything which brings a coaptation anteriorly can cause SAM. This is just a part of research people are trying because neocordial length is difficult to assess. So people have used echocardiography for that. I tried it for one patient. We got the same result. We used a 20 mm neocordia for the same case. It was again a P2 prolapse. So what are the predictors for difficult repair? In organic MR, a very dilated annulus, annular calcium, inadequate tissue, or if there is a prolapse with restriction. In case of functional MR, anything which makes the LV more spherical so that the valve is not coming up to the annular plane can cause a difficult repair or failure of repair in the long term. So what about in the OR? You have to follow a systematic approach for post-op assessment. It has to be focused, it has to be comprehensive, it has to be repetitive. So again, I'm repeating, that is the important thing. We have to assess it at different points. It's not enough if we just see it when you're coming off. You have to see it post-protomine. Definitely you have to repeat the echo before the patient is shifted out. If there is any, because all these things are causing changes in hemodynamics. So this is one thing when you're saying, when you come off bypass, you shouldn't assess the mitral valve in this kind of a hyperdynamic underfilled LV. Because again, you can see that there is papillary muscles are kissing in systole. So this is a hyperdynamic state. It will cause a high transmitral gradients and it can cause a hyperdynamic SAM also. So for valve stenosis, you have mean gradient ideally should be less than 5 and the mitral valve area should be more than 1.8. This is as part of the AAC recommendations. This is the 3D view of the mitral valve. Once again, it gives a single unfaced view of the valve, which is useful for communication also, like where is it. So coming to our patient with a long PML, he underwent a P2 triangular resection, caudal shortening, but when we came off, we saw this. You can see turbulence in the LVOT, there is definitely an MR jet. So what next? So this is the textbook appearance of SAM. The AML is hitting the septum. There is a typical dagger-shaped appearance of the LVOT gradient. Peak velocity is 56. That is a late systolic peaking. So what do you do when you have SAM? First step is give volume expansion, stop inotropes. If it doesn't work, you can add beta blockers, add vasopressors. If both doesn't work and if the gradient is still high and you have more than trivial MR, maybe you should go back. You can do an edge-to-edge repair, a sliding plasty, or you can upsize the ring. Anything to bring the coaptation posteriorly. So this patient, it was just a simple step. We just went back and the height of the PML was just pulled down. That was the only simple step we did, but the SAM disappeared completely. Another issue is circumflex injury, and I think that is relevant for the previous 2-3 talks also. When you are doing decalcification, any other procedures, circumflex is very close to the lateral annulus, lateral commissure. So that's what we have to remember. And if this distance is less than 3 millimeters, the patient is at a risk. So even if you don't have anything, this is a single view which you should be seeing. That is the transgastric mid-short axis view. Usually hypokinesia of the circumflex injury will manifest as hypokinesia of the lateral wall. And sometimes you can mistake it. Air also can give a similar picture, but that's usually mostly the infero-posterior wall. Echocardiographic identification, this is one of the most quoted articles on that, where you can trace the circumflex artery scores, or you can use 3D to measure the distance from the annulus and the circumflex. It's all by the Leipzig group. So this is a post-repair decision pathway. So if 4 criteria have to be met. There shouldn't be MR, there shouldn't be a gradient, should be trivial SAM, and there should be no new RWMs or no unanticipated worsening of LV function. If all these criteria are met, it's a good repair. If there is a residual gradient or SAM more than 50, which is not responding to conservative measures, we should be thinking, should we go back? And any RWMA or any new LV dysfunction which you cannot explain, always suspect circumflex injury, because the timing of injury to the timing of intervention will affect patient outcomes dramatically. So this is the same article, it came from Amrita. So if there is more than trace MR, you have to assess leaflet motion. So if leaflet motion is normal and if there is a cleft or a perforation, it's easy to go back and repair. If the leaflet motion is abnormal, residual prolapse is there, again you have to go back. If it's a tethering or if there is a coaptation length issue, you have to think about patient factors and technical factors before you decide to go back. So this is just a case which we did again, we did it 2 days ago. So this was a mixed pathology. Again, it's difficult. You have an A2 prolapse and there is some P2 restriction. First bypass run, there was a ring was placed and there was neocordial to A2, but there is still residual MR was there. So how do you go about it? The vena contracta was 0.5. And even if you don't have a lot of sophisticated numbers, you can check for the MR jet density. The anterograde jet and the divergent jet is almost the same color. So that means it's a significant MR. It is holosystolic. So we went back and additional sutures in the medial commissure were released, and there was a small cleft in the PML, it was closed, and there is 0 MR. And it's not enough when you shouldn't stop in the intraoperative OT, you have to follow the patient up in the ICU. So this is a post-op day 1 echo. Again, if you can see that there is good coaptation, you can see the neocardia, and there is no MR for her. She's extubated, doing well. This is just, I added because of the previous 2 topics, how 3D can help us. So if there is a paravalvular leak, you can communicate easily with the surgeon. When we talk in terms of a clock phase, 12 o'clock is the aortic valve. So it's easy to say where the jet is rather than interpreting with the 2D images. Again, this is just a case, this is just a video to show, again, since we had the same topic, it's a submitral aneurysm. So this was a 60-year-old lady who was posted for a CABG. And when we saw the echo, this is what we saw. So there was a large submitral aneurysm. We did an off-pump repair, and echo was used to guide whether during positioning, during clamping, was there any worsening of MR. She underwent a successful procedure and she's on good for follow-up of 6 months, doing well with trivial residual MR. So this is the submittal annulus. So to conclude, TE can play an additive role. It ensures safe weaning from bypass, and we can also guide the surgical approach. So what is the role of the heart team? It's good to have an echo timeout, communicate your findings, communicate if there is any issues in the surgical side, and we can see impact of the new echo findings on surgical plan. Decision making is always complex. So you have to integrate echo, hemodynamic and patient factors. So even if conversion topics are difficult, the actual conversations about it should not be. Thank you.
Yeah, thank you, Dr. Manjusha. Have you come across a situation where the surgeon tells that he has done adequate repair, but on T you tell that the repair is not adequate, MR is there. So how do you handle that? To what extent MR do you accept? Or do you end up taking some LA pressures to see that the surgeon is happy, you are happy, and the patient is happy, go home?
Yes, we have done LA pressures also, but it's always better to have a systematic approach. Like when you see an MR, why is the MR there? That is the first question which we should be analyzing. So if there is, like it was shown in that algorithm, if there is an underlying morphological cause for that MR, like a prolapse or a restriction, it's not going to go away. So, and again, it is very important to assess hemodynamics. Like I mentioned again, a hyperdynamic state, if there is tachycardia, it's an empty heart, you can precipitate a SAM, and usually it will just resolve with just stopping the inotropes and filling. So it is not just one thing which you should take in account, it should be a comprehensive, integrated approach. And finally, communication is the key.
Okay. Dr. Praveen sir, please.
So the surgeon's job in the OR is always, after repair, to make the anesthesiologist happy. So what makes you happy after a mitral valve repair? Can you say the points that will make you happy after a repair?
Yes. So again, like following a repair, the first thing which we will see, once hemodynamics are optimized, so the first thing we will be seeing is how is the leaflet motion. If it is a prolapse, has the primary pathology which we went in for, has it been corrected or not? The tendency is always there that as soon as you have a post-op echo, the machine is on, you have to put color and see whether there is MR. Always start with a 2D exam. First your hemodynamics, then your 2D examination. Check for the valve, motion is normal. Check for the coaptation depth. Adequate coaptation depth should be at least 6 to 8 millimeters is variable. Less than 5 means we want a repair which is going to last for at least 10 years. It has to have a less than 95% reoperation rate. So this is a marker for that. If coaptation height is good, the leaflet looks good, then only we'll put color. And we're putting color, usually what happens is that since the TE, one of the things is that very small jets you will automatically sometimes, and those jets probably might not be there in the post-operative transthoracic echo also. So finally think why the jet is there. Again, that's why I showed the last slide. When you see that, it looks like it's just a small jet, but it was a high velocity jet, and on analysis there was some tethering of the AML also. So sir decided to go back and we released it, and it made a difference for that patient.
So trivial MR at the end of bypass and area mitral valve gradient of less than 5?
Yes. So 5, some people say up to 6. Again, gradients are depending on hemodynamics. So you shouldn't go by just one number.
And good LV, left ventricular function. No new RWMA?
No new RWMAs.
Okay.
And the aortic valve also?
Aortic valve also is competent.
Yes. Yes.
I think the take-home message for our surgeons is we need to listen to our anesthetist.
No, we have to make the anesthesiologist happy.
Absolutely.
Yeah. That's a take-home message. Thank you.
Thank you very much, Doctor. Thank you.
Thank you, sir.
Thank you. With this we close this session number on session on valvular heart diseases. Next will be, go to the organizers plan.
Thank you, panelists and moderators, for such an amazing session, providing interesting information.
We will be moving on to an official inauguration ceremony. So, by the time the stage is organized, we will have the results of the quiz. So, we will announce the 4 student teams. No, and after the inauguration, we have the session 6. Yes, sir. So we have selected 4 teams, resident teams, to participate in the final quiz after the panel discussion. Team 1 is Dr. Tibara Prasad and Dr. K. Prithvi from NIMS, Hyderabad. Second group is Dr. Parvati Yoganathan and Arun K. Philip from MCH Trivandrum. Dr. Prithvi and Dr. Deepak from Sri Chitra Institute Trivandrum. Dr. S. Yogendra and Dr. Swecha from NH Bangalore. These are the 4 student teams who are selected for the final quiz late this evening. And the very well awaited consultant of the day, the first prize goes to Dr. Rajesh, who is HOD CTVS of Calicut Medical College. He has the top score of 24 out of 30. And the top scorer in the student team is only 17. So let us give a big applause to Dr. Rajesh. So I welcome Dr. Manoj Dureraj, President ICTS, Dr. C.S. Hiramat, Secretary ICTS, Dr. P.V. Ram Narayanan, Organizing Committee Chairman, Dr. Praveen K. Verma and Dr. Vivek Pillai, Organizing Committee Co-Chairman, and Dr. Jayakumar T.K., Organizing Secretary, to occupy the chairs on the stage. May I invite Dr. Manoj Dureraj, President ICTS, for the welcome address.
Good evening, everyone. I think this is the first time we are having 2 inaugurations. And the first one was obviously very spiritual with the lamp lighting. And this one, it's basically, we'll just keep it very short and go on for the next session. And initially, I'd like to just thank the organizers for putting up a great show. We've been having this theme, which is, evidence, innovations, and practical wisdom. And I think it's very important for all of us to embrace this theme, embrace technology. Artificial intelligence in this day and age is big time. There are monitors now which can actually predict whether the patient is going to have hypotension in the OR or 24 hours before in the ICU. And it's very important for us to also embrace this technology in our day-to-day practice. The wire skill programs we are all talking about, the cardiologists have gone a long way ahead because of technology, and technology become very easy for especially structural heart. And whatever generation, we have a gap. We are saying that, okay, I have reached 50, 60, I don't want to do structural hearts. I think we should embrace that technology because the hardware has become so easy. I just give an example. For example, the fax machine in the US. India has actually skipped that generation of having faxes in the offices, if you remember. So in US, they still have fax machines. But India, we are straight away gone to 4G and 5G because we were slow, but then we embraced technology very, very fast. Similarly, I would encourage all of us, irrespective of the age, to get into structural heart as soon as possible, get into artificial intelligence as soon as possible. If you have not done it, I think you should do it today. The other thing is, we are masters in our craft. We are surgical craftsmen. We have been trained that way. We use our knives, we use our instruments, which is made of cold steel, to actually create or uncreate things which have already been made to treat patients. But I'd like you all to combine that and just stop being surgeons, stop being human beings also, but be good humanitarians. See, your patients are coming to you. At that time, they're very vulnerable. We need to comfort them emotionally, keep them happy, give a positive thought to them that they will be all right. So at the end of the day, we should be walking, talking centers of excellence, examples to the community on how a doctor should be. That is the basic premise of what we all are. Technology, artificial intelligence, craftsmanship is great. We should all have it. But at the end of the day, be good human beings and be good humanitarians. I thank you once again. I'd like to thank the chairperson, the chairman, Dr. Ram Narayanan, Praveen Verma, sir, Dr. Jay Kumar for a fantastic show, along with Vinita Nair, who's been his right hand. And also I can see Dr. Nitish, he keeps a very, very low profile everywhere, but I think he's done a lot of hard work and spade work. And he's always whispering in people's ear on how to go ahead next. And all the other organizing team members, which I may not mentioned. On behalf of the IACTS, we are all proud of you, proud of the work which you have done, and your examples of how a team leader should be, Dr. Jayakumar. You've taken into account the least of the least. And we really appreciate and proud of what you're doing in the government sector. Thank you very much.
May I call upon Dr. C.S. Hiramat to give the Secretary's message.
Good evening, respected dignitaries on the dais, organizing chairpersons, Dr. Ram Narayan, co-chairperson Dr. Praveen Verma, Secretary Dr. Jay Kumar, Dr. Vivek Pillai, Vinita Nair, and all the organizing team members. At the outset, let me thank Dr. Jay Kumar and his team for an outstanding program on this backwaters. I think ICT has never had such kind of a techno-college CME, sir. It's really, we really appreciate the ambience and the scientific program. Yes, he has added on not only the who is who speaker in the country are here today, very good discussions, and also we have a robo outside waiting, and I think everybody can have a hands-on robo experience, which is the future of cardiac surgery at many centers. Even wet lab sessions, we have the best of Masters Dr. Tendulkar and his team. And apart from that, we happen to see the live demonstration of root enlargement procedure. Root enlargement is not everybody's cup of tea. Very few surgeons do it. And I think as a surgeon, we should know how to do a root enlargement. And today, we had a very good live session being shown. And that's a lot of take-home messages we have for the residents. And I think more than 200 plus delegates are here, including students. It's a very good show. Once again, on behalf of IACTS, we would like to congratulate you, sir, for a wonderful techno-college CME. Thanks.
Let's now have a lamp lighting ceremony. I invite Dr. V. Devguru, Senior Vice President, also to join the lamp lighting. I invite Dr. T.K. Jayakumar, Organizing Secretary, IACTS Techno College 2024, to say a few words.
respected President, Dr. Manoj, Secretary, Dr. C.S. Hirema, our respected organizing chairman, Ramnaran sir, Praveen, Vivek, and dear friends and senior colleagues, respected teachers. It is my privilege to thank during this inaugural section to all extend my sincere thanks to all of you. The IACTS Executive Committee, including the office bearers, were very helpful in bringing out the entire thing, including the scientific program and coordinating everything from that side. Then we have a very wonderful organizing committee with the entire team behind or in front, helping and guiding us throughout the way. And the industry supported like anything. And this backwater ripples, they were very cooperative. And so we could do all these things, especially with the support of each and every one of you. And I don't want to extend my talks too much because Ambassador is waiting for his next session. So thank you all. Thank you very much. On behalf of the organizing committee and personally, my sincere thanks to all of you, including the senior faculty who has traveled across. Thank you.
Without delay, we are moving to the next session.
Shared decision making is a key for ideal patient management in any clinical scenario. Scientific advances and innovations aid the surgeons to improve patient care with new gadgets. Young surgeons need to know the newer prosthetic materials available in the market to suit each clinical scenario. Today, we have a much awaited session on the choice of prosthetic valves and rings, where the expert surgeons express their preferences and provide their armamentarium to choose from. May I call upon the panelists to the stage. Dr. V. Devaguru, Professor, All India Institute of Medical Sciences, New Delhi. Dr. Manoj Durairaj, President IACTS, Director of Manugian Cardiac Center and Research Foundation. Dr. Prasanna Simha, Professor and HOD, CVTS, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. Dr. C.S. Hiramat, Secretary IACTS, Senior Consultant and Chief Cardiac Surgeon, Sri Satya Sai Sarla Memorial Hospital, Karnataka. Dr. Lalit Kapoor, Senior Consultant Cardiac Surgeon, Narayana Hospital, Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. Session is moderated by Dr. Anbarasu Mohan Raj, Director and Clinical Lead, Cardiovascular and Thoracic Surgeon, Medway Heart Institute, Tamil Nadu. Over to Dr. Anbarasu, sir.
Good evening, everybody. We are running short of time, so the allotted time was about 1 hour 15 minutes. We will not extend to that extent. We'll try to keep it as short as possible. Distinguished panelists, welcome to this panel discussion. We are going to have a bit of discussion on choice of valve, choice of rings, and what are the options we have. Now, there's been a lot of overlap in a bit of topics we've had yesterday and today, so we'll keep it a bit precise and focused. The first topic is going to be on sutureless valves, and we are going to get Dr. Lalit Kapoor involved in this discussion. Sutureless valves are getting in more and more. Most of these valves were designed for TAVI, which didn't work out, and then were modified into sutureless valves. Now, Dr. Lalit Kapoor, the questions are, what is the role of sutureless valves in the modern era? The choice obviously is only perceivable because the Edwards valves has been withdrawn from the market. What are the factors favoring a perceivable valve implantation, and what are the factors against a perceivable valve implantation?
The sutureless valves, actually they are rapid deployment valves. Now, being rapid deployment valves, you could have had two types. The other one is the Intuiti, which is actually a sutured valve. In a way, you take a stitch and do it quickly. And this sutureless valve is also a rapid deployment valve, which doesn't have a suture. Now, the advantage of these are basically they're TAVI sort of valves based on a nitronol stent. They go in and they can be expanded and put into the annulus. So, in a way, it's very easy to deploy. And the role is that they can be used with short bypass times, short clamp times in old sick patients. So you can cut down the bypass and cross clamp time and thereby make the operation much safer for an older person or a person who would otherwise have a lot of comorbidities. It is easy to deploy, so it can be used in minimal. So the same old patient can have a minimal operation, minimal mini stenotomy, or a right anterolateral or even an infraaxillary. So we can do it anyway. Therefore, actually in the era of TAVI, the role of these is fantastic. For surgeons, it's a way out, because we can employ these valves in patients who we will actually refer to cardiology. So therefore, they can stay with us, point one. And surprisingly, the outcomes of these valves, when compared head-on to TAVI, with low-risk patients, intermediate-risk patients, the results are far superior. No other surgical valve has beaten TAVI in both those, so-called. But these have beaten TAVI. So therefore, there's a big role for sutureless valves, and all of us should learn how to use them. The second question was?
What are the factors favoring a perceval implantation, and what are the factors against a perceval valve implantation?
The factor, you see, as a surgeon, you want to give a big valve area. And so to put a bag valve area with a low gradient, this has no so-called stent. Though it's based on a nitinol stent, it's called a stentless valve. It's a type 5 stentless valve. It's like a TAVI.
Yeah.
So it doesn't have a sewing ring, which means your actual orifice area is very big. You give very low gradients. Also, because the shape of this valve is almost like a flask and sits in the sinus of Valsalva, that valve makes it amenable for future TAVI. So in today's day, when we are talking about lifetime management of valve disease, this is an ideal first valve to put, because once you put it in, you just put another TAVI later on, and there's no fracturing needed.
No, the only other valve which was available was Edwards intuitive valve. It is being withdrawn from the market by Edwards. I'm not sure, I don't think any surgeon in India has got experience with Edwards intuitive valve. As you said, it's got 3 guiding sutures.
Yes.
Still has got those 3 sutures holding on to the thing, apart from the pneumatic pressure deployment.
Yes.
So what is the workup protocol for a perceval valve tissue?
I'm sorry?
What is the workup protocol? How do you work up a patient for a perceval valve?
Okay.
Do you just go by just an echo?
No,
or does it need a full...
No. You can't go by echo when you're starting out.
Yeah.
See, there are 2 stages. You do in the first 10, 15, 20 cases, the best thing to do is to start with the CT TAVI protocol for the patient. The CT scan is done. I actually do even one step ahead. I include the coronary evaluation at the same time.
Yeah.
So it means I can do one CT and the patient doesn't need an angiogram after that. That's an advantage. The CT evaluation tells you the thoracic aorta size. It tells you the size of the root, the sinotubular junction, and the annulus. You can make out what type of valve it is. Suppose it's a kind of a bicuspid, type 0, you wouldn't want to do that, because
you don't want to do that.
You don't want to do that. If it's a type 1, some of those cases you can do. Tricuspid are ideally suited. If the sinotubular junction is more than 1.3 times the annulus, you can't put this valve because it doesn't stay, then it moves out.
Stay there. Yeah.
So the idea is that you do a CT. So the evaluation of that patient is the moment he comes to you, the first thing you do is say, we are going to evaluate whether you can get a TAVI or a CT on how your coronaries are. You do a CT scan and we'll see. Once you have the CT in your hand, you can then decide which way he goes.
Yeah. Okay.
And you also know his coronary status.
Now, why is a type 0 bicuspid valve a contraindication? Because anyhow you are excising the valve.
Yes.
But for most of the cardiacs, any type of bicuspid valve, for them practically is not a contraindication for a TAVI. But why is it a contraindication for the TAVI here?
The reason is because this valve is self-expanding, basically. You're putting a balloon, but that's more to get the shape. It's not for putting it there. It's a self-expanding. The Martensite becomes Martensite, the 2 stages of nitinol. It gets shape when it warms up. Now, with the shape of the type 0, it's actually not even circular. Some of those, they have little bumps. If you see the things cross-section, they're not a circular or not even elliptical. So those valves don't seat. If it sits, it has a leak. If it doesn't sit, it slips out.
Slips out, okay. Yeah.
So there is a technique described how to fix it in type 0. But I would say for most beginners, I don't think it should be done in type 0.
And I believe you need a proctor for the initial few cases before you do a perceval.
Yeah.
Now, how many cases with the proctor do you think it's ideal before you can do it independently on your own?
See, I proctor for this, so I can tell you what I think is, it depends to an extent surgeon to surgeon. More than the hand skill, it is the mental acceptance. To get an idea that you're going to put a valve, just leave it there and come out and close the aorta. I mean, some people are very averse to the idea, get very nervous. On the other hand, some person understands the concept and says, let me give it a shot. He's more confident. that person will do it in 2 proctorships should be good enough, usually.
And how do you deploy it, and what are the potential complications?
Deploying is actually, you open the aorta like you normally would do, but you open it much higher than normal.
Normal, yeah.
Okay, at that big yellow band across the aorta, the fat pad, it's called that plicae transversalis on the aorta.
Yeah.
You cut it approximately that height. It should be 3.5 centimeters above the annulus. You cut. You make a transverse aortotomy, not the hockey stick.
Yeah.
So you make a transverse, then you can see the valve. Now, I will tell you my trick, because the valve sits deeply inside. What I prefer to do is put 3 commissural stitches and pull the valve out, like you would do for a minimal invasive, like you always do. So you pull the valve upwards, the valve sort of almost just comes up. Then you routinely excise the calcium, which you would do like with a normal rongeur, and you don't have to be over aggressive. Even if you leave a few drops of calcium, it doesn't matter. TAVI leaves the whole lot.
Whole calcium is left out.
So it's not a problem. Then you take 3 stitches. Once you've done that, you size the valve. And sizing is not very difficult. They've given you 4 sizers. You just put it in. The transparent sizer should just go in.
And the sizes are not in numbers. It's like small, medium, large.
Medium, extra large, and large. Yeah. So once you find the size, that's a bit of a tricky part. The only part is that's the tricky part. Then after that, you take 3 sutures in the nadir of the 3 commissure, of the three cusps. And if it's a bicuspid, then you take the first one under the left coronary and another 2 at 120 degrees away.
Okay.
So you have 360 degrees covered. You take the 3 guiding sutures, put it through the eyelet of the leaflet of the valve prosthesis, and slide it down. And when you slide it, you can position it like that. But what I do, this is not officially documented by the company. What I suggest is you use a snugger at that point.
Okay.
You just put a snugger, put one down, snug it, put the other down, snug it, so you get the position right. So once your position is right, you're not dependent on the assistant or the proctor or anybody. You're on your own.
The valve.
Then you leave the valve. Then you release the valve. So because the snugger is in place, nothing happens. It is seated in the right place.
Okay.
I would say that's the way to do it. And then close the aorta. That's all.
And the valve is a tall valve. It's a high-profile valve.
Yeah, it's about 3 points. They're different sizes. I mean, the small one is approximately 29 millimeters, 22.9 centimeters, and the largest is 3.2 centimeters.
Okay. Because the regular valves, the surgically implantable valves, are moving on to making it shorter.
Yes.
Whereas here we have a tall valve. Now, if you're going to do a CABG combined with a perceived...
No, I would not call it a tall valve.
Okay.
It's the stent it's the surrounding stent which is tall. The leaflets themselves are actually very low. So doing a valve in valve, for instance, doing a valve in valve is very easy in this.
Very easy.
It's not a problem.
You have a framework there.
Yeah. Yes.
Now, if you're going to do a CABG combining with the perceivable valve, number one, A, your iototomy is quite high. B, you would not want to put a side biter on this patient. How do you manage the proximals if you want to combine a CABG with a perceivable?
Yeah, there are 2-3 ways to do that. Yeah. One is you do your top ends before. One is you do your top ends before and then open the aorta. So that's easy to do. And you put them a little higher because you have to keep the iototomy high. Yeah. So your top end has to be very high. So that's one way to do it. The second is if you made a distal your aortic cannulation can be very distal. You put it just below the innominate or even further in the arch. You put a straight cannula in the arch. Doesn't matter. You have enough space. And you can put your top ends later on with a side biter. But that's not possible.
That's not a problem. Now, does it have a high risk of heart block like a TAVI valve? Does this perceivable valve have a high risk of complete heart block like a like a TAVI valve?
Yeah, the original Percival which had come out had approximately 7 to 10% rate of PPI.
Okay.
Then they came up with the modification, the Percival Plus. In the Percival Plus, they've reduced the intra-annular component to below 6 millimeters. And now the incidence of heart block is down to 3%.
Okay.
Yeah, so that's very acceptable. And to be honest with you, I have not yet had a case. So it's pretty...
And when the valve was introduced initially, an Austrian surgeon, I'm not sure what his name was, he was the initial proctor who came and introduced the valve. He said that there were a couple of instances where the valve just embolized.
Yeah.
Have you seen that complication or the new addition, new modification of the valve? Have they reduced the incidence of embolization of the valve?
Yeah. Now there are two real problems which happened in this case. One case of embolization happens because you put either the wrong size.
Yeah.
If it's too big, surprisingly, the tendency for most surgeons is to put a big valve.
Bigger valve.
When you put a big valve in this, it sort of doesn't open in a circle, it crimples up into an oval. You can imagine it gets crimpled.
Okay.
When it gets crimpled, it's not held, it just becomes loose. So never put a too big a valve, that's point one. The second point important is that you have to look at the STA and the size of those two before in the CT scan.
Yeah.
It should be correct, your dimensions. And lastly, you must always keep your eye out for subvalvular, like LVOT obstruction, just below the annulus. Sometimes we overlook that they may be having hypertrophied septum.
Yeah.
And so that hypertrophied septum will help push the valve out. So again, CT scan preoperatively will tell you how the LVOT is. If your LVOT is okay,
so the CT scan analysis is just like a 3 menses for a TAVI.
Yes.
Is it
exactly the same? We use the same software, the same 3-mensure software.
Okay.
And you just get the analysis done. And they almost give you, the company who does it for us, they actually give you a photograph. You can actually see the valve in place and you will know for sure.
And what is the literature described evidence of paravalve leak? Because in a TAVI, you have the calcium holding on to the valve, but here you decalcified the valve, excise the whole thing.
Yeah.
And is it okay to implant this valve in AR with a dilated annulus?
No. I'll answer both questions.
Yeah.
The incidence of paraprosthetic leak is very, very low. Surprisingly, your paraprosthetic will happen when you put too big a valve. Like I said, it will crumple.
It crumbles, yeah.
So that is point one. Second one you said about...
is it ideal for a regurgitation valve? Where
no. Yeah. Ideally, it is not meant and recommended for aortic regurgitation. It's not recommended. But there are series where they have used it in aortic regurgitation, but with the caveat, the root has to be normal size and the patient should not have a collagen vascular disorder.
Okay.
Because the root will subsequently enlarge and then you will have a migration.
So essentially it's like a surgical TAVI.
Yes.
You sort of excise, but the rules you say, the indications, contraindications, everything looks like a
TAVI.
Surgical TAVI.
The advantage for you is you have taken out the muck, the calcium, which actually, you have to imagine, let me put it in a different way for the audience. In a normal, your car tire has 3 atmospheres pressure. Have you ever kicked one and seen how it feels? It really hurts.
Yeah.
And a TAVI is 12 atmospheres you are distending. So what are you doing to the calcium? Where are you putting it?
Yeah.
Right? So your conduction bundle, you have a chance of annular rupture, you have all kinds of things can happen. Here you have taken out the calcium and just left the valve inside. So
what are the literature long-term results of?
I'm sorry,
what are the literature available long-term results of perceivable?
Excellent results, because even now 15-year follow-up has come and only a 0.5% per year structural degeneration has come at 15 years. So I would say that's excellent. And with the Notion trial, the latest showing that a normal surgical valve and TAVR is having this thing, our comparison of this valve vis-a-vis TAVI for low risk as well as for intermediate risk has shown superior results to TAVI.
Okay.
So so where are we? This is better than any surgical valve. It's better than any TAVI valve. So why are we not doing it? We should all be doing it.
And I think that you've answered the last question. TAVI is possible after a perceval, isn't it?
Yeah, it is.
It's possible.
TAVI is possible all the time. Yeah. It's very easy actually. Because your coronary distance, because of the round struts, is pushed, the coronary is pushed away. So you can never obstruct the coronary.
Now next we move on to selection of valves, mechanical and tissue. We'll get Dr. Manoj and Dr. Hiremath involved in this. What are the factors involved in your choice of valve? And what is your choice between bileaflet and, because throughout the world I think probably TTK Chitra is only available tilting disc valve, and we have to use that valve for economic reasons and scheme patients. What are your thoughts about how do you decide on choosing a valve, and what are your thoughts about bileaflet valve in a versus tilting disc in mitral and aortic position?
So should I take the questions or?
Yeah, please, yeah.
So I think I think I'll ask Dr. Hiremath also to take a few questions from here later. But my choice would be primarily age, the age factor. In an Indian setting, I would go a little lower when I'm choosing a tissue valve. I would go even down to around 50 because we have an option of a redo, and some of these biological valves are also lasting for a longer period of time with better technology. The factors also which influence my valve, especially for the tissue valve, are what are the long-term results of a particular, what are the track record. So if I'm using a biological valve, especially at the age of 50, I would like to, I've been using the Edwards, which is given, Perimount has been giving me very good results. The new Mitris Resilia is also good, but I don't know the long term. Of course, everybody claims. Trifecta was good, but then it's now off the market, off the shelf. And of course, now we have Daffodil also coming in. So we have a lot of range of valves which we can choose from. If the patient is obviously in the pregnancy age group, then there is a sort of, a requirement that we need to use a biological valve. But some of these patients who obviously can't afford it, we've had no problems using mechanical valves even during that age group. And we've been able to manage those.
The only issue with I don't think there are problems in suture management, but it puts a lot of stress on the gynecologist. And in periphery, getting a cardiologist actively involved in these patients. None of the cardiologists are very keen on actively getting involved in the care of these patients. So if they're in the periphery, it becomes very difficult to manage. In the cities, it's easy to manage patients on mechanical valve undergoing pregnancy, but in periphery, it becomes really difficult. Yep. And what do you think about the orientation of Dr. Hiremath, bileaflet valves? Mitral always it's anti-anatomical. Is there any concept you think about when you implant a bileaflet valve in the aortic position?
Aortic position, normally we keep it where the coronary ostia are there.
Okay.
The openings are there normally. And if it's a monoleaflet, it's towards the greater root of the greater curvature of the aorta. That's one.
Yeah. The original,
and choice of valves, orientation of tilting this valve in mitral position. Whenever we preserve the chordae, usually now of late all cases we preserve the chordae. So the greater orifice opens anteriorly.
Anteriorly, yeah. Because
and we don't preserve it.
There was an original literature paper for the Metronic Hall valve, which is a parallel tilting disc valve, where they proved with an MRI that if you have the greater orifice facing towards posteriorly, the performance and hemodynamics are better. But that may not be applicable in our situation where we have a lot of rheumatic patients with a bulky PML, isn't it?
And when we do a root enlargement procedures in aortic valve, we prefer a bileaflet valve because the valve seats at around 30 to 40 degrees at an angle.
Yeah.
So preferably I would use a bileaflet valve in aortic root enlargement procedures.
Yeah.
Of course, in other cases like whether ascending aorta replacement, doing Bentals and all, we can use both TTK or a bileaflet valve. And apart from this, the mitral annulus not allowing the 25, yes. After debridement, invariably at 25
we might end up in those situation. Yeah.
I think till date, I ended up putting only one case 23 valve. Otherwise, most of them 25 is minimum with seats in after debridement. I have not any root enlargements in mitral valve replacements. Maybe Dr. Prasanna or somebody can highlight.
How do you manage the situation where you've done everything, still you're not able to get a 25 size, at least a 25 size valve?
Yeah.
How do you manage
this? I usually there are two options. One is to place the thing with the posterior annulus along the LA, or put a cuff. I have many times sutured to the annulus. I have sutured a graft. I mean, it's not that we do that often. The other trick that I have done is actually incise into the aortomitral content up a bit, and take bites there. But trust me, this is not something which I have done often. I have done it once in a while when the gun is on your head. But the easiest for anybody is to take a piece of prosthetic graft and put a U-shaped sliver across and tilt it a bit.
Yeah. No.
That's easy.
Has anybody reversed an aortic valve and put it?
I was just about to come. I have no shame in telling me that once, not long back, just about 2 months back, we had a young lady, a 42-year-old lady, and the pathology was not rheumatic, surprisingly. She was rheumatoid arthritis positive. She was being treated for rheumatoid arthritis. On opening the valve, the AML was densely calcified with, like an aortic valve, how it extends into the ventricular septum, there was calcium. In spite of all these things, we couldn't do anything. So I reversed a 23 onyx and implanted. Surprisingly, the gradient was only 3.
Yeah. But the option for that, I always say, the other thing that I have done is done a top hat with a homograft.
Okay. Now, this has been always discussed, but let's just touch upon it. What do you think is the age limit for tissue valves in aortic and mitral positions? Dr. Hiremath?
Sir, as of now in our country, less than 50 is mechanical, 50 to 60 is patient's explanation and availability of the valve. Above 60, I straight away go for a bioprosthetic valve.
Dr.
Both for aortic movement.
Yes. Dr. Manoj?
I would go for 50.
Yeah. Like sometimes we find these ladies coming from remote villages whom you're not happy sending them away with anticoagulation, especially in the mitral portion. It's easier to manage anticoagulation in the aortic portion, even if they take unmonitored anticoagulation, as long as they're on an INR of 1.8 something, nothing happens. But mitral difficult. Would you choose a 40-year-old lady or a 45-year-old lady going back to a remote place where you have no control on INR management? Would you implant a tissue valve so that she can come back 10, 12 years later for at least she's alive for the next 10 years?
Yeah, if they are very clear that they are unable to take the tablets or unable to do a test 3 weeks, yes, I would straight away go for a bioprosthetic valve. Make an attempt to repair the valve. If that fails, then definitely may go for bioprosthetic.
Most of them may have rheumatic calcified valves, may not be. And I think we'll not touch too much on root widening because we've had extensive discussions on that. And what is the role of cost? And will you think about what to do now because this market is putting pressure on TAVI later? Will that be in your back of your mind when you select a valve?
Yeah, definitely role of cost definitely makes a important criteria in decision making. And as of now, the Make in India valve which I have been using, apart from that, other valves can be used. It's not that based on the patient's affordability. And of all the bioprosthetic valves, yes, they are TAVI compatible as of now.
Even in 19 valve, they're comfortable enough in implanting a 23 size TAVI valve. Dr. Deva, what do you think is the role of homograft in modern era?
Endarterectomy. That is the only place we can use homographs.
Yeah, otherwise there is not much of role. Do you still do a lot of Ross procedures?
Ross procedure we do in younger children.
Younger children. Okay.
Not in adults.
And Dr. Prasanna Simha got to add on both Ross and Ozaki.
Yeah, one of the places where I still put a homograft is an elderly person with a small aortic annulus where you don't want to do a root enlargement. Yeah. A homograft gives a very good this thing. That's an occasional
it gives good gradient, but once again the surgery becomes longer. Instead of that, we can easily do
if you have been doing it, it doesn't make a much. I'm talking about inclusion route, don't do a full root.
I've seen quite aortic homograft explantation. It's extremely difficult. And getting those coronary buttons back is extremely difficult.
As far as the Ross goes, I do it selectively. Okay. And Ozaki, actually, I have increased my volume significantly. The elderly ones, it's an excellent option because we have our 250 case 7.5 year data. We have not had degeneration in the elderly persons. Elderly
means what is the age cutoff?
Above 50, we have not had any patient degenerating. And in young people, I was just telling yesterday, we are electively widening the root to delay this thing. The problem is endocarditis. We have to be very careful about that.
Now, when you widen the root, how do you plan? Because the whole concept of Ozaki is to have those commissures there. Yeah. When you widen the root, how do you plan these commissures? Yeah, because 2 commissures are already there. The third one, how do you plan it there?
It is just like how you do in a bicuspid aortic valve. You create 3 neo commissures. Usually when I widen the root, I put the widened part of the root on either side. I mark that as 2 commissures, and the opposite side goes to the third one is the third created neo commissure. So it works that way.
Yeah. And do you think in a 50-year-old patient we should do Ozaki because there are good bioprosthetic valves, and once again TAVI is not possible in Ozaki later?
See, if for a 50-year-old person, I am still going ahead and doing this thing because we have seen 7.5 years data seems to be good for so far. I'll have to give you the longer data about that. As far as not being able to do a TAVI, it's still possible if you do a bacillus this thing. And actually what I have seen, that's a theoretical consideration, is actually when the Ozaki has failed, we've actually seen the leaflet retract down. Okay. So I don't think, and actually we have had 3 cases where we have ballooned the Ozaki and extended.
Because Ozaki degenerates by calcification.
Yes.
Yeah, but will they able to tear the valve when they do a TAVI?
Actually, I've seen it going down.
Yeah, okay.
It is not, the concern was that the leaflet point is high. But in the ones which I have read on, I've actually seen a retraction also occurring. So it's a theoretical construct. I don't know whether it will be.
Now, just a few questions to Dr. Hiremath and Dr. Manugian. How do you take up a new product? when somebody approaches you, what are the questions you ask like a new valve or a new ring or a new bioprosthesis comes? What is there in your mind?
Yes,
when the person
definitely.
meets you, how do you take it up?
One is the make and all we look into, and the follow-up we see, whether it has been done, the studies, reports and all we look into. But Make in India valve was international product. Anywhere, somewhere one has to start. So I was involved in the clinical trial, but if you are Make in India versus international product, it's a difficult question to answer, for especially a person like me, wherein you have only available totally as a institute provides totally free of cost. So invariably we see which is easily available and affordable, that we look into. And when the industry person approaches definitely with the new processes, we look into the retrospective aspects, whether it has been used before or no. One, if it is for the first time, then definitely we'll ask for the clinical report, and we look into experiences who have used with people, we discuss with them and see what are the practical challenges, the follow-up period and all. Then only we can think of using it.
Dr. Manoj, the Make in India and international are two extremes. Because Make in India, we are trying to cut cost and use a much economic product. Whereas the international product, when they push it to you, it's the high-end product, upmarket product where they're quoting in lakhs. So how does it
the same thing happened. Same thing happened with the Chitra valve.
Yeah.
It was just 5 years, 6 years. It was just into wilderness. But now it's a fantastic product because the track record is good. Whatever, I think with the present government or whatever, our concept of Make in India has changed. It is an international product when we make it in India. It's not necessary that we should consider it as an inferior product. I mean, all of us then will become very inferior. So I feel the production line is good. The only thing is when you're talking about a foreign or imported valve, yes, that way we can look at their track record as well as whatever the clinical trials have been done in both and compare it with head to head. It should not be Indian or overseas, and an Indian product should not carry a label that it's inferior than a overseas product in this day and age.
I didn't use the word inferior. I said
no, I'm sorry.
Can I make one comment on that?
Please.
The teaching institutes have to be the place where these things are put under trial, under inspection. When we are having, like for example, many of the Indian products, we actually try to encourage people to do it, because unless we as our academic institutions, if they don't do the study and give the results for others to use, then we are nowhere. So we have to do it.
Yeah, like the Chitra valve came out.
Yeah, the Chitra valve. Like that,
Yeah.
so many products are coming to us for testing. I don't say no. I just look at the feasibility, but it's our duty. Our academia has to provide the data for the rest of the cardiac surgeons to use.
Exactly.
Dr. Anbar, so just one simple thing before you go to the repair. Any experience with the polymer valve which is coming out? Any breakout research? Not yet?
No, polymer
because
valve-
that's going to change the game.
No,
or people are doing the
issues.
trials.
There are issues.
Oh, there are issues. Okay.
There are issues.
Personally, I don't think that's going to change the
No,
game.
there are issues. I can just say that.
Because even the initial polymer valves which came out in 70s failed very fast.
Yes, there are issues.
Biomaterial may improve because science has got so much to give us. We'll just close the session very soon with the mitral and tricuspid. And which valve will you never repair?
The valve which I won't repair is the calcified valve, especially with the AML and the commissure.
Yeah.
Then we have described what is called the infra-PML triangle, which is the triangle between the PML, the posterior LV wall and the chordae. If that is less than 0.5, I would not recommend a person who is beginning repair to definitely do that. That's the one you shouldn't do.
Dr. Deva, on the rest of the questions of what is your opinion on option? Do you do a bileaflet valve repair? Do you think it doesn't last? Will you just replace the bileaflet prolapse?
You should make an attempt to do a bilateral prolapse. First you tackle the posterior leaflet, then you compare. Most often posterior leaflet I manage with resection, and anterior leaflet will require chordae. Adjusting the chordae, you will have to get a perfect on the posterior leaflet repair first done, so that you can adjust the height of the chordae. If in case it fails, usually these bilateral prolapse have a huge orifice. Alfieri is not a bad option.
I think in centers which are consistently doing valve repairs, bileaflet grafts is not a question.
It's not a question. Yeah, that's true.
As a non-repairable this thing. They give a very good result.
I'm sure most of us repair most of the degenerative valves.
Yeah.
But what percentage of rheumatic valves do you repair, Dr. Prasanna?
I said if the infra-PML triangle is above 1.5 centimeters, our data shows that we have had a 98% repair rate. If this thing is below 0.5%, then the repair rate drops down to around 60%. And in between is
so still rheumatic 60% of the valves are repaired.
If the area is more than 1.5 non-calcified valve, that 98% is our repair.
The rheumatics. Yeah.
In rheumatic. If it is less than 0.5 and less, it drops down to 60%.
Okay.
There are not. That's the area which I don't recommend a beginner to even try.
As far as rings are concerned, we have an armamentarium of rings. There are at least about 8 to 10 rings to choose upon. How do you decide which ring to use for which patient?
Rheumatic repairs, rigid ring. Ischemic MR, rigid ring. For myxomatous, use anything on earth.
Anything. Do you think different brands of rings makes a difference in your outcome, or do you think everything is the same?
Not really.
Okay.
Not really.
I definitely agree with you. Now, Dr. Deva, what is your choice of CAMR? Moderate or severe? Do you repair or just replace the chronic ischemic?
Severe, you have to. There is no problem at all. Either you repair or replace. In fact, the replacement with caudal preservation shows better results. Moderate, you'll have to take a decision.
Moderate, do you with the recent guidelines, do you still address a moderate MR or just leave it out?
I'd like to tell one point here. The repair for a ischemic MR is not an annular solution, but you have to combine with a subvalvular work. If you are not doing the subvalvular work, then moderate MR, just leave it alone. But if you are going to do subvalvular work, then do it. And the important thing is that the evaluation of a ischemic MR is not, the echo criteria are not the same. A moderate MR with the classical listing is equal to a severe MR as far as ischemic MR is concerned.
Yesterday Dr. Lalit gave a very good talk on CAMR.
Yeah.
Now this is the last part of the session on tricuspid. What do you think is the role of DeVega in modern era? Do you think DeVega still has got a role?
I do it only in the place where it's not required, that is in CTPH.
Sorry?
I do it in I use a DeVega today only in the only place where it is not required, and that is in CTPH.
Okay.
Otherwise, I don't use DeVega at all.
Dr. Deva?
If it is moderate TR, then we do a modified DeVega with 2 switches coming in the middle. If it is severe, ring.
And what sort of ring do you use in the tricuspid, and how do you size the tricuspid ring?
Tricuspid, the main difference between the mitral and tricuspid, you will have to combine the anterior and the posterior leaflet together and approximate surface area of anterior and the posterior combined, then you size the ring. So ring sizer is meant for both anterior leaflet and the posterior leaflet put together. Ring choice, I don't think there's much difference between, the results are very good.
Yesterday we were having a discussion like all males will have a 30 size ring and all females will have a 28 size ring unless otherwise BSA is, would you go by that choice? Or?
No, I go by 26.
26?
26 is enough because even Aniliche and both of us have been following the same thing. 26 is enough. That's actually the normal size and you are just fixing it in a bigger size than normal. And another thing that is that I don't use it instead of a DeVega. What I do is I use a K stitch, and what is his name? Lawrence Cohn had shown that using a K for moderate moderate TR is okay, but for severe TR I will put a ring.
The last question to Dr. Deva is: what is your choice of valve if you're going to replace a tricuspid valve?
Probably bioprocesses.
And what type of bioprocesses? Porcine or bovine?
Bovine pericardium.
Okay, bovine.
For me, I will put bioprosthetic, but more and more of these days I am doing autopericardial reconstruction of the tricuspid valve using the pericardium, patient's own pericardium.
Dr. Hiremath and Dr. Manoj, Dr. Lalit, you got anything to add? We'll add and then we'll close the session.
No, sir. I think it's more or less same. Yeah.
I mean, I think Van Fan, he had given a cutoff of around 30-34 mm for the annulus, for the tricuspid annulus. So anything less than that, 30, 32 or
21
28?
millimeters, indexed 21 or 40.
Yeah, I very religiously follow that 21 mm per meter squared. It is marked before surgery in our preoperative T. And in the transthoracic T, we measure it. And automatically, if there is no TR or mild or moderate TR, we put a K stitch. If it is severe TR, ring is placed.
Ring. Okay, sure.
It may be a ring which we manufacture in our hospital or a commercial ring, but we will put a ring.
Oh, you manufacture a ring in the...
Pardon me?
How do you do the ring? Custom
My ring which I use is made of neckline and steel wire, triple lumen and steel wire, and I've been using it for 30 years.
Okay.
And whenever we don't have the supply of the ring, I put that.
Okay, sure. Okay, then. Thank you very much. Thank you.
Ambarish, can I make a comment?
Yeah.
So you said if you cannot put a 25 mitral valve, what will you do? 23 mitral valves are available.
Is it?
Yeah, Chitra has 23 mitral valves.
Is 23.
Onyx has 23 mitral valves. And I think St. Jude has also 23 mitral valves.
I was not aware of it. And is it
No,
marketed again?
Yeah.
Sir, it's easily available.
23 Chitra is available.
23 Onyx is also
Onyx
available.
is available.
St. Jude is also
St. Jude
available.
is now not available.
No, maybe.
Not available.
So I actually put quite a lot of 23 valves. So
I thought 25 is the smallest.
No.
23 is available. And when you were talking, I was talking in a situation where even 23 would not go. I didn't realize you were talking 23.
Okay.
So can I ask one question to Dr. Lalit Kapoor?
Yeah.
Sir, Dr. Lalit Kapoor, sir. So TAVR explant is considered as one of the most disastrous operations. So what will happen to Percival when it degenerates? What is going to be, how easy it's going to be explanted?
Logically, it should be as difficult. One would think it's as difficult as a TAVR. I have not done one yet, but from the experience of other surgeons, it is not so difficult to do. The reason being two. One is a nitinol stent and it's covered with carbofilm. So because the stent is covered with carbofilm, it doesn't get fibrosed like a TAVI valve. The TAVI, the balloon expandable, is steel stent. So that gets completely incorporated and has to be explanted as almost like a Bendal. Here, you just have to, you can go inside and there's a technique described where you can just snug the stent from the top, then go sequentially snugging downwards. You put a snugger, and go down, and it just comes out like that. So that's been described, and there are reports on that. So they say it's possible to do with no explant. You don't have to sort of take out the root or cut the root.
This nitinol shrinks with
cold water. I've seen videos of that.
You put cold water and then you use a snugger. You use a snugger and keep snugging it downwards.
Okay.
There are videos on CTS net showing that being done for Percival.
The ASD device has, some patients have reported headaches.
Sorry?
The ASD because of nitinol.
Yeah.
So I was just asking Dr. Lalit Kapoor whether he's seen any of those.
But that, I think it's because of shower of small...
No. Nitinol allergy.
Okay.
Yeah, nitinol allergy is supposed to be it's an entity.
People have had after these.
Sure. The only problem, actually, one of the post-op complications, I would say, one of the post-op problems in a Percival is thrombocytopenia. So when you're seeing the patient post-op, first week you'll get a little bit of thrombocytopenia and we'll get worried. And it's known to happen, it takes a week and then resolves.
Incidentally, it happens in Ozaki also.
Okay.
Initially we used to panic, but then I started doing TEG for these patients and found that the values are normal. The platelet functionality of the TEG curve was normal. So now we don't panic as much as.
So got used up to that.
It just comes back in a week.
Comes back after a week.
Okay, sure. Thank you.
Please be seated. So now we have the quiz finals for the 4 teams who are selected from the preliminary round in the morning. So that will be a quiz on the stage. So I welcome the 4 teams to come to the stage. Team 1 is Dr. Tiwara Prasad and Dr. K. Prithvi from NIMS, Hyderabad. Team A. Team B, Parvati Yoganathan and Arun K. Philip from Trivandrum Medical College. Team C, Dr. Prithvi and Dr. Deepak from Sri Chitra Tirunal Institute, Trivandrum. And Team D is Dr. Yogendra and Dr. Swecha from Narayana Hridayalaya, Bangalore. I also introduced Dr. Paras Lalwani, our post-MCH SR, who will be maintaining the scoreboard in this quiz. And NIMS Hyderabad team, the Team A. Sit there, Team A. Team B is MCH Trivandrum. Team C from Chitra. Team D from NH Bangalore. Okay, this is the rule for the quiz. We have 4 rounds, 8 questions each. Round 1 will be on history of cardiac surgery. Round 2 on cardiac anatomy. Round 3 on investigations and imaging. And round 4 on surgical procedures. Each direct question carries 10 marks and carry forward question gets 5 marks. And not 10, 15 seconds to answer. We will give 15 seconds for each slide. After 15 seconds, it will be directly asked to one team. If they don't know, they can pass to the other team. If all 4 teams passes the question goes to the audience, and whoever in the audience tell the answer will get a dairy milk. So if there is tie between 2 teams, there is another tie-breaker quiz also. So are we ready? So let us go to the history of cardiac surgery. This is to Team 1 from NIMS, Hyderabad. So identify the surgeon. 15 seconds. Who said that a surgeon would attempt such an operation like cardiac suture should lose the respect of his colleagues, and he is rightly known as the father of modern abdominal surgery. Who is this surgeon? The direct question is to Team A. Team B?
Billroth.
Yes, Theodore Billroth is the correct answer, and Team B gets 5 points. Second question, direct to Team B. This is John Gibbon with a girl. So you identify the girl.
Pass.
Pass. Goes to Team C.
Pass.
Esperanza.
Who?
Esperanza.
No. Esperanza is the girl first ECMO. This is not the girl. So if you pass, this goes to the audience. Anybody in the audience? Oh, so okay, so Team A.
Is it Brownwald?
No, not Brownwald.
Cecily.
Yes, she is Cecilia Bavelock, the first ASD patient, and she is with John Gibbon with the first oxygenator he used for her ASD closure. So sir gets the dairy milk. Where is the dairy milk? So now this is for Team C. This is a very famous operating picture. Identify the operation. Very, very famous operating picture which mark a milestone in the history of cardiac surgery. Which is this operation procedure?
BT shunt.
Yes, first BT shunt. So Team C gets the 10 points. Okay, to Team D. I think everybody know this surgeon. He is Walter Lillehay. Now why does he sit like this? Why he has a crooked neck? Team D, it's a direct question to you. Why is his neck like this?
Pass.
To Team A.
He has lymphoma for which he had radiation therapy.
Sure, yes, correct. He has lymphosarcoma of parotid. Yeah, and he had a surgery followed by radiation therapy. So why is he? They get 5 points. Okay. And now again to, no sir, next is this. The next is which team for us? Team A. So this is Alexis Carroll, who got the Nobel Prize. You have to tell the name of the technique for which he got the Nobel Prize. It is a vascular anastomotic techniques. Yeah.
Carroll's stitch.
I didn't hear.
Carroll's technique.
No.
That's parachute technique.
No, no. Then it goes to team A, team B.
3-point technique?
There is a term. You are coming to that.
Triangular technique?
Yes, triangulation technique. Yeah, triangulation technique. Yeah, correct. Next is a direct question to team B. Yes. So you know the surgeon, he is René Favalaro, who popularized the subvenous vein graft in CABG. Now, how did he die?
Pass.
Team C?
He committed suicide?
Yes, he committed suicide. Because he had a foundation, he was in debt, he had to sell all the property. So out of desperate depression, he committed suicide. It's a very sad story. He shot out his left ventricle, I suppose. Okay, so next is to team C. Now this is the first transplant by Christian Bernard. You have the donor recipient. Now the question is which hospital? This is the donor and the recipient. So in which hospital was the first heart transplant done? Pass.
Pass.
Team D? Team D? Yes or pass? Pass. Team A?
Stanford.
Team B? Sir? Grootshire Hospital. Sir gets second dairy milk. Donor. She is the donor and he is the recipient. This is the last question in the history round. So who commented that Lillihe provided a can opener to the biggest picnic cardiac surgeons have ever known? It's a direct question to team D. Team D. Do you know the answer? Okay, team A. Team B.
Devaki.
Team C. Audience. Denton Cooley, yes. Sir gets the dairy milk. So here we come to the end of history. So Paras, can you tell me the score marks?
At the end of round 1, team A has 5 marks, team B has 10 marks, team C has 15 marks, and team D 0.
Audience get the maximum points. So now we go to anatomy again from team A. Okay. So which is station 7 in CA lung lymph node marking? Which is station 7 in CA lung lymph node mapping? Station 7.
Paratracheal.
No. Team B. Subcarinal, correct. They get 5 points. Second question directly to team B. You can identify the Arranches nodule. You need to tell what is the full name of Arranches.
Pass.
Team C?
Vesuvius.
What?
Vesuvius.
No. Team D?
Nodulus Arrantius.
And the name of the person, Arranches. Full name of the person, Arranches.
Pass.
Pass. Audience? I think Quizmaster will get the chocolate. Julius Caesar Arranches. Okay, so we go to third question. So, to team C, what is the name of the valve at the coronary sinus opening?
Sebastian.
Yes, Sebastian valve. Okay. Now, team D, what is this yellow marked portion called?
What is this?
The yellow mark portion, no? Question mark is there. The yellow mark portion. What is the specific name for that yellow marked portion? It is present on either lung, either side, yeah. I have marked the left side only.
Simpson's fascia. Apical.
You have to tell the name. Do you have any answer or we will pass to
Simpson's
teammate?
fascia.
Your time is up.
Simpson's fascia.
No. Team A?
Apical.
Team B?
Supraclavicular.
Team C?
Cervical pleura.
Yes, Kipula. Shaji sir. Okay, next to team C. Identify the condition. Team A. Okay, team A. 4 questions. Team A.
Parachute mitral valve, quadrate.
No. Team B.
Pass.
Team C.
TAPVC.
What?
Quadrate.
Team D.
Quadratum.
Yes, quadratum. Yeah, team D gets 5 points. Next is direct question to which team? Team B. Yeah, okay. So this is Ehlers-Danlos syndrome. Which is the chromosome affected? Team B.
7.
No. Team C.
What is the question?
Which is the chromosome affected? Ehlers-Danlos syndrome. Team C.
9.
No. Team D.
6.
No. Team A.
13.
No, it's 8P. Oh, sorry. Shah sir, ariyardo. Okay, next is a very, very easy question, I think. Next is to team C. Okay, which is the space?
Transverse.
Yes, transverse sinus. Okay. So now, which named convention of naming the coronaries in TGA? What is the name of this convention? Team D, it's a direct question to you. Okay, if you pass. Pass. Team A. Team A. Pass. Team B.
Pass.
Team C.
Leiden.
Yes, Leiden convention. Okay. So we are at the end of 2 rounds. Please tell the score points.
Second round, team A 0, team B 5.
No, total points.
Total points, team A 5, team B 15, team C 40, and team D 5.
Okay. So next is in a round of investigations. Team A, water lily sign is in a
Hydatid cyst.
Yes, correct. Hydatid cyst. Okay. Team A get 10 points. So team B, identify the lesion.
Popcorn lesion?
Yes. Which condition?
In benign condition.
It's a popcorn lesion. Popcorn calcification. Seen in which condition?
Benign lesion.
Should I give 5 marks? Okay, then 10 marks. Okay, it's hematoma. Okay. Team C, name the index. What is the name of this index used in pectus excavatum? Team C. Yes, Haller index, they said. So 10 points. Team D, name this test which is done to identify thoracic outlet syndrome. Name this test.
AdSense test.
What? Well, I didn't hear. What is that?
AdSense test.
No, pass. Team A.
Ruse test.
Yeah, partly correct. Actually, it's a modified ruse test. You see the hands opening and closing, it's a modified ruse test. Yes, of course. So 5 points. Now again to team A. So, where is this scene?
Schmitter syndrome.
Yes, in which condition?
TAPVC. PAPVC.
Okay, right. They get the 10 points. Okay. Then it's to team B. Fill in. What is that? What is that space?
Total capacity.
Your option is going, you don't jump on the answer. You see the question mark. Total lung capacity is already given there.
Functional residual volume.
Yes, functional residual.
Capacity.
Yes, capacity. Okay. So to team C, this is the coronary calcium scoring in CT. Now what is the name of the coronary calcium scoring? Agatston, correct. Agatston scoring. And now to team D. What are you seeing on the X-ray? What are those? What are those red things? Pass to team A. To team B.
Pass.
Team C. Team D. Team D has already passed to the audience. Artifact. Yes, not coils, actually endobronchial valves, like endobronchial valves used for emphysema treatment. So, okay, so we have finished 3 rounds. Now we have only the final round to go and 8 questions. So, maybe, okay, we will see at the end. Okay. So, the last round is surgical procedures to team A. So, this is PA banding. What is the named rule to calculate the tightness of PA band? Team A. What is the name of the rule we use to measure the length of this tape to tighten the band? Pass to team B.
Pass.
Team C?
Trussler.
Trussler's rule. Yeah, correct. 5 points to team C. Now, next direct question to team B. Identify this procedure. You have to give the correct name. Yes, as sir said. You have to give the correct name. Pass to team C.
Unidirectional gland.
What? You tell it loudly? Glension is not the answer.
Unidirectional.
Unidirectional gland.
Unidirectional glands.
Okay, the term is classical glension. It's a classical glension. Okay. So, say 5 points. Okay. Now, team C, direct question. Name this procedure. Time's up. Team D.
Subclavian transposition.
You have to tell the name.
Coarctation
Then only you'll get the points. Subclavian flap plasty, yes, I agree, but you have to give the name. Name of this subclavian flap plasty. Team the A, B, audience. 2, 3 chocolates. Share between Prasanna Sinha sir and Sri Krishna sir. Okay, so next is question to team D. Identify the procedure.
Lecomte
Yes? Times up passed to team A. Team B.
Pass.
Team C.
Heterotopic heart transplant.
Yes, heterotopic heart transplant. Team C gets 5 points. Okay, next direct question to team A. Identify the procedure. Team A.
Shoemaker's procedure.
Huh?
Shoemaker's procedure.
Shoemakers, no, not shoemakers. So you had the answer. Team B?
Pass.
Team C?
It's Hemifontan.
Hemifontan, correct. Hemifontan, yeah. Team C get 5 points. Now next is a question to team B. Identify the procedure.
Pass.
Pass. Team C?
Strands procedure.
Stance operation, yes, stance operation. So next is direct question to team C. So what is this modification to do a classical BT shunt on the same side of the arch? In order to avoid kinking at the base of subclavian, some classification was devised by which you can do the classical BT shunt even on the same side of the arch. Otherwise, usually classical BT shunt is done on the contralateral side. So what is this modification? Who proposed this? Pass. Team D? Team D? Pass. Team A? Pass. Team B?
Watterson?
No. Audience? Lax Castaneda modification. He said, Devaguru sir. So next is the last question of the quiz to team D. Identify the procedure. Okay, you want to answer? No. Pass to team A.
Alkapa.
Alkapa is not a procedure. Alkapa is a disease. You have to tell the procedure.
Tekushi technique.
Takeuchi technique. Okay, right. Takeuchi technique. So that marks the end of quiz. Now we will give 1 minute to Paras to calculate the score and have the final scores. So at the end of 4 rounds, we have team A with 30 points from NIMS Hyderabad. We have team B from Trivandrum Medical College with 35 points. We have team C from Chitra with 85 points. And team D from Narayana with 15 points. So the winner of today's quiz is team from Sri Chitra Tirunal Trivandrum with 85 points. And second prize goes to MCH Trivandrum with 35 points. Congratulations to the winners. Thank you. Prize will be given during the valedictory function and also to the consultant. Dr. Rajesh will also receive a prize during the valedictory function. Yeah, this is the team from Sri Chitra. They are the first and second is the team from Trivandrum Medical College. So the capital city gets both prizes. I am not from capital city.
My name is Dr. Prithvi Patel from third year Sri Chitra Tirunal Institute.
I am Dr. G. Deepak from Sri Chitra.
I'm from Trivandrum.
So we will be having our gala night dinner with fellowship at 7:30 in the Green Arch outside.